case of middle-aged lady who complains of watering from the right eye. And the patient has been operated in May for the same complaints. And so it's a revision DCR which we are going to do on the right side. Can we see the scan? Can we have a look at the scan?
Yes, sir.
So this is the bone window. This is the soft tissue window. If you look at it, can you focus here? You can see here that this is the nasal septum. I always said see the septum first. You see the septum is grossly deviated. You can see it's almost touching the lateral nasal wall. You can see again there is a gross deviation of the nasal septum. I don't know if there is a synechia, but there is definitely deviation of the septum. And on the right side, this is the right side. Maybe there's synechia, I'm not sure. So here there is also bony deviation as well as cartilaginous deviation. And then if you look at the area of the nasal lacrimal duct, the bone here, you see this bone is there intact, but this bone has been removed. So the bone removal and all has been done properly. I think the main problem is the septal deviation, synechia, maybe. And that's why there is a little addition, and then the patient has developed a recurrence. So what I have to do is now I have to do a septal correction, and then I will see what I can do for the area of the lacrimal sac. So what are the usual reasons for failure in a DCR? So these are the things we have to discuss now. The first reason for failure of DCR is inadequate bone removal. So if we don't remove bone properly, then there will be failure. That is the first reason. Second reason is you don't extend that bone removal till the level of the fundus. So you have to go till the level of the fundus, see the common canaliculus and remove it. Number three, there should not be raw bone exposed. You should always cover it with flaps. If you don't have proper flaps, then again there will be scar formation, and that will lead to closure of the sac. This is the third. Number fourth is like this septal deviation. Gross septal deviation, we should correct the septal deviation, then only do the DCR. Number five is, of course, inappropriate selection of patient. Because if you have a common canalicular block, then you will not have a good result with the DCR. So you should have a nasal lacrimal duct block. So these are the 5 reasons why DCR fails in individuals. But the commonest cause for failure I have seen in my practice is use of laser, use of diathermy. These are dangerous to use any hot instruments in DCR. Never use coblation or diathermy. Best would be cold steel instrument, and because the healing is the best with cold steel. So with that in mind, what we are going to do now is we are going to operate on this patient. So what is my plan? My plan would be, first I have not done a nasal endoscopy. So I'll see the nasal endoscope finding. I am expecting septal deviation. If that is a synechia, I will release the synechia and I will correct the septum. Then we will see how the bone has been removed. See, yesterday or 2 days back, I did a DCR. Same way. The patient has undergone mucormycosis surgery. Mucormycosis surgery. They have done a Denker surgery, and then we couldn't have landmarks at all because everything was like one plain sheet of this one. So how do you identify landmarks when you don't have maxillary sinus? There's no middle turbinate. There's no septum. Nothing is there. Just one big sheet of this one. Only fibrosis. So I'm going to give you a trick. The best is identify the Lyman nasi, and from the Lyman nasi, you identify the bone. And from there, like a lateral nasal wall flap, start raising the flap. And then you come down, and then you can raise the flap, and then identify the Usning process of maxilla. Just behind it will be the lacrimal bone. So this is how you have step-by-step approach for revision DCRs, which are very difficult. I don't think this is going to be difficult. It's going to be So what is the role of stent? So in revision DCRs, generally we place stents because stents are, they're good because it prevents that the ostium which you have created to stenose. So in almost all revision DCRs, we place stents. But if you are confident that you have created good mucosal flaps, then you don't need to place a stent. Let us see what is the scenario in this case, and we will plan accordingly. Do you have a stent, DCR stent? Yeah. So we will plan for a DCR stent.
Hello.
Any questions you have, you can ask me.
Do you tackle any the right frontal sinus disease is there in this case?
Yes. Yes. Frontal sinus disease is there in this case, bilateral. See, the frontal sinus here also is this one. But I think the patient, I don't know what is the complaint of the patient. Patient has headache. I don't know what is the complaint of the patient. So basically, we can do a frontal rhesus surgery also. But the thing is, I don't know what is the complaint of the patient. So if the complaint is headache, then I would do it, or else I wouldn't treat a scan. See, basically, one rule I want to tell you is that many people treat scans. We are not here to treat scans. We treat patients. And you can have some incidental sinusitis here and there, and you just don't go aggressively and operate on all these cases. If the patient
Right.
has complaints, you treat the patient, not the scan. So just because there's some mucosal thickening in the maxillary sinus, see, even the maxillary sinus is involved here. So I can't do a full house fest for this. It is not required. So we can treat it with douching. We don't know whether maximal medical therapy has been advised or not. So all this is very important. History, Lund-Mackay scoring, SNOT 22, all these are important before you go and operate and do a frontal. See, suppose, imagine this patient, I have not taken a history. Patient does not have headache. You just see the scan, there's a little frontal sinusitis. I create some CS of rhinorrhea, they can go to court. So these are all things which we should anticipate, and we are not going to do anything for the, we decide with respect to the patient's complaint. I hope I'm
Right,
clear.
sir. Right.
Any other doubts?
No, sir.
Dr. Sanjay Bhai.
He just gone out, Sanjay.
Okay. Have the participants come, or how is the hall?
The participants are there. All are in the hall.
Okay. Okay, we will, shall I wash up, Shilpi? Okay, I'm going to start now. Shall I wash up, sir?
Yes.
Yeah.
Should be. Point one over battery point.
Early.
रात को भूल गए लगा
Okay, so we are going to start the case now.
Yes, sir. Sir, all the DCR you do under general anesthesia?
No. We in our center we do under local. Of course, if it's a conference, we do under GA because the pre-medication, all the timing and all will be different. Give me a white balance karna. Now I'm doing a nasal endoscopy. See, I told you there's synechia. I told you, right? There's
Yes, sir.
synechia. So that is one important reason for failure. Suction, please.
Suction on.
See, post-operatively, we follow up these cases regularly. 3 days once we douche. Suction. Scissors. Irrigation.
Ready.
Irrigate, please. Yeah. Can you see the synechia, all of you?
Yes.
I'm not able to go inside.
Hello?
So first I will
Hello?
start with septal correction. Infiltration. So one thing I want to tell you in DCR is that
Excuse me, Janki.
yeah.
Our friend Dr. Deepak is here. I am giving mic to him.
Hello, K. Balachandar of ENT.
Good morning, Chief.
You are the chief. Hello, sir. How are you?
They said you're doing a revision DCR
Yeah.
and your septoplasties are always worth seeing. You have a special knife come elevator for that.
Yeah. So nice of you to have come. I was actually missing you yesterday.
Yes, sir. You know the reason anyway.
Yeah. I'm really
He's
sorry.
doing well.
And,
He's doing well. Yeah.
Yeah. But surprisingly, 3 days before, my father, the same problem. I was like, whether to come or not, like that. But somehow he recovered. So people are growing old. Infiltration. So what we do is we infiltrate saline only. Saline. We never infiltrate xylocaine adrenaline. The reason is because the nose is very vascular. And infiltration per se has got its own complications. Let us understand that so vascular area, you're going to infiltrate adrenaline. Imagine. And that is not a great idea to do. So we have stopped infiltration in most of our cases. Not most, all the cases of the of rhinology, we have stopped infiltration. In fact, I have heard of many casualties following infiltration. I don't know how Aguila Sami is doing under local anesthesia yet, but I am scared to do anything under local without an anesthetist, especially. And
Yeah, I think in today's era, Janki, if there's a tube in place and an IV line in place, the anesthetist or somebody can do anything if there is a problem.
Exactly.
And nowadays, with so much of fear and other things,
Yeah.
People can arrest even with a small injection prick.
Exactly.
So,
That's what I
yeah.
want to tell. See,
Yeah.
the most important thing, sir,
Yeah.
see, it is the airway. It is the
Yeah, yeah.
airway. We know ABC. ABC is airway.
Yes.
Then only next comes breathing, circulation, all this. But when we are playing with the airway, you cannot allow the patient to aspirate.
And even for anesthetist, even if he's on standby, once the arrest occurs, then to intubate and all is such a cumbersome
very,
thing.
very difficult. Very becomes
It is
big
better.
headache.
Yeah. So I've almost completely changed over to a tube in place, Janki, because I feel that is very safe.
I think always better to protect the airway. In fact, one thing I want to tell you is that some people operate on foreign bodies under IV sedation and all. Rhinolith, something like that under IV sedation.
It's very dangerous. Very dangerous.
I strongly recommend not to use IV sedation for nose cases. Don't use IV. Irrigate, please. Hey, Shilpi, आओ ना. छोड़ दो. So, don't use anything IV for nose if you suspect bleeding, because it will directly go into the airway. And that is a rule for all the youngsters. Same way when you are doing ear case, one thing you have to request your anesthetist is what? You should not give ketamine.
Yeah. In fact, Janki, ketamine is a very dreadful drug.
Yeah.
Somehow, I've had people, I've seen people having complications with ketamine.
Yes.
And I think it's not.
I request the juniors to note all these points, because the seniors, they will have a lot of experience.
No, but one of the most amazing things about your surgery, Janki, is the quickness with which you adapted to 3-hand technique. And then went on to 4-hand. You know, that this makes the work so fast.
Life so easy, huh?
Yeah.
See, Shilpi is irrigating, and I'm not fogging, and I'm not. See, it takes a matter of 2-3 minutes, and that's it, finished. The septum is over.
Yeah.
Give me a knife. So now, another important thing I want to convey for the sake of juniors, my dear juniors, you might be doing septal correction under headlight control. So please change that to endoscopic. So whatever case you get, even caudal deviations, so you try to do it endoscopic, because I always believe that the most difficult of nose surgeries is not even pituitary surgery, but doing a good septal correction under endoscope. And that too a gross deviation, if you do it under endoscope, believe me, you have mastered rhinology. Why? Because ultimately you are expected to take a good nasoseptal flap, that is a Haddad flap. And if you are not able to do a good septal correction, how will you take a good nasoseptal flap? So I think all of you should start practicing septal correction under endoscope. So this is something very, very, very important. And even gross deviation, there was a small discussion in some group regarding tears and all. So see, unless you practice this, you cannot take a good nasoseptal flap. Believe me, if you want to graduate, see, for example, Deepak Aldipur sir works with a fantastic neurosurgeon, I know. But the thing is, the neurosurgeon expects Dr. Deepak ji to take a good nasoseptal flap, because you're creating a big CSF rhinorrhea or whatever. So the thing is, the ENT surgeon should do a scissors. Am I right, Dr. Deepak ji?
Absolutely. And in terms of giving total justice, septoplasty is a very difficult operation.
Yeah. It's
As
actually,
as a first year PG, you feel it's the simplest operation.
yeah, exactly.
But
No, you would have taken residence. If I ask what have you done? Sir, septum and all I have done, sir. Septum is easy surgery, sir. So I will ask them how you did the septum. They'll say headlight. Headlight septum, I will not consider as septum at all.
Yeah.
Because to introduce this endoscope in a less than 4 millimeter space is not at all easy. You will have the Bernoulli holders. And you should have your techniques.
And only after the endoscopes came in, we could teach septoplasty properly to the residents.
Correct.
With headlight, we would stand behind Madhavaya sir struggling to see what he was seeing.
Exactly.
It's so difficult.
And that era is gone now. That's why I wrote recently all this SMR, septoplasty, behind the caudals line. This and all is pre-endoscopic era. Please understand. Now, after the endoscope, it is totally changed. Please understand, it's totally changed. And unless you are able to see that. Now, I'm not going to come out, see what my assistant did now. See, these are the things, these are the points which make a lot of difference. So, you can actually study the deviation. You can actually exactly go and target your approach towards the deviated part of the septum. You don't have to take that fully like the SMR. Only thing is elevation should be done both sides. That's the only difference. But we can perform a limited, directed, it's called a directed septal correction. See that? Now I have done it, but the synechia is preventing me. So what will I use to take off that synechia is the biggest question now. So hold this, scissors. Now I'm going to take off this superior part. Even the rhinoplasty surgeons, I think they should also, I always tell, my son got trained by Dr. Gaisas. So I told him, try to do it under endoscope.
In fact, our Dr. Vishwas, he does some steps in the rhinoplasty through endoscope.
Endoscope, see?
Yeah.
Now, I think, that's the way to go actually. Dr. Vishwas sir, fantastic surgeon. Actually, he called me yesterday.
Yeah.
And I will discuss with you.
Yeah.
Bada wala scissors though. So you see how you are able to see each and every part. How much you have left above. All that you can see so nicely.
Yeah.
Never use lux forceps. Some people just use lux. See the osteotomy I'm creating. See that. See all. It's so precise.
Yeah.
Unbelievably precise.
And you can err on the safer side by removing a small portion first. If required, you can remove a sliver more later.
Exactly.
Rather than remove a large piece and then regret.
Pack. Now I have done my septal correction, but the problem is the pulling force is the synechia. So how am I going to deal with that synechia?
Yeah, that would be that would be interesting.
Yeah. Now, see, I want to tell something about the synechia. In the post-operative period, in case of FES, we have synechia between the middle turbinate and the lateral wall.
Yeah.
So what we do, we just cut that synechia and leave it. See, I call what is called the Bernoulli phenomenon. I will tell maybe when I come there how to permanently avoid the synechia. So that I will give me a coblation. Now this anterior synechia, see that completely synechia. So now where should I put this coblation? Towards the septum, towards the lateral wall. So I prefer, even if there's a small tear towards the septum, I don't mind. Hey, the coblation foot switch. Here, here, blue.
Again, you're using evac.
70, yes.
Yeah.
See, I prefer using evac itself. I don't use precise max.
No, precise is not available also.
Is it?
The wands have become short supply.
Oh, is it?
And
people like
it's
you.
only no. We have also changed over to evac. After seeing you, we have changed to evac.
evac is good enough, sir. What is the problem? See, the charge only is higher for the precise max. I think it is higher charge.
The fellow who is playing around with PCOM, ACOM and all, if he is using evac for his angiofibroma.
See here. Now, see the synechia here between the inferior turbinate and the... Oh, this patient has got polyp also.
Yeah.
And see the scarring here which has taken place.
Yes.
At the site of the DCR. So,
yes.
Now, there was a question from the audience whether I will do FES along with DCR. This is something which is very, very tricky now. I think from the patient point of view, we should do a FES because patient has polyp. If the patient has sinusitis, it's okay. But see, I will tell you something. In corporate practice, I think Dr. Deepak ji will agree.
Yeah.
You cannot do any surgery without a consent.
No, but to be honest, Janki, where the indications are pakka, you still will never have problem. See, for example, here, it looks like, that way reasonably non-infective, good, simple polyp. Justified in doing a FES along with DCR.
Elevator. You would do it, is it? Without the consent?
Yeah, sometimes. I tell them, because we do record all the cases, I tell them this was there, so I did it in the same sitting and most of them are happy. Most of them are happy.
So, where is my Modalali? Modalali means owner. Where is the owner? I have to ask the owner. Where is the owner, please? Dubeji. Dubeji, what to do? Dubeji.
Dubeji will say, आपको जो ठीक लगे वो कर देना. मरीज को जो अच्छा रहे. Whatever you feel is good for the patient, you do it.
No, I have to formally ask him. First, I will do the DCR first.
Yeah.
Because anyway, I have to do the DCR.
Yeah.
Now, I am going to press the nasal lacrimal duct. Now, there is a lot of scarring. I can see that. Give me a knife. Give me a knife. No, scarring will not bleed, my dear friend. Don't infiltrate. Give me a knife. Give me 11. So, I'm going to start my DCR. There is scarring right high. I really don't know how the previous surgeon did a DCR with this amount of deviation. It's a great thing he has done. So, what now I'm going to do is, that's the middle turbinate. I will make that incision like this. I know scarring will not produce bleeding at all. So that's a middle turbinate. I'm going up. And then I'm going to make that incision. You know my technique. It's slightly different from the PJ technique. It's an inferiorly based flap. We have published that in the JLO. There's no bleeding at all, I told you. There will not be any bleeding. Elevator. Now give me the elevator. Now, where do I start? That is very important. Big boss.
That is more.
Patient has polyp, what to do? Shall I do DCR alone or polyp?
Why to wait for?
No.
See.
No.
No. This is ethmodal polyp. Consent, consent, ले लेंगे. Patient को बताना है ना.
Go as early as possible.
बता के. Patient has ethmoidal polyp. No. Oh, the sac has already been. See, one thing I want to tell, see, the sac has been opened already. One thing I want to tell is, see, whatever mucosa you have, don't take off that mucosa. This is a very important statement I make. Mucosa is like gold. Mucosa is like gold. So whatever mucosa you have, try to preserve that mucosa. Because mucosal flaps, they prevent scarring. So I'm preserving that mucosa now. So that's it. I have done it now. That is the inferiorly based flap. I think good amount of bone has been removed. Now, can you press? Okay. Now, give me a pack. Dr. Deepak ji.
Yes, boss.
For the sake of the juniors, you can keep talking and asking them and interacting. Only DCR. See, my boss, big boss has told, don't do anything for the polyp. Do only the DCR.
Acha.
No, I mean, means the patient has told.
Yes.
See, consent sometimes can be tricky.
Yeah. No, I totally agree with you. No. Yeah, especially in corporate hospitals, consent in today's time is most important.
Yeah.
Sometimes you can even stall the surgery, go out, talk to the relatives, and even legally that is not still considered complete.
Yeah.
You're supposed to take it from the patient himself. But then I cannot lie to you. 33 years I have never done that. If I felt something is right, I've done it. Somehow so far, so good. That doesn't mean that I shouldn't get into trouble tomorrow.
Yeah.
As in North, we say Ram Bharose. I've done sometimes. If I felt it is good, not going to harm the patient. I've done it, but I won't advise, as you correctly said, for the younger colleagues and in Satya Sira and all, better I think they go for a proper consent. And
one thing I want to tell you is, if you go abroad,
yeah.
Even if they have to do one extra procedure, even MMA or something like that.
Yes.
The consent is not proper, they wouldn't touch it, because tomorrow,
yes,
the patient can actually ask you, why you cut my turbinate?
Yeah.
Here we cut the middle turbinate, do whatever we want, but there you can't do all that.
I clearly remember in one workshop in Hyderabad, Piezo Vermold, he was asked to demonstrate the debrider turbinectomy or whatever. He said, tomorrow we will show. And the next day there were 5 cases of FES. But he said none of them required an inferior turbinectomy, so he didn't show. We thought, one of them he will show anyway. So they are very particular about these things.
I think consent is like,
Yeah, no, I think what you said is correct. Very valid point. Yeah, I was just telling Dr. Sanjay that the upper synechia should go, and you are precisely doing that.
Yeah.
Because the game of DCR is all about the top half more than the bottom half. Yeah. Most of the beginners work on the NLD rather than the fundus of the sac.
Exactly. See how much that septal correction has given us.
Yeah.
See the space. I think exposure. You will all agree that
Yes,
the
yes, yes.
single most
Absolutely.
important thing in
Absolutely.
surgery is exposure.
Yes.
Okay, now I'm very happy. Give me a gauze. Now I'm ready. I'm ready.
Yeah, and I think now the exposure is good.
Flex sleep. Flex sleep. Sorry, Dr. Dubeji. I have to take a little more time. Usually DCR doesn't take much time, but here, because
No, please take your time, Janki, because these are the cases which we are going to get regularly.
hereafter.
Yeah.
Hereafter, it's the era of revisions.
Yes.
So initially there was the era of virginity.
Yes.
Now nobody is going to come to you, at least in a tertiary care center, without a revision. At least one time revision you will get hereafter.
Yeah.
Am I right, sir?
Yeah. And as a surgeon keeps doing more cases,
yes,
he will have to handle his own revisions as well.
His own revisions, correct.
Yeah,
correct.
yeah, absolutely.
That's what I'm telling. So that is a flap. Now what I'm going to do is slightly modify my
Can you again palpate this thing externally once, Janki?
Yeah, that's what I'm doing.
For us to just see the...
Palpate. See.
Okay.
That has already been opened.
Yeah.
So, give me a Blackesley. Now, what I will do now is give me a elevator again. I'm going to take off a little bit of this mucosa. Which is above the middle, that's the middle turbinate, above the middle turbinate. And I'm going to get that bone above. See the bone above now. I got the bone here.
Yeah, that's the key. Getting the bone. Yeah.
So you search for one landmark. Very, very important, my dear friends. So if you're not having anatomy, search for some place to catch on. It's like if you're drowning, catch hold of whatever catamaran or some leaf or wood or something. So like that, the best landmarks, standard landmarks are bones. So in some areas you will not take the bone out. So the higher part, the highest part, the bone would not have been removed. So I'm trying to get that bone. So now I'm going to show you what I've got. See the bone there. See the bone here.
Yes.
Now give me the this one. See, I'm going to show you that bone where I've got the bone now. See, this is the area I've got the bone. This one.
Yes.
Now, where is the middle turbinate? That is the bone here. See the bone? See the bone there. Now, adequate bone removal has been done. I don't know why the patient has had a recurrence. I don't know. So that is the bone. I'm getting the bone now. Can you see the bone here? The whole edge of the bone?
Yeah.
Yes or no?
Yes, very much. Very clear.
Now I will remove this through biting or anything else. So I'm not, see, I can easily coblate or do something and remove. I'm not using any heat instrument. The reason is it will lead to scarring.
Yes.
So don't use cold laser, nothing. See, DCR is all about cold steel. Now what I will do you have a stent, this one?
DCR stent.
Not DCR stent, this one, the cannula. Put the cannula from outside. Probe. You have it? Get me the probe. प्रोब है क्या? एक मिनट पहले प्रोब डालेंगे. शिल्पी, ready? Palpate. See, see. Already I've got that bubble. See that?
Yeah.
Yeah, already I've got, but
There's a small opening there.
Small opening. Give me a pack. No. You cannot. You have to probe. First, you get the probe. I want to get the probe. I have to open it very wide. You just can't put again a pinhole and come out. It'll fail.
And this is another salient feature of your technique. I find that you mop a lot more than doing suction.
Yeah. Never use suction. Again and again. From yesterday, we have been telling the same thing.
Yeah.
Probe है जो भी तो छोटा सा प्रोब है तो वो साइलेंडोस्कोपी का होगा ना? नहीं. हाँ. नहीं. Sorry. I need a probe. I'm going to wait for some time to get the probe. Now let me check the cannula, the canaliculus, punctum. That's a punctum. Okay. Press, my dear friend. Yeah, nicely opened. Yeah, no. Can you cannulate it? हाँ. नहीं, छोटा. हाँ, वही. Now, my sweet friend is searching for the lower punctum.
Yeah, sometimes you'll have to dilate here and then probe.
He is better than a doctor, boss. What's your good name, my dear friend? Dharmendra. शोले का धर्मेंद्र जैसा हो तू. अरे यार, आसानी से चला गया अंदर. अरे बढ़िया. Okay, अब नीचे लाओ. हाँ, okay. See that?
Yeah.
So this is actually a very nice. Usually we don't do that in a primary case, but for a revision case, always better. Hold it like this. Now give me a sickle knife. Sickle knife है क्या? See, I'm going to enlarge that opening now.
And जैसे उसने किया approach से थोड़ा डिफेक्शन भी हो जाता है. Yeah. उसका जानकी.
Can you bring it down? Yeah.
In fact, 12 blade use किया तो it is nowadays.
Bring it up.
Sharp भी रहता है ना.
Now, can you give me a backbiter? Now, I am trying to see, there is no point in creating flaps here. I am trying to backbite and widen the orifice of the sac. For that, what should I do? I have to remove the medial wall of the press, Shilpi, press karo. All fibrosis. Press karo, bhai. Give me a Blexley. So that's the lateral wall of the sac, very clearly seen. That is normal. See, it has not been injured. So you should always look for the lateral wall of the sac and don't injure the lateral wall of the sac. Okay, that is fine. Now, give me a sickle knife again. I'm going to remove that keratome. So I'm creating a posterior flap here. Okay, give me a pack. Give me a pack. Blacksley. So I think this is straightforward. Now it's so easy. We have created a big. So now analyzing why it has failed. Good bone removal, but failure I think is because of the synechia. So exactly.
I think primarily the septum should have been addressed then itself.
Exactly.
So sometimes what happens, we feel we can manage in that space.
Yeah, because exactly. But when we operate, we see somehow we go and see the bone has been removed adequately.
Yeah.
That means they have been able to see it nicely through biting.
But the opposite side of the instrument keeps traumatizing the deviated area.
Correct.
And that mucosa becomes raw and the synechia spoil the whole show. It's almost similar to doing a good fess, but in the end, if the middle turbinate gets lateralized,
exactly.
The whole work is, something similar to that.
Exactly. I agree. Now, I have to now make sure whether I am seeing is that the, just 1 second, take it out, Shruti. Take it out fully. Now, is that the lateral wall of the sac or is it still the medial wall of the sac? Because, hold this like this. Now, what I'm going to do is, see, if that is going to be the lateral medial wall of the sac, then again I'm into trouble. So you have to make sure that is not the medial wall of the sac. So what do? Take the ball probe. Yeah. So I want to check whether this has a lumen at all. So that is where my probe came out. Okay, this is definitely the lateral wall of the sac. Now what I will do is I will go here and remove this bone, extra bone. Okay. You have a drill? Give me the DCR drill. Okay, that's the lumen. If I remove this part, then I'm done. Give me a through biting. So, see, one thing in a revision, you see that you have to give a success. You cannot give any sort of failure. For that, you have to go to any extent to keep pressing the...
Yeah, I totally agree with you, Janki. I mean, I have tremendous respect for a patient who comes to the theater the second time. For the same problem, you have to revere it, value it, and try to do your best.
So, already he has...
See, it's easy to sit on this side. How many doctors, when their patients themselves will come for a revision?
Exactly.
Isn't it?
So that's a DCR drill.
Yeah, that's a good instrument, Janki.
Yeah, it's a beautiful instrument. Give me a pack again. Now I have taken off the virgin bone, which has not been removed, so that I will get more exposure of the sac. Give me a pack. Not bada nahi, chota dono. Now I'm going to pack it. Now let me check where is the medial wall, lateral wall, because that's virgin bone which I drilled, which was not drilled before. So I can get an idea of what is really happening. Okay. Now I will just try to press this downwards. That's adrenaline soaked gauze piece. Now press the sac. Now see what is happening now. I'm getting more exposure of the Sac. Give me
Yes,
the
yes.
ball probe
Yes.
now. Ball probe now, please. Ball probe. So that is beautifully seen now. That is the lumen of the sac.
Yes.
Now, you see, I will do one small maneuver where you will see the lumen. I'm going to show you that maneuver. You see, everybody should know this maneuver. This is called pinching out maneuver. Of course, not published, but my own. See here. Now, you see here, this is a one. See, usually we press, right? Like this. So, if you do like
Yes.
this, that is, pull it out, then you will see the lumen. So, this is called pinching out maneuver.
Pinching out.
So, there you wait, I will show you now. You press Shilpi first. Now, she's pressing now. Now, pinch out. Pinch out. See the lumen.
Yes, yes.
You see very clearly. See the lumen. So, in a virgin case, no, you will see that beautifully. You will see the common canalicus, everything. So, this is actually a very beautiful maneuver. I need a little, I want to remove this part. Kasam scissors hai kya? Kasam scissors.
Can come with Kerrison punch also, Jan.
No, I have done the bone removal. I just need to remove the.
No, this medial wall, you can remove it with punch also.
Yeah, correct. Now I'm using the Kasam scissors. Okay. Now give me a small patty. Yeah, thank you. So again and again I say, my dear juniors, don't suck, don't suck, don't suck. Mop. People have a little habit of being a little lazy during surgery. They don't want to pack and wait. They just want to suck and clear the blood. Sucking only will increase the blood. It will not decrease the blood. Suck over the gauze. So this, and you can irrigate also. Okay, now where is the stent? You have the DCR stent? है क्या? Stent है क्या? Stent दो भाई, एक stent दो. So I always told you that I always stent in a revision DCR. This is a rule because stent will be placed for 3 months and you will have a nice cannula there. You will have a.
Yeah. Even in cases of diode laser failures, some ophthalmologists use diode laser and try to do a DCR. I always stent, Janki, because they would have.
Stenting is very, very essential for revision cases.
Yes.
Give me a ball probe. Do. So that's called pulling out maneuver. Pulling out maneuver will give you the medial wall and the lateral wall. So you see that? That's the medial wall. That's the lateral wall. Beautifully seen. I can take a little bit bone here. That's a fundus. I can even palpate the overhang. You can palpate the overhang of the bone. Like the mastoid, we palpate the overhang.
Yes.
So you can palpate. This is the overhang of the bone. Give me the.
Which will tell you how much more bone to remove above and anteriorly.
Remove. So that is all tricks, small tricks.
Yeah.
Don't injure this wall. If you injure this wall, 100% failure. So I have to remove a little bit more bone. Nice case, beautiful case for demonstration. Of course, I can use a punch like Sanjay Bhai told me. I can use a punch.
Yeah.
But there is a study by I think one of the Germans. Use of punch versus drill. They said that the punch was superior to the drill. The reason is the reason was drill produces heat.
Okay.
It leads to fibrosis. So that is his conclusion.
No, but you irrigate also, no, when you're drilling.
Irrigate, but then give me coblation. But somehow,
What
I don't
I've
know.
seen, Janki,
Ah,
when the bone is very, very thick, and if the ledge is a little shallow, the punches, it is difficult to engage.
correct,
So
correct. That is what.
probably, yeah, you can use the drill for the most part.
Exactly. And the punch finally.
Yeah, blue line it and then use the
Correct.
punch.
Give me again elevator. Sorry, this one. Ball probe. See, now I'm removing the bone higher up. See that? Now I'm doing a pinching out maneuver. See that? See that now? Kitna हमने open कर दिया. See, that is the maximum I can remove the bone. And this is the flap here, and I think this is, now you're going to irrigate now. Now give me a small pack. So we will irrigate and see if the flow is good. Now irrigate. Where is the insulin syringe? भैया रेडी है आप? जब रेडी हैं बताइए, मैं इसको लूंगा बाहर. जब रेडी हैं बताइए. रेडी है? एक मिनट. हाँ करिए. See, free flow. Can you see that?
Absolutely.
If I use methylene blue, then you will see better. But
No, this is very clear. We can see some bubbles as well. So
yeah,
this is good enough.
can you see?
Yes.
Yeah, very clear.
Free flow. Yeah, free flow. Now, can you give me the stent? So I am done with the DCR. Maybe I'll remove a little. If I have a good punch, I can remove that. That punch is not good, man. Not that punch. I mean the through biting. You have an upturned through biting or something, which. Okay, I will remove this because there is a little here. Okay. That is good. Now I'm happy.
Yeah, now it opened up much better. Yeah.
Okay, right. Now, can you give me the stent, please?
Stent.
Give me elevator. Elevator though, bhai. Nahin. Now give me the stent. Can you put the stent, my dear friend? See how he's putting the stent. Please, all of you see this. Very important.
The chances of restenosis because of the
okay, very easy.
Is quite
now I'll pull that.
Hello. Sir, there
yes,
is
my dear friend.
Sir, there is a quite a raw area all around. So, are we going to place some stand, some splint?
Yeah, we have
plastic.
to, boss. We have to. Again, yeah. Can you see that? I have got this out of the nose. Now we are placing the upper punctum. Dr. Dharmendra is fantastic. मैं क्या करूं? इसको दिखाना है ना?
The septal synechia formation can also take place again.
No. I'm going to place a stent, my dear friend.
Okay, sir.
I'll place a stent, boss, for the septum. You cannot leave it like this. Again, there will be synechia formation. You use coblation, no.
So what then you are going to do for that?
For which one?
For this synechia?
No, we'll place a stent.
Septal stent.
Septal stent?
Yeah.
Okay. Huh? Split, you mean?
Yes, splint.
Okay.
Nasal splint. आ गया.
Dr. Janki was.
So,
Yes, sir.
need some opinion about pediatric DCR. At what is the earliest age you advise, or what are the diagnostic tool for the kids? If suppose someone is
Okay.
coming with.
Very, very good question. Actually, what we do, is it ready? Can I? Yeah. Now you see what we have done. Now, see. Beautifully coming, huh? This is the stent. So the earliest age I have done a DCR is 6 years old. Before that, usually we do what is called nasolacrimal duct probing.
Yeah.
And probing itself cures it in newborn or even in, I have got opinions for, that's all. You should not do too tight. Okay, put the suture. कर दोगे scissors करके nasal splint है आपके पास nasal splint ये नहीं करना है एक मिनट okay, now I'm going to put that, wait no hold on. Earliest is it Dr. Rajiv Pachori who has
Yeah. Yes.
Earliest is 6 years. Before that we do nasolacrimal duct probing.
Yeah.
So if it recurs after probing, then we think about DCR. So my earliest age was 6. That's all. Okay, right. One more. Put one more note. Any other questions, my dear friends? What is the how do you diagnose?
Yes, in kids.
First we do give this one. Canal patency test. So first of all, you have to inject from the lower punctum and see whether there is regurgitation. That is the most important test, because that will tell you whether you have a ductal stenosis or a
Absent.
canalicular stenosis.
Yes.
So that is very, very important. So apart from that, we can do a DCG, dacrocystography.
Yes.
Some people do it, but I generally don't do.
So we do in all the cases of DCG in all the cases, in fact.
Or DCG you do in all cases. Okay. So that's it. Yeah. Thank you. DCG is a good investigation, but basically I do it with the nasal splint. Nasal splint. Now, can you see that very clearly now?
Yeah, very clearly.
Ointment, please. Ointment hai. So what I usually do is to keep ointment. So I do this chloromycin. This is lovely ointment, I'm telling you.
Rajiv.
Very nice case for demonstration. Thank you so much, Dr. Dubeji. No. There is no flap, no, so we can keep it now. If there's a flap, then we cannot keep. No. So you see the nasal splint here.
Yes.
So we keep the nasal splint to prevent synechia. At the same time, the patient also can breathe. See, through this. Okay, right?
Yes. Beautiful case.
So I'm placing the splint to prevent the synechia formation.
How long you keep this stent? You advise to keep
48 hours. And then douching is the treatment. You have to keep on douching. And regular follow-up of the patient. I advise the stent removal this one, no, the DCR stent
Yes.
to be removed after 2 months only.
Okay.
So it should be stented, or else the patient will go in for stenosis again. So DCR stent after 2 months and the septal stent for 48 hours. Any other doubts? Any questions? Any discussions? Deepak ji?
Thank you, Janki. Very good show.
Thank you, sir. All your blessings. I am sure that there's not much audience because it's too early. But it's okay. It was a very good case.
No,
Thank you,
show
sir. Finished. You can start.
you can
Yeah.
see in the hall. They are adequate.
All is full, like yesterday.
Now we are shifting to Dr. Jayakumar Garu.
Before we go for the next session, I would like Dr. Deepak to kindly honor our chairpersons, Dr. Amit Ganguly and Dr. Yashveer. Thank you, sir. Dr. Yashveer. Thank you, sir. Now the next session is Dr. Menon's case discussion. And for that, I invite Dr. Rajendra Bansal and Dr. Sudhir Kadam to kindly chair the session. Dr. Sudhir Kadam and Dr. Rajendra Bansal.
Whenever he speaks, a lot of efforts he has to put and break in voice.
How long? How long? 1 year only. Before that, he was okay, no? Before that, you were okay. No.
If there is any pubofonia, female-like voice in between? No. From my class? Like this.
Okay. And you are studying for what?
Yes.
You are studying, no?
Yes.
What?
I'm studying law at Shimla. Law. I'm at NLU Shimla.
Any problem with eating and drinking?
No, sir.
Nothing. No breathing difficulty?
No, sir.
You are not allergic to any medicine?
I had asthma. I have asthma, but it is of very linear stage, sir.
Are you using inhaler?
No, sir. Since second grade or first grade, I haven't used anything.
No.
20 years.
Good morning, all.
Good morning, sir.
Can you hear me? You can hear me?
Yeah, we can hear you, sir.
Okay. So we are starting the laryngology case discussion. Here is you're 18-year-old, is it?
20.
20-year-old young man, your name?
Akshat.
Akshat.
Yes.
Okay, okay. He's a law student.
Yes.
He's a law student and his complaints of voice problem for the past 1 year. Can you just tell briefly what is having?
Whenever
This voice like?
Whenever I speak, my voice breaks a lot, and I'm not able to talk to people normally. I have to put a lot of effort while talking to someone else.
Yes, yes, we can see.
Okay, and no change, say, depending upon the time, it is what's in the morning, what's in the evening, something like that. Nothing like that. He doesn't have a breathing difficulty. He doesn't have any swallowing issue. He doesn't have any other illness. Of course, there is a history that he had some asthma earlier, but he doesn't have, he's not on any medicine as of now. He's not allergic to any medicine, not a smoker, nothing like that. So we'll see. And he said that there is nothing, no complaint, something similar to puberphonia. Nobody mistakes him for a female voice or something like that. And in phone also it is same. No, right. Okay. So let me have a look at it. So first is you just look at the larynx. Looks fine. You can see that the thyroid is okay, cricoid is okay. I'm just palpating the greater corner for any tenderness. Absolutely nothing. They look soft. Thyroid interval is very soft. Cricothyroid interval is all right. Tongue. There is no tenderness at all. Okay, I will ask you now, do the maximum phonation duration. So what you need to do is that take a full breath and say E in your normal speaking voice for as long as you can. So I will just demonstrate. It is something like E, like that, how much you can go. Okay, please do that. He could go only 5 seconds. Do that again. Do that again. 6 seconds. It's not very high. We have to be suspicious. So let me see then. If I press right side of the L, say louder. Do it again. That is nothing. Again. No. Okay. Count 1 to 10. 1.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Okay. Okay. Let me have. I don't have anything to suggest as of now. Let me have a look at the vocal cord. I'm going to spray a little bit. For a minute, it will be a little bit stinging. After that, it will be everything will be okay. Don't worry. So just spraying 10% silocaine for the left side. Usually for the right-handed surgeon, left side is easier. That is why I always do it on that. That's okay. For a minute, it is a little bit stinging, but then it will be okay. Don't worry. You will be okay. I'm just saying, how is your vocal cord? What is wrong with that? Okay. So here I go. You gently breathe through your mouth. Okay. I am going through the nose. Breathe through your mouth. Now breathe through your nose. I think the finding is very obvious. There are two small swelling on the right side, both sides, slightly whitish on the right side. Now, vocal nodule in a young male is a very unlikely diagnosis unless he has got a very unusual habit. So that is a very suspicious thing for a 20-year-old man to have bilateral vocal nodule. So whenever you see bilateral vocal nodule in a young male, you should actually think of cystic change. So it is most likely a vocal cord cyst, that is his voice is so bad. You can see if I go very near, you can see actually they are cysts. Can you appreciate that? It's not a nodule, it's actually a cyst. Can you switch on to the NBA, please? 1 second. Don't worry. Nothing to, okay. Breathe through your nose. Yeah, it's almost typical of a cyst finding. You can see that whitish, and you see that left side is a very well formed cyst, and even on the right side you can see it is actually a small cyst. Now we will put the classical thing, stroboscopy. So strobe, go on to strobe, change to strobe. Put the microphone on his neck. Yeah. Now you keep on saying continuously E. E. If you look carefully, you will understand that mucosal wave is there, but that swelling as such doesn't have a mucosal wave. It is like the classical description will be you're putting something like a coconut in the water, and if the water is moving, the ripple will be there around the coconut, but the coconut won't have a ripple like that. Exactly. So you see that. Watch very carefully. The cyst is just moving with that. There is no mucosal wave going over it. Especially on the left side, you can see that cyst is simply moving. So it is a mucus retention cyst bilaterally. Probably it originated as a vocal nodule and then underwent a cystic change. That is why his voice is so bad. Nodule, so you can see that at first it may look like nodule, but it is actually a cyst. It is actually cyst, especially the left one. You can see the left is a very well developed cyst. While
yes,
on the right side also you can see a slightly yellowish tinge. That is a cyst wall. Okay. I will generally straight away go for surgery. I don't think voice therapy is going to work here. Once a cystic degeneration happens and his voice is bad, his MPD is 6. In a young lady of same age, maybe I would have thought that there is still vocal nodule content, the possibility is there. But in a young male to develop vocal nodule is extremely unlikely. So this is bilateral cyst, more pronounced on the left side, and the treatment should be actually surgery. So you've got 2 small swellings on the vocal cord. No cancer or anything, nothing to worry about. But unless they go out or unless we take it out, your voice will be always little bit strained. So you need an endoscopic surgery. It is done through the mouth, nothing on the neck or anything like that. You need to have 2 days absolute voice rest after the surgery. 2 weeks, you need to speak softly only. Other than that, you won't have any issue. Next day onwards, you can actually go to class even, but you are not supposed to talk. You can eat normally, all those things. So that's a bilateral vocal cord cyst, more on the left side. NBA and stroboscopy confirmed it. Anything else? Any point to be clarified?
So, what are the exactly cause of this thing? Because a vocal abuse or just incidental finding, or it's a vocal abuse, anything? Cause for this thing?
Vocal cord cyst remains an enigma. Because we know that there is actually no gland in the vocal cord proper as such. All the lubricating glands are in the ventricle and the vestibule. But still you get cyst. So there are different theories like, embryonic remnants going on. But one thing, like nodule and polyp, cysts also occur at the junction of anterior one-third and middle one-third, which is an area of maximum impact during phonation. So definitely phonotrauma has a role. So probably some kind of injury happens, a nodular change happens. Sometimes it is like an implantation dermoid. Epithelial is being driven inward and then develop a cyst. It is different from nodule, but obviously over voice abuse induced itself, because otherwise it should have come at other sides too. Almost the cyst always occur at the junction of anterior one-third and middle one-third.
Sir, what happens sometimes when we plan for surgery and we place our laryngoscope, these type of cysts get disappear?
Yeah, if they can easily break, that's a problem, because there are 3 types of cyst: the mucus retention cyst, the epidermoid cyst, and the pseudocyst. This is a mucus retention cyst. They have got really the relatively thin walled cyst. Dissection is not that easy. Pseudocyst doesn't have a wall at all, so it will immediately break. But epidermoid cyst is more yellowish, more laterally placed. They are actually, they're little more resistant to rupturing, so you can actually excise it. But even in the most experienced hand, some 40% of the cyst will break. Breaking the cyst is not the key, is not the issue. But what is important is that once a cyst breaks, you should take time, shouldn't do the suction immediately, then you will actually spoil the surgery, because you can't see the cyst wall at all. You try to retain the fluid as much as there, and try to find out the cyst wall and completely excise in total. Most of the time you can actually excise it if you are a little patient and take time.
Thank you, sir.
Sir, in this plan would be removal of left cyst alone? Right could be just...
No. We will do bilateral.
Okay.
Nothing. No, I don't understand why probably you asked. Yeah, maybe.
Sir,
because
right could it be right because of contact which has developed secondarily?
Yeah, but once a cystic change, what I will do, of course, the final decision is on the table. I will excise the left side, and on the right side, see if it is still a cyst, I will go and excise. Otherwise, it is just a thickening. I will just do a superior cordotomy and decompress it. Now, there is no harm in doing a bilateral nodule, or nowadays you don't do nodule. But bilateral surgery, the previous the concern was that if you do bilateral surgery, there is a chance of web forming. You can always prevent by first putting a small transverse incision at the anterior end of the cyst, so that whenever you catch and you dissect, it won't avulse the anterior commissure. If you avulse the anterior commissure, chance of web forming is there. So you can safely excise.
Okay, thank you, sir.
Shall I go to the next case?
Yes, sir.
Okay, please. I think I need your translation. So how old? Yeah. You please come.
He's hard of hearing.
He is hard of hearing. How old is he? He's 72-year-old gentleman. And what has happened to his eyes?
Black fungus. His eye is already removed, and in palate is already removed. So he has mainly difficulty in swallowing. That is the issue.
When was this orbital surgery was done? 2021. 2 years back, he had black fungus and he had operation and removal of the orbital content and palate.
Palate, yes.
Part of the palate. Okay, right. But still, then why that bandage?
Eye is removed.
But it's 2 years back.
Yeah. So why you are putting bandage? Hollow is there because they have not put any prosthesis.
It is not healed or anything.
Eye, it's healed.
It is healed.
Yes,
Okay.
yes.
He's a diabetic. He's not a diabetic. Hypertensive. Any other comorbidity like high sugar, cholesterol? Nothing. Thyroid? No. Asthma? No. He's not allergic to any medicine. Okay.
He's having glaucoma.
His own treatment for glaucoma.
Yes.
Okay, right. But his right eyesight is good enough. It is not good. Oh, he cannot. So that is a history. He has got a problem with the right eye too. Okay, I understand. So, but you came today to
Swallowing.
The swallowing.
Swallowing.
Right. But is he eating and drinking normally? He has got a peg. So he's taking nothing by mouth at all. Since how long? After this palatal removal. So whenever he takes the food, it actually comes through the nose. Okay. So he had a palate excision. I don't know how much we will see that. So, and then since then he is actually on a peg. He cannot really eat and drink. That is understandable because the palate plays a very major role. The only comorbidity is that he has hypertension, for which he is on treatment. Okay, that's the thing. His voice is all right. Voice is all right. Your speech is all right. Can you just tell me your name louder?
Govind Prasad Malvi.
Okay, how old are you?
72 years.
Yeah. Okay.
सालीवा है ना वो अंदर नहीं जाता.
Okay.
और जो फाइलेट हटा दो तो वो कहीं आवाज ठीक नहीं आती.
Okay.
और जो बाना वगैरह लिंक ले दे ना ऊपर से एक चम्मच ले दे ना वो नीचे डालने के बाद अटक जाती है, नीचे नहीं जाती.
It vomiting. When he attempts swallowing. But what is the striking quality of his voice? This is the typical hypernasal voice. You know that the palate is not functioning. I suppose you can appreciate that. Can you appreciate that? That voice?
Yes, sir. We can appreciate the nasality in voice.
Hypernasal voice. Then nasality is more because the palate is completely cut off. Now we will see what is the palate like. Can I have that scope? So before doing a nasal, the laryngoscopy, I will just have a look with my scope inside the mouth. Ask him to open. No, wait. Ask him to open the mouth. So he has got an obturator. Say his palate is not bad. Soft palate is not bad. It is only the hard palate. That shouldn't be a reason for swallowing problems. Open the mouth again. Open the mouth again. That looks reasonably good enough. I don't know why he should have a swallowing problem. We will see. Now, let me be ready with a little bit water.
Yeah. Yeah.
And if you can get a drop of methylene blue, is there?
Yeah.
So just put 1 drop of methylene blue in 1 ml water. So we'll see. This is a little bit surprising because I thought he had a soft palate removed. Soft palate is intact, looks reasonably good shape, but the hard palate is removed and he has got an obturator. Still, he has got a hypernasality and nasal regurgitation. So that suggests that probably the palatal process is not correct, or it is probably ill-fitting. It is not completely closing off. We will see what is happening. So before that, I will be ready with just a little bit of 1 or drop of two drop of methylene blue. Just 1 or so. I'm just going to. I think he may not be able to drink from. Can I have a small cup? Small paper cup may be easier for him to drink because he has to. Just small paper cup. No, put 2-3 drops. That is okay. So I'm just coloring in my water to be swallowed by him when I do the fees. Yeah. So this is just give me a small cup of, any small cup is fine. So what I'm doing is using a colored solution while giving the food. Yeah. And to see that. I'm now going to do it without spray because it is going to be the swallowing assessment. Can I have the jelly, please? Actually, among all the resection, hard palate is the easiest resection to rehabilitate in swallowing. So it is quite surprising with a hard palate resection alone, his swallowing got damaged. We will see what is wrong with that. Tell him that I am passing the scope through the nasal cavity and to see the throat. It won't hurt. It won't hurt. Don't worry. So, what does he tell? So obviously there is a very fairly big gap there because I can straight away see the ghost piece kept in the orbit. I am going along the floor. There is some distortion. Let me see. It's okay. I can. Yeah. Yeah, I have reached the soft palate now. Ask him to say ah. Ah. You can see the palate is closing. Do that again. Ah. 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 That is closing fairly well. There is nothing wrong with that soft palate. Close again. Ah. Ah. You can see that. Ah. Ah. Okay. Now I ask him to breathe through the through the. Papa, मुंह से साफ लीजिए. मुंह से साफ लीजिए. You can see the larynx looks reasonably in good shape because there is no, you can visualize the larynx straight away. So if there is a big swallowing problem, the whole area will be flooded with secretion. That is not there. So that is a good sign. That means his larynx is not in bad shape. You can see the movements of the vocal cord. There is some pooling in the left pyriform fossa. Vocal cords are moving normally. That is fine. Now ask him to swallow. Just no, without anything, just swallow saliva. No. Ask him just to try swallow. Swallow. He hasn't swallowed it. No, he's not, still not swallowing. So what I am looking for is the whiteout sign. For a split second, you won't be able to see the larynx. See if the larynx is moving up. But here, till now, he hasn't swallowed. I don't know why. We'll have to see. Ask him to swallow. He hasn't swallowed it at all. See, you see that this is the absent whiteout sign. Normally, when people swallow for a split second, you won't see the larynx at all. Now, we are continuously seeing it. So that suggests that there is no laryngeal elevation. That need to be investigated. Why his laryngeal elevation is gone. He's still not swallowing. You can see that you are continuously seeing the larynx. That's not a normal thing to happen. Okay, now keep a little bit of water in his mouth, that colored water, and ask him to swallow only when I tell. You can take it. Ask him to keep it in the mouth. Ask him, but don't swallow. Don't swallow. Keep it in the mouth. Keep it in the mouth. Yeah, you can see that now. Ask him to swallow. 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 There is something is coming. Okay, but it is not a complete thing. Swallow, swallow. Swallow. Swallow, swallow. Sorry. Don't worry. Swallow. Keep on swallowing. 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 Ask him to do a chin tuck. Dr. SP, can you ask him to do like this? Touch his chin, touch his chest with the chin. I'm doing a chin tuck so that whether I have to check whether the cricopharynx open up. It's not swallowing. Larynx is not elevating at all.
So was there a history of any neurological paralysis, which was usually there in few cases of Mucar?
I didn't get you. What did you ask?
Did the patient have history of any paralysis, sir?
Yeah, that is what I was also asking. There is no such history. Ask him to cough a little bit. That is all fine. Cough is fine. There is some penetration, but he is actually clearing it. So here the surprising thing is that when we go ahead the history, I thought it was actually nasal regurgitation going on. But here the problem is that his larynx doesn't elevate at all. Now, one of the most basic function aspect of the swallowing is that larynx has to elevate. Only when the larynx elevates, two things happen. The larynx comes under the protection of the tongue base, so it closes off. And more importantly, the cricopharynx open up. So for the cricopharynx to open up, larynx has to elevate. And larynx elevation is seen in the endoscopy as the whiteout sign. Because for a split second, you won't see the larynx at all. Because larynx moves up and the tip of the scope touches the mucosa. And you say a white glare. That is known as a whiteout sign. So whiteout sign is the most important finding actually. If it is not there, it suggests that larynx is not elevating. Why his larynx is not elevating? As of now, I don't know. When the larynx is not elevating because of the problem of its neural connection. And the laryngeal elevation is actually mainly by the suprahyoid musculature. So it is the digastric anterior and posterior bellies, stylohyoid, mylohyoid, geniohyoid, and thyrohyoid. So out of that, the two are supplied by anterior belly of the mylohyoid and the anterior belly of the digastric and mylohyoid are supplied by the trigeminal. Posterior belly of the digastric and stylohyoid are supplied by the facial. Thyrohyoid and geniohyoid are supplied by ansa hypoglossal. So, and all the trigeminal and the facial nucleus has to be in the brainstem. So, usually when there is a pontine problem, when the pons is problematic only, actually this happens. Obviously, there is nothing to suggest he has got a neurological illness. So, this is a perplexing case. We don't know why his larynx is not elevating. So, he need a thorough neurological evaluation. As the larynx is not elevating, he won't be able to swallow at all. Another question is that is quite possible. That is what actually coming through my mind. Because he had this mucormycosis, he had this operation, and he had this palate removal, and he was not swallowing for quite a long time. And sometimes in old age, that can actually happen. The system actually forgets. He has actually, the swallowing mechanism is deranged. But I really don't know. So as of now, I need a neurological evaluation to make sure that his pontine part, because the control of the 5th and 7th, why it is weak, I don't know as such. So we need a neurological evaluation. If that is not, if everything is okay, then I will start rehabilitating him, because he has to elevate the larynx. His laryngeal elevation is not working. So primary treatment is, primary area interest is to rule out a neurological lesion. If the neurologists say that everything is okay, nothing, there is nothing in the neurological system to suggest that, I will actually start my rehabilitation depending upon his motivation. First of all, we have to start dry swallowing, because he has not been swallowing for a long time. So just keep on applying honey over the lip or the tongue so that the swallowing mechanism tend to come back. But you know that in swallowing therapy, there are 3 groups. The indirect swallowing therapy, that is strengthening the muscle. The swallowing therapy, proper direct, where you give the food and modify it. And finally, if required, you do some surgical correction. So here, the laryngeal elevation is incomplete. So the exercises to develop the laryngeal elevation, there are 3 things. One is known as the shaker exercise, which is very difficult for a older person like him. Shaker exercise means you ask the patient to lie down flat, lift the head off the table and look at your big toes, so that the suprahyoid muscle become very strengthened. You have to do it many times a day. But a person like him will find it very difficult. They won't be able to do shaker. So when they are not able to do a shaker, the second exercise is known as CTAR, chin tuck against resistance. So what they do is give a squeeze ball here, keep the squeeze ball here, and ask the patient to squeeze the ball with the chin against the anterior chest wall. So this also actually strengthens the muscle. And the third, probably the easiest thing for him will be, you do the neuromuscular electrical stimulation. I am sure that some of you might have heard about the vital stim. So we have to stimulate both the suprahyoid musculature and infrahyoid musculature with electrical stimulation every day, 1 hour or so, for at least 10 to 14 days, and keep on trying to move the suprahyoid musculature. This is the treatment plan as of now. So we have to have a neurological consultation to rule out any neurological pathology, why his larynx is not elevating. Especially my area of concern will be the pons. And then I will actually do an indirect swallowing therapy with like CTAR, chin tuck against resistance, as well as the neuromuscular electrical stimulation with the vital stim apparatus. I won't do a shaker on him, because shaker exercise is very difficult for him. And then once that swallowing start, the laryngeal elevation start, we can think about giving food with other exercise. That is the plan as of now. Any clarification, any further discussion on that is required?
Thank you, sir.
This is quite surprising. I was thinking that he had severe nasal regurgitation. Nothing, because it is a hard palate resection. Hard palate resection hardly ever produce any major swallowing issue, because we can always put a good obturator and correct it. But here, surprisingly, his larynx is not elevating. So we have to find out.
Sir, in mucor cases, we had many such cases where they had isolated thrombosis of a few areas. And neurological evaluation, including MRI, came to be normal all the time.
Yeah, so, that can happen. Probably if it is very small area, especially in the brainstem, it can actually happen. Many times the brainstem stroke may present just as dysphagia. Maybe. I don't have any experience with black fungus or mucormycosis producing a neurological problem. But if you tell that you have seen, probably yes, I agree.
And he has got a voice problem.
Prakash Kumar Valecha,
Umr?
47.
He's a 47-year-old gentleman who had a nasal surgery. What nasal surgery was it?
Sinus surgery.
Endoscopic sinus. He had an endoscopic sinus surgery when? 2 years ago, he had a fist surgery. And after that, it is a voice problem?
Yes, initially.
Even before that, he had a voice problem. How long?
He has got since so many years.
So he doesn't even remember it as a long-standing voice problem. But no breathing difficulty.
सांस लेने में तकलीफ होती है, नाक के अंदर
नाक में ये अभी तक पूरा जो सेप्टोप्लास्टी करा है, लेकिन प्रॉपर मजा नहीं आ रहा है, फंस जाता है बार-बार जो ना, काफी जो है यहाँ से पूरा.
He had a septoplasty. He has got some breathing difficulty through the nose, but no true dyspnea. No true breathing and no problem with eating and drinking. No dysphagia. Any other comorbid? Pressure, sugar, cholesterol, thyroid, asthma. Are you on medicine? Tablet? No. Thyroid is okay? No asthma, nothing like that. Did he ever contract COVID?
Yes.
You had COVID. When was that? 2020. Was he admitted? Did he have a sequelae?
एडमिट हमारा हॉस्पिटल में थे भाई, हमारा कई हॉस्पिटल.
Hospital is there. We admitted there.
But he didn't have any sequelae or anything. Nothing. He's not a smoker.
He runs a medical store.
Yeah. Oh, he speaks a lot. His profession is a medical store. We need to speak a lot. How many hours he work a day? Yeah, he worked 12 hours. So that itself is actually produced. Can you ask him to do the MPD?
अपने को सुनो, एक लंबी सांस खींच के कि जितना लंबा बोल पाओ बोलना. लंबी सांस बोलो.
He actually forced, ask him to don't force it so like that. No need of. 10 seconds, but he still forced. There is some harshness, maybe because it is related to his jaw. Let me palpate his neck. Palpation of the neck is important in many muscle tension dysphonia. The first area to palpate is catch hold of the hyoid on either side. You palpate the greater cone of the hyoid like this. Normally, if you do it on yourself, you will have some slight uncomfortableness, but nothing really big. But a person who has got severe muscle tension dysphonia, vocal nodule, they will wince with pain. So be careful. If it is very, very painful, then probably he has got a vocal nodule like that. Is not there. Now the next is thyrohyoid interval. Between thyroid and hyoid, normally you should be able to insinuate a finger. Here it is very difficult. I think from the history, it looks like a ventricular band voice. Yeah, it is extremely tight here. So normally you will be able to put your finger between the greater cone of the hyoid and the thyroid. There is actually a space, thyrohyoid space. Now here, there is hardly any space. It is almost totally obliterated. That means he put lot of stress. The way he produced the E itself is suggestive of his habit. Because he didn't say E, but he told E like that. He was actually forcing. I think that habit is very much there. I can't actually go between thyroid and hyoid. So this is quite tight area here. That's a sign of muscle tension dysphonia. Now I will palpate the cricothyroid space. That will be tense in a vocal nodule. It is not here. It is quite a normal cricothyroid space. Then palpate the tongue base. When somebody is simply sitting or speaking, the tongue base should be soft enough. The mylohyoid shouldn't be contracting. If they are contracting, That means they are talking with a lot of strain. Ask him to count 1 to 10. Slow. 1. That is soft enough. So the only finding in the neck is actually the tightened thyroid space. So probably we are dealing with a ventricular band voice. We will see. No, we are doing. Jelly apply. Okay. So here I go. Ask him to tell that. Yeah, breathe through him. So ask him to breathe through the mouth. There is some crusting there. Okay, it's okay. Palate looks all right. Now breathe through the nose. Yeah, you can see that it is a fairly tubular epiglottis, not an easy one to negotiate. So I have to go carefully to go to the vocal cord. Oh, you can see that he has got a sulcus. Can you see that on the... So this, his ventricular band is actually secondary. It is not primary. Ask him to say E. E. See the ventricular band? E. Can you see that left ventricular band is medializing more than the right? Both are medializing actually. Sorry. The epiglottis is quite a tricky epiglottis. E. 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 Can you see the left ventricular band medializing more? E. Even the right, but the left is more. E. 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 And see the reason. No, don't do anything. Just relax. Yeah. I will go near now to see the sulcus. That is why his history of voice was bad for long time. It's not a bad sulcus, but it is a shallow type of sulcus. Now put the NBI, please. Yeah, now you can see the sulcus better. Can you appreciate it better now? You can see the sulcus now. I'm going very near. Can you see shallow area? Shallow. You see that? Now on the left side, you can see very clearly. Sorry. He's keeping on swallowing. Don't ask him. Don't do that.
How will we just differentiate whether it is a pseudosulcus or it's a...
Pseudosulcus will all go, it is little more inferior, and not only that, it will go posterior to the vocal process. True sulcus is always confined to the membranous cord. See that the middle third, can you see on the left side, there is a very big phonatory gap?
Yes, sir.
Yeah. So that is anterior to the vocal process. And underneath, if you look carefully, you may have even pseudosulcus, but this is the true sulcus. Now put the strobe. There is... So this is a sulcus vocalis with secondary type 2 MDD because the vocal cord is scarred, he has to actually using the ventricular band more.
We lost the endoscopic pictures.
Yeah, I also lost it. I'm waiting for it to come. What happened? Yeah. Ask him to swallow once again. Yeah, right. And now say E continuous. No, swallow. Okay, that one is okay. E continuous. Probe is not picking up louder. E. Now you can see that. E. Not bad. Maybe it is not a bad score. So it's only a grade 1 sulcus. It's a shallow sulcus. The mucosal wave is not bad. It is confined to the medial half. Maybe the amplitude is slightly reduced because the mucosal wave should go beyond more the medial half of the superior surface. You can see that it is confined to the medial half. So that is a grade 1, probably grade 2 sulcus with secondary type 2 muscle tension dysphonia. But he is 40. How old is he?
47.
47. It is not an age where you will actually try and go to correct the sulcus vocalis, because by the time the brain is used to it. So now our aim is not to reconstruct the Rhingi space. Suppose he is a 20-year-old guy, 25-year-old guy, I would have advised to correct the Rhingi space too with the fat. He is 47. He has got a job which demands a lot of vocal effort. So what he needs, if he has got a voice problem, he's really bothered about. What I will actually do is that you do a paraglottic fat injection. You just medialize, make the gap, the sulcus a little more fuller. And at that time, when I am going endoscopically, I will do a coblet-assisted partial excision of the ventricular band. So that will actually reduce the strain load, but his quality of the voice will remain same because the vocal cord, the sulcus is same. The medial margin is the same scar, but his voice strain will come down and the effort to produce the voice will come down. This is all only if he is really bothered about his voice. Otherwise, at the age of 47, you don't go and operate on a sulcus.
Sir, is there any role of voice therapy in these type of patients?
No, it is very difficult. They are not going to be amenable to voice therapy because they are going to be there for long time. Of course, you can give. So for a voice, for here, you know that his MPD is 10 seconds. He has got tenderness over the thyroid space. So the voice therapy, standard voice therapy should be to improve the breath power. That he can do. He can do a regular exercise, maybe 5 to 10 minutes daily. 2 to 3 times daily, take deep breath and say E for as long as you can so that the MPD improve. For the specific voice therapy for ventricular band voice will be proper thyroid massage. You have to actually widen that area between thyroid and hyoid. Then only the ventricular band will move away. Because when ventricular band doesn't medialize because of the muscle action of the vocal cord, it is actually because of the muscular contraction of the thyroid muscle. They all are difficult at that age. There is no harm if patient is very compliant and I think you can do that. But from my experience, I see that somebody who is in the 40s with a long-standing ventricular band voice, they don't actually get respond very well to voice therapy. So I will generally go for a coblet-assisted excision.
Sir, there is some kind of spasmodic disorder.
How old is she?
क्या उम्र है आपकी? 65.
She's a 65-year-old lady and her complaint?
गले से फटी फटी आवाज निकलती है.
Ask her to speak continuously in Hindi. What is complaint? Listen to her voice. Please listen to her voice.
मैं ओल्ड बनाल भोपाल में रहती हूँ. मेरा नाम शशि श्रीवास्तव है. मैं ओल्ड बनाल भोपाल में रहती हूँ.
Can you hear that voice?
आपके पति क्या करते हैं?
Can you hear that voice?
बैंक से
Yes, sir.
रिटायर्ड हैं.
Yeah.
कितने साल से रिटायर्ड है बैंक?
10 साल हो गए.
कितने बच्चे हैं आपके?
3 बच्चे हैं.
क्या करते हैं वो लोग?
वो बेटा विदेश में है. बेटियों की शादी हो गई.
So he has got the typical adductor spasms in between. That is almost typical of adductor spasmodic dysphonia. There is a lot of small spasms in between. And ask her to do the E for as long as you can.
अपनी एक सांस लेके ई जितना लंबा बोले.
See, her MPD was 13 seconds, but she was going on. That is typical of adductor spasmodic dysphonia. But when you suspect adductor spasmodic dysphonia, you rule out it doesn't have a tremor, because many times laryngeal tremor coexists with the adductor spasmodic dysphonia. So look for essential tremor. Ask her to spread out the hand like that and watch for any tremor. Nothing like that. She doesn't have any swallowing issues. No other neurological issues. Is she on any medicine, regular medicine?
कोई दवाई लेती है डायबिटीज ब्लड प्रेशर किसी चीज की?
आर्थराइटिस, डायबिटीज,
It is on diabetic treatment, hypertension?
नहीं.
Nothing. She's on treatment for arthritis.
Arthritis.
Okay. So this is almost typical of a spasmodic dysphonia. The MPD is reasonably good enough, but there is lot of adductor spasm, and the way in between she get this kind of spasm that's typical of adductor spasmodic dysphonia. And she has been there for how long? This
कब से आपकी आवाज ऐसी है?
1 year.
1 year. Before that, you were okay. Okay. So that's a late onset spasmodic dysphonia. We'll do the scoping. Yeah, please.
So can you demonstrate that auditory inhibitory maneuver?
What maneuver?
Auditory inhibitory.
Feedback. Okay,
Yes.
okay, sure. Ask her to count 1 to 10 again. 1.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Now block your ear with finger, one finger. Any ear. Any ear. Now count.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Not much. Now ask her to speak in a baby voice. Like 1, 2, 3, 4. Without that.
1, 2, 3,
See that?
4, 5, 6, 7, 8, 9.
Spasm is gone.
Better.
So that is spastic falsetto. But auditory feedback didn't improve much. No, that doesn't happen in everybody, but some people it will improve. So this is the spastic falsetto. With the falsetto voice, the spasm disappear. I'm going to do the scopy. This straight away we go for stroboscopy. Straight away we go for strobe. In the meantime, spray something. Just a spray little bit. You are ready with the strobe? Lean. It's not painful. Keep it. Breathe through your mouth. Okay. And don't go back to it. Don't go back. Then I can't do that. Yeah. Ask her to breathe through the nose now. Ask her to swallow. Right. Now say continuously. Can you see the adductor spasm there? That is very evident. Can you see that?
Yes, sir.
See that that's a severe adductor spasmodic dysphonia. Like that. And corresponds to your voice. Each spasm, each time her voice break like this, then the vocal cord jam against each other. And it is many times common to find that the ventricular band also get adducted at that time. Do that E. See, there is a lot of spasm. E. Can you see that? Jamming of the vocal cord. Again, louder. E. See that? That is jam in between they jam against each other. That's yes, strobe. So that is the adductor spasmodic dysphonia. So the counseling should be you have to tell that this is nothing as a serious disorder. The name is very long, adductor spasmodic dysphonia, but don't get frightened. It is a innocuous disease, but it is a nuisance disorder. If you are not really bothered about, absolutely no treatment required. But if you are really bothered about treatment, there are two options. One is the Botox, that is a first line of treatment all over the world. That is the problem. The good thing is that you don't require any surgery and you need not get hospitalized, nothing. But the disadvantage is that maximum effect is only for 6 months. So every 6 months, she need to get injected. And there are not many centers where that is done regularly. And the expense of the Botox. Botox is fairly expensive, but now there are many companies who are bringing out Botox. So price is coming down. Second option is do the surgery and do the same effect. But as a principle, I never operate straight away. I actually give Botox, see them and let them experience the benefit of Botox. And if they are only uncomfortable, they don't want to come every 6 months only, then I will actually go for the surgical treatment. In her case, if I am going for surgery, I will certainly do endoscopic thyroretinoid myoneurectomy. Coblator assisted endoscopic thyroretinoid myoneurectomy will be my choice in her. I won't do a type 2 thyroplasty in her.
So now Janki, because his flight is there,
no,
so he will switch on to.
Okay, if there is any other clarification required, I will come and talk to you later. Because
Okay.
Janaki is quite busy, quite in a haste. He
Flight
has to
is there.
finish off that.
And we have a lot more case discussion afterwards, after the nasal enteroconal polyp surgery.
Can you take this?
Audiovisual, please show the case slide of AC polyp. Before we proceed to the next session, I would request Dr. Rajiv Pajori sir to kindly honor our chairpersons, Dr. Ravindra Bansal and Dr. Rajendra Bansal. Thank you, sir. Now I would request Dr. Tarun Gujjar and Dr. S.K. Jetlia to kindly be the chairpersons for our next session, which is an AC polyp by Dr. Janki Ram. Dr. Tarun Gujjar and Dr. S.K. Jetlia. Thank you, sir.
Hello.
My dear friends.
Hello. Yes, sir.
May I know who is the moderator, please?
Doctor, right now mic is in my hand, Rajiv Pachori, but let's see who is officially. Dr. Jethalia is there.
Dr. Rajiv ji.
Yes, sir.
Dr. Rajiv ji.
Yes, sir.
This patient is having massive septal deviation. So I didn't want to again and again demonstrate the same thing. You will get bored.
Yes. Yeah, we could see.
So I finished off. I'm just going to finish off the septal deviation part of it. See. Yes. See, that is the spur you can see.
Which was the, yes.
See, massive spur. Now I think I'm done with the septal correction. It takes around 5 minutes. So the important carry home message through this is, don't ever shy away from septal correction. It is not for intra-op, but for
post-op management.
Post-op management. Very, very important. And this to me doesn't look like an AC polyp. I think it could be an inverted papilloma. I'm not very sure. Elevator. Dr. Dubeji is actually giving all the tough cases here.
All googly.
No. Give me the elevator door, normal elevator. Okay, this is an elderly lady who presents with, does she have bleeding, sir?
Yeah, bleeding.
Okay, you see, this is not AC polyp. For sure, it is not AC polyp.
It is not AC polyp.
And it could be either just normal sinusitis or it could be
Either infected polyp or some inverted sort of.
Yeah, it could be something. Yeah. Now, see, I want to tell you something very important. Give me a pack. Whenever we do a septal correction, the problem in doing FES is that it is called the Bernoulli effect.
Yes.
So, what is the Bernoulli? Bernoulli means whenever we put suction, when there is suction effect, there is decrease in pressure. And so, what happens is there is a flap. Take it out. So, use as less suction as possible whenever you're doing FES after septal correction. So, you can understand that debrider has got a suction. We can't do a case without the debrider.
Yes.
So, whenever you use the debrider in a case post septal correction in FES, it's going to fog like crazy. So, I have designed a small trick for that. It's a small trick. I'm going to show you what trick we follow for that. I'm going to show you both whether it is flapping or not, how it's flapping, what is the Bernoulli effect, how to avoid the Bernoulli effect. This is the most important thing every rhinologist should know. So see here what I will do now. I have done a septal correction. And you see what I will do. First I am putting the debrider. You see what happens. Where is the foot switch? Foot switch. Foot switch. Foot switch. Okay, you see here. Now I am putting the debrider and see what happens now. See what happens. No, don't pitch. Ready, ready, leave. Hey, kya ho raha hai? Sorry. Ready? Now you see what happens. Luckily nothing. Oh, it's fungus. Fungus.
It's fungus. Yes, yes.
This is fungus.
But it happens in most of the cases when you put either suction or debrider, the flap comes in your way.
So see, I'm going to tell you, in this case, it's not coming luckily because I have not removed that amount of septum. So I keep a little bit of septum. Whenever I want to do a face, I just remove that septum and place it back.
Yes.
So that there's not much flapping of the septum. But I will tell you the maneuver which we should use to prevent that septum. You see now, I'm going to this fungal culture.
So one very basic question. Suppose when we do the septoplasty by the endoscopic or by natural way, and sometimes we get tear on one side. Then what you do, and suppose on table you get bad spur or very big DNS, we get tear on both the sides. How do you manage those cases? And
okay, there are two ways to manage it. One is you reposition that septal cartilage exactly at that place. That is the first way. That's the best way.
Yes.
So that the perforation doesn't form. Number two way is you can suture it. Suturing is a little difficult, but the best is to place an interposition septum. You see now, hey, external camera though, I'm going to show you how to prevent the septal. Very, very practical point. Many of my residents, they have a problem when they do the septum. See here. Now I will show you how to do. See the body. First is the body. Very important. Postgraduates, septal correction. After that, you do face. What happens? See here. Number one. This is position one. Position two. Turn towards the patient.
Okay.
Hey, are you seeing external camera?
Yeah, we can see.
Turn towards patient. And then take your elbow out. Okay. Position number three. And you come with a debrider like this. See the nose now. See the nose.
Yes.
I have stented the nose. Can you see?
Yes, we can see.
No. You can't see. Endoscopic picture though.
Oh, endoscopic.
Endoscopic picture though. उनसे उससे दिखेगा. Endoscope. देखो यहाँ क्या हो रहा है. See, I have completely stented the septum. Now you see what happens. Now there will not be any flap.
Okay.
The septum will not come. So, my dear friends, again I repeat because it's very, very important. Many people, when I see, oh sir, it's fogging, like that, they will keep on telling. Again, position 1, position 2, position 3, position 4. This is very practical. Please follow this. You will never have a flap. Simplest method is what is called the stenting of the septum with the debrider. Okay?
Yes.
All these are not given in books. So what happens is, you will see the demonstrator doing very nicely. When you go back, अरे क्या हो रहा है? मुझे ऐसा नहीं आ रहा है, ऐसा you will think. But that trick will not be told to you. Lot of bleeding because of fungus. Don't worry. This is actually very osteoitic bone. That's lamina papyracea.
Yes.
Irrigate. So I will irrigate the maxillary sinus later. Now I want to see the sphenoid sinus is normal. I didn't show the scan because I have to leave urgently to the airport. My flight is at 1:30. Again, I want to thank the organizers, especially Professor Dubey sir, Dr. Sanjay Agarwal sir, and of course, my close friend. Give me a rotation mode, quick, very osteotic. First time I'm visiting Bhopal, and the first visit has been so sweet. Hospitality has been wonderful. Cases have been very interesting. And I learned a lot from Dr. Jaikumar Menon sir. And of course, yesterday's dinner party. Hey, irrigate. Keep irrigating. You should not. I will not come out at all. You see, one thing I will never do in endoscopic sinus surgery is coming out for anti-fogging. That means I'll blame my assistant only.
Yes.
I'll shout at them because, see, another thing also, irrigation, no. Many people don't know how to irrigate. You have to give bursts of irrigation. Means, wow, change to debrider mode. You have to give bursts of irrigation, my dear friend. It is not just little irrigation. Chop. You have to irrigate. Like that, you should irrigate. See how osteotic the bones are. That's why I use the, see, that's the lamina papyracea. Now, again, I want to tell you that if you want to open the sphenoid sinus, again and again, I tell you, my dear friends, follow the technique, which is the very safest technique. What is the safe technique I told you yesterday?
Gotcha. Miss, through
small
the
ball probe. Small ball probe. Use a small ball probe. Not this, my dear friend. Sphenoid probe. Give me sphenoid probe, please. I'm almost done, except for the frontal. So that's the ethmomaxillary crest. I will go below the ethmomaxillary crest. Always go below the ethmomaxillary crest.
Yes.
This is the ethmomaxillary crest. Don't go above ethmomaxillary crest. You will open the skull base. This cell of the posterior ethmoid is normal. Sphenoid also is normal, but okay, I'll use this one. Bhaiya, एक minute. Low bhaiya. Bahar low bhaiya. So I'm palpating, I got it. See, very important, my dear friends. See the bubble sign of Stamberger, debrider. See, getting the sphenoid is just a small trick again. Can you see the sphenoid sinus, all of you?
Yeah, well opened up.
Hey,
Your comment about recently, some people have started cutting the will terminate all the cases.
No, please, don't, yes. Jesus. Stamberger used to say, oh, Jesus, you're killing my patient. Please don't cut. I beg everybody who's doing FES not to cut middle turbinates, because you are not the last surgeon. You are not the last surgeon in FES.
Yes.
You yourself will find it difficult, my dear friend. You yourself will find it difficult. And remnant middle turbinates always are unstable. They are all unstable. And they will lateralize. And once it lateralizes, It will block the frontal sinus. The main culprit is you will get iatrogenic frontal sinusitis. That's the Parsons ridge. See how nicely the sphenoid has been opened. That's the skull base. Lamina paprasia. That's all finished. Now we are going towards the neosteogenesis according to the scan. Okay, now that's lamina paprasia. I'm now going to, this is all the result of the fungus, little granulation. This is, give me a wash. Now last is the frontal. Give me a wash. It's an old lady having fungus in the maxilla and also sinusitis secondary to it in the ethmoid and frontal sinus. That's all. Now I will show you the easy trick to open the frontal. See, that is it. Don't do anything to the mucosa. You don't need to do. See the sphenoid, single shot. You have to see the maxilla and the sphenoid like this. My dear friends, that's skull base, skull base, skull base. Now I will show you how to open the frontal sinus. Give me 70-degree telescope. Another 5 minutes, I'm through.
Any comment
See, again and again, we have demonstrated FES in just 15 minutes is maximum. Even in a good demonstration, you can take only 15 minutes. You don't need 3 hours, 2 hours.
What about axillectomy or axillary flap technique?
You want to see,
If you have time.
There is no time, sorry. I have to rush.
That's why it's almost
all.
Dr.
Kubeji is there. He said, I will change the timing of the flight from today.
He can do it, no.
He can do anything. No, but I also have an alternate. He has got a private jet. I'll go in that. No problem. Now give me the maxillosinus suction tip. So you can see the uncinate there. And I'm going to give rat 60 debrider blade. Nahi hai?
Yes, sir.
I'm very impressed with this Dr. Dharmendra. I want to steal him away. See, that's the frontal.
Yes.
Inside the frontal. Now I'm going to take my J curette, and that's the agonadi here. That's the recess terminalis. Now I'm going to take the J curette, and I'm going to pull it forwards and laterally. It's all osteitic. Forwards and laterally.
Yes, the way.
Never do it medially. Why? Because the skull base medially is thin.
Yes.
It is only 0.05 millimeters. See how nicely the frontal is opening up. Now, the most important thing many people do is they stop here. You cannot stop here. This is not complete frontal recess surgery. Why? Because you should take off this ledge of bone. How do you take the ledge of the bone? See here, you go into with the debrider and break it posteriorly. It's very osteitic. Give me giraffe. I will take off this and then I will show you how to break that bone. So I have to break that bone or else this is going to go in for a stenosis. Can you see the frontal, all of you, please?
Yeah, we can see.
Clearly seen. Now, how to break that bone? This is the most important part of the surgery. So that means you have to combine the frontal recess with the fovea. Some people call it suprabular recess. Some people call it some name and all they give. That is actually the anterior fovea. Now, give me the J curette. See, I'm going to use the J curette to break it. So, there are two ways of breaking it. One is from anterior to posterior. That's the skull base here. This is the frontal here. So, that's the ledge of bone. I can either break it like this or I can break it like this. I should not break it like this if you have anterior ethmoidal artery dehiscent, because you will pull the anterior ethmoidal artery. So, always safe is to break it from anterior to posterior. Now I'll use my J curette. See how I do that. Now I go towards the lamina paprasia.
Very thick.
Yeah, I broke it now. See that? Can you see that I broke it? Give me giraffe. Now I've broken it now very nicely. I'm convinced. Now I just have to take that bone with the giraffe and take off the mucosa with the debrider. So my dear friends, this is very, very important. Many people do frontal recess surgery inadequately. So frontal recess surgery is a all or none surgery. What is all or none? When you do frontal recess surgery, you should see the nasofrontal beak anteriorly. You should see the anterior ethmoidal artery posteriorly. If you don't see that, that means you have not done frontal recess surgery fully. This is that. Give me debrider now. Debrider. Now you see, I generally don't use the debrider in the reverse mode because the postgraduate will always feel a little bit tense to use it on the anterior ethmoidal artery. So I use it in the forward mode with the guard facing posteriorly. So that's the anterior ethmoidal artery here. Can you see this here, please?
Yes, yes.
All of you.
Yes, we
Now
can.
see how I widened the frontal recess. This is nasofrontal beak here, my dear friends. There's a little remnant uncinate here.
Yeah.
This is nasofrontal beak here anteriorly. Medially is the middle turbinate. Laterally is the lamina paprasia. Posteriorly is the, can you see now clearly, all of you?
Yeah, artery can see.
Very beautifully seen. I have to remove this remnant uncinate process. That's all. Give me. So we have completed. Give me a J curette. Give. Now I'm taking an upturned Blexley, which has been given to me by Bhatia. So I'm just going to take this out, leaving behind the mucosa. That's it, finished.
Yes.
So that's it. I've finished the surgery. I'm very happy. I'm sure this patient is not going to have any sort of recurrence. I'll just show you with a 0 degree. I always say at the end of the surgery, give me straight. At the end of the surgery, you should see all the sinuses with a 0 degree telescope. If you don't see it with a 0 degree telescope, that means you have not done a FES properly. That means the frontal should be seen. The maxilla should be seen. See the maxilla now seen very clearly here, all of you. Yes or no?
Yes, yes, sir.
Okay. Now suck only the nasopharynx again. Now the next is the sphenoid sinus. See the sphenoid sinus. Can you see the sphenoid?
Very
view.
clear. Very clear.
Maxilla, sphenoid. Then see the skull base. Next is the skull base. You should not have a triangular skull base. You should always have a rectangle. See the frontal. Can you see the frontal, my dear friends?
Very clear. Very clear.
Anterior ethmoidal artery, frontal. See, I'm seeing 1, 2, 3, 4. Anterior ethmoidal artery. What more you want in FES? That's all. Finish.
You
will have a very good result. Thank you very much.
Thank you, sir. Thank you very much,
really
all of us.
Dr. Dubeji, for this wonderful opportunity. And I thank Dr. Sanjay ji and Dr. Vaidya sir and all the delegates for all like my friends, brothers. Of course, Dr. Rajiv Pachori, who actually moderated this session. Thank you all. Love you all. See you again sometime later. Yeah.
So everyone in the hall is vote to your shower of knowledge given by you to all of us. Thank you very much. Very much.
Thank you. I'm going now. I'm going to the room to vacate the room.
All the best, sir.
Thank you.
Thank you, sir.
Now I would request Dr. Sudhakar Vaidya.
अरे हम आपको किडनैप करेंगे
To kindly honor our chair,
धर्मेंद्र
Dr. S.K. Jetli and Dr. Tarun Gochar.
Okay, bye. Then I need my this one. he is better than us.
Next is also a case discussion by Dr. Menon. I would request Dr. Kirti Ashwin ma'am and Dr. Anil Jain to kindly moderate the session.
You open it to me. Open again. Dr. Dubey is here. Good morning. So we are starting the next session of OP.
Anil Jain is not there. I would request Dr. Anusha Shukla to kindly chair this session. You are here. Okay. Dr. Anusha, you also please join Dr. Kirti.
I'm waiting for Dr. Dubey to come because obviously I need a translator. In the meantime, any thing about the last case, the spasmodic dysphonia or the swallowing problem, anything we can discuss. Just few minutes till Dr. Dubey comes. Oh. Can you speak English? Yes. So this is okay. He can speak English. Okay, then we can start. Your name, good. You can speak on it. Your good name?
Nikhil.
Nikhil, and how old are you?
It's 33.
So we have got a 33-year-old gentleman, Mr. Nikhil, and tell me the complaint.
Actually, I'm facing a problem since 2019, 1920 around. There is a sort of unwanted tissue developed in my vocal cord.
What is your complaint? What is your problem? You feel something?
I feel something irritation. I always feel in cord. It's like a hair.
How long?
Since 2020.
So he has got sensation of something irritation, something lump in the throat, like that.
And sometimes it's painful.
3 years.
Sometimes
it is painful.
Painful too.
Is it always on one side, or is it in going to the right or left, something like that?
Majorly on right side, left side, but maybe because of some infection and other thing, when I got throat infection or any other issue, then it's like,
but it is more on the left side. More on the left side. But your voice is all right.
Yes.
Voice is okay.
Voice is okay. For the very first time, before just 1.5 months before, I found one thing, that my voice is like not that good, or and I came to sir and he suggested me to come.
But right now your voice is okay.
Yes, my voice is totally.
No breathing difficulty.
No breathing difficulty.
No problem with eating and drinking.
Sometimes when I feel irritation or
not a major. Okay. Are you on any sort of regular medication?
Since 2020, I guess I'm getting medicines from here, but
no, I mean a regular medicine.
No,
nothing. No. Are you a smoker?
At times,
you take drinks?
Very occasionally.
Okay. And what is your job?
I'm working with coal industry. Coal.
Okay. And does your job need you to...
No, my job is desk job.
So not much of a talking is required for his for his job. Okay, okay. Did you ever contract COVID?
Never.
Never. And do you suffer from tummy upset, stomach problem, acidity?
Never.
Nothing. Okay. You are not allergic to any medicine?
No.
So you heard that story. 30-year-old young man has got complaints of sensation of lump or irritation of the throat, predominantly more on the left side. No hoarseness, no dyspnea, no dysphagia. And he doesn't have any other illness. He's a occasional smoker and drinker. No other major contributing thing. So that's about the history. Let us start now. Can you locate where exactly is that pain? Where can you locate externally? Can you? So he is actually showing somewhere on the side of the thyroid cartilage. That's usually the area he is actually in the upper 1/3 of the thyroid cartilage. This usually corresponds to the cricoarytenoid joints. That's a common area where patient has got a sensation of lump. This is the area, no? Yeah. At times here also. And the laryngeal crepitus is normal. There is no tenderness of the hyoid. Thyrohyoid space is quite roomy space. See, unlike the other patient, I can easily put the finger here, nothing. Cricothyroid space is normal. Thyroid is not enlarged. And tongue base is reasonably okay. Now, just to check your vocal power, I will ask you to take deep breath and say E for as long as you can. Keep the microphone and do that for as long as you can. E. He's got terrific vocal power, 35 seconds. Very good. Okay, I'll just spray his nose. So he doesn't have a hoarseness, he doesn't have dyspnea, he doesn't have dysphagia. So he no major serious symptoms regarding to larynx. But he probably has one of the commonest symptoms, that is a sensation of the lump in the throat, the globus symptom. So we will see why he is having any specific cause, or sometimes you may not find anything at all. I'm just going to spray your nose with a local anesthetic. For a minute it is stinging, but otherwise it will be okay. Then you will be comfortable. You won't have any pain or anything. That's all. That's all. 1 minute. Now you can have it. Gently, please. So I'm just going to do the scopy. I'm going through the nose. You breathe through the mouth gently. Gently open the mouth. So I'm going along the nasal floor of the nasal cavity. Reach the palate. Ask you to breathe through the nose. Breathe through the nose. You're going backward. Don't go backward. That's all. Nothing. Don't worry. Now I reach the larynx. Ask him to swallow. Can you swallow saliva? Yeah, that is very. Oh, that's okay. Then enough. Say. You see that this is the overriding arytenoid. Can you see that? Yeah, that's okay. Can you see the overriding arytenoid here?
Yes, sir.
The right arytenoid is significantly overriding. Say. So there is a grading system. Okay, stop. If the corniculate of the overriding arytenoid hit the cuneiform, posterior part of cuneiform, it is grade 1. If it hits the anterior part of the cuneiform, it is grade 2. If it is below even beyond the cuneiform, it is grade 3. So watch here. See, that's almost coming to the anterior border of the cuneiform on the left side. Can you see that? Yes,
sir. Yes, sir.
See, so this is a grade 2 overriding of the right arytenoid, but obviously that is a benign overriding. This is actually sometimes known as benign adduction arytenoid asymmetry, BAAA. Many times in literature, if you look, you will say that BAAA. BAAA means benign adduction arytenoid asymmetry. So in the absence of any major hoarseness or a sudden onset hoarseness, phonatory gap, any symptom, then that is known as a benign adduction arytenoid asymmetry. Now you see that when you hit the corniculate against uniform, you will see that there is a chance that this is an sorry, don't go back. Adduction arytenoid asymmetry. So there may be a small ulceration because it is not a symmetrical hitting. See that, look at the medial margin of the left uniform. Okay, that's okay. This area can get little bit congested because of this. So that is the reason. And you know, the his actually larynx is very sensitive. That again suggests that his larynx is quite sensitive larynx. So probably reflex is contributing, and the area of tenderness he tell is actually corresponds to the arytenoid. So this is secondary to the benign adduction arytenoid asymmetry. That is why he is having that. So what he needs is essentially reassurance only. It is nothing serious. It's a normal variant. He may benefit from a PPI because the reflex bathing of the posterior larynx will actually be less with the PPI, and the symptom will be okay. That's all what is required. So it is nothing serious about it. PPI, proton pump inhibitor. That's a tablet you take for few. What did he ask? Yeah, you know that you got two vocal cords, right? It has got a joint. And normally the vocal cord hit like that. Normally, right? Suppose I have to clap my hand like that. But many times, one vocal cord will be a little bit more powerful. So that many times for the right side. And in your case, so if I am hitting, my right hand is coming like that. Similarly, your right is hitting little bit hard on the left side. And on the left, that area where you hit, you get a small area of ulceration. Yes. That is what you are feeling as. It is nothing serious. It is not, it is probably related to your style of speaking. And many times acidity will make the condition worse. So treat that, take plenty of water. This is absolutely nothing to worry about, not cancer or anything. Just leave it alone. Okay? Right.
Thank you.
Sir, what do you have any opinion on people having any kind of problem in the nose and that affecting the larynx, like a DNS or obstruction, which leads to the people sleeping in particular positions and the reflux affecting them on that side only?
I don't think, as far as I know, to my knowledge, there is nothing which affect the larynx. So not a postnasal drip or anything actually affecting the larynx. There is no evidence as such now. Reflux is said to be a major cause because reflux comes from the esophagus, that is posterior to the larynx. So the posterior larynx is likely to be affected by the reflux. So posterior laryngitis, intra-arytenoid pachydermia, thick mucus, they all are sign of reflux. So a reflux acid bath mucosa is more prone to injury. That is the only thing as far as now we know.
Okay, sir.
Yeah, please. Do you speak English?
गले में अंदर जो गांठ है.
We have seen her. She has got some nodule in vocal cord.
So what is her complaint?
क्या तकलीफ है आपकी?
हाँ तो वो दवाई खाते हैं जब तक ठीक है, उसके बाद क्या आवाज थोड़ी गला से लगने लगता है.
She takes medicine. It is all right. When she leaves medicine, the voices again become hoarse.
So she has got hoarseness for how long?
वो सर हम ये चाहते हैं कि मतलब ये ऑपरेशन की ठीक हो जाए, मतलब दवाई से.
नहीं कितने कब से? 3 months. 3 months.
Before that she was fine.
3 महीने पहले बिल्कुल अच्छी थी.
हाँ ठीक है, लेकिन आवाज तो 4-5 महीने से कभी कभी गला बैठ रहा था, पर हम समझ.
She's saying intermittently since last 4 or 5 months, hoarseness is there, then taking medicine, it is relieved, then again it comes.
How old is she?
मैं 38.
She's married and has your children?
हाँ, two children.
How old are they? Children age?
10 years, 5 years.
So she's a housewife. She doesn't have any. She has got a 10-year-old and 5-year-old children, and her complaint is hoarseness on and off. Does the voice become normal in between?
बीच में बिल्कुल आवाज normal हो जाती है क्या?
हाँ, normal रहती है आवाज.
That's a very important history. When somebody says that their voice become absolutely normal in between, then it almost rules out a significant pathology. So vocal nodule typically present like that. So here the history, everything probably points to a vocal nodule because she's a young lady. She has got young children. She probably speaks a lot. The symptoms come on and off. In between, it's become better. All these things. No breathlessness, no swallowing problem.
अटकने में और सांस लेने में कोई तकलीफ तो नहीं होती ना?
नहीं होती. कभी कभी रात में पहले लगता था कि ये दवाइयाँ कुछ भी नहीं खाई थी तो ऐसा लगता है जैसे कुछ है गले में. रात में एकदम से मुंह खोलना पड़ा था.
Very occasionally she has choking sensation during night.
Okay, fine. There's nothing and no other illness. She is not on any medicine.
Diabetes, blood pressure कुछ तो नहीं, कोई दवाई तो नहीं खाती?
ये गैस है, गैस का प्रॉब्लम.
Acidity.
Acidity.
She has got acidity. And is her menstrual periods regular?
आपका मासिक धर्म नियमित है?
पर अभी ठीक है, अभी दिखाया है तो तुम.
She has shown for irregular menses, but now it is regular.
She had irregular menses, but she didn't have it. She is not on any gynecological treatment. Now, that's many people might wonder why I am asking a menstrual history, but I think I told yesterday that's a very important history in a female patient with a voice problem because estrogen is a very big protector of the vocal cords. Progesterone is other way around. And even a normal voice speaking lady can have problem during the premenstrual period or the progesterone phase. So always ask about the history. Let me ask one other thing. Have you noticed anything special about her style of talking? Her style of talking? That's the key. It is not the loud talking which produces the vocal nodule. It is the fast talking. And if you listen to her, you know that she talks very fast. That's typical. So it's almost typical of a vocal nodule. Of course, sometimes finding may change depending upon the scopy. But as of now, history, everything suggests in favor of a vocal nodule or a type 1 muscle tension dysphonia. Let me see now. There here. She has got pain. When I touched his pain. See that? Can you see that reaction? You have seen it earlier. They didn't jerk. Now she has got. See that is painful. Vocal. See that? Can you see that? That's very painful. This is typical of a vocal nodule finding. They develop that hyoid is so tender the moment you touch. And I have had experience of patient developing vasovagal syncope and collapsing. So you have to be careful when you palpate the hyoid in a suspected vocal nodule. They'll be very tense because the muscle from the digastric, the stylohyoid digastric come like that and get attached to the greater cone of the hyoid. And from there, the anterior belly of the mylohyoid go there. And that area is very, very tender in a vocal nodule patient because they keep on pulling the hyoid up. In vocal nodule, the larynx is always slightly up. So these muscles are overacting and the hyoid is that area of interest. They become very, very tender. Now I palpate little bit below thyrohyoid space. That is not painful. That is more in type 2 MDD, ventricular band. Here it is okay. She doesn't have any tenderness. So I am putting my finger between the thyroid and hand. But if I go high up, that's painful. She winces. So, and ask, is it both same side or pain more on one side?
एक तरफ ज्यादा पेन हुआ अभी कि दोनों तरफ बराबर पेन होता है जब दबाए? Right.
She has more on the right side, but usually 90% of the people have more on the left side. It may be related to the handedness. Is she left-handed? Okay, it can happen. So, but she has got tenderness both vocal cord. And now the next point is cricothyroids. See, that's also painful. See that? This is all typical of vocal nodule. The cricothyroid is tender, hyoid is tender, and many times the tenderness will be in the base of the tongue also. It is not there. Okay, now we will do the MPD and then MPD.
एक लंबी सांस लेके आप बोलेंगी नॉर्मल आवाज में जितना लंबा बोल सकते हो उतना बोलना.
So we are just checking the MPD. Okay, please do that.
लंबी सांस बोलेंगी.
That is good. 15 for a lady is actually quite good. That is okay. Now I will do the spray. Tell her that it will. I'm spraying. Little bit stinging. Tell her. So I'm going to do the scopy now. Ask her to breathe through the mouth now. Gentle. No need.
अब सांस से सांस लेना शुरू करो.
Okay. Take deep breath. No, relax.
Relax.
Okay. Take breath now. Take breath. Relax. You can see the airly nodule on the left side.
Yeah.
Can you? Okay. And slightly polypoidal on the left side, and a very small, very early nodule on the right side. So that is actually the typical. And her larynx also is highly irritable. See, she keep on. Can you see that hourglass shape phonatory gap?
Yes, sir.
Can you see that hourglass shape phonatory?
Yes, sir.
Yeah, there is a polypoidal nodule on the left side and a very small early nodule on the right side. And she, yeah. I can connect, if she is tolerating, I can connect strobe. Please connect the strobe. Okay. So, vocal cord polyp and nodule will have a mucosal wave, while cyst will not have. That is how you differentiate, really. Yeah, continue. See that beautiful mucosal waves are there. That is actually normal. Okay, that's fine. So that is type 1 muscle tension dysphonia. Typical, everything is typical except her MPD. Usually these people have a poor MPD. Her MPD is not bad. 15 seconds is not very bad, really. So vocal nodule, this I want to tell everywhere. I keep on telling. Vocal nodule is not a surgical disease. There is not much role for surgery, except, of course, exceptional circumstances may be there. But this is actually a condition which probably wants voice therapy. And no medicine is going to cure the condition. You can, of course, treat LPRD and all these things. So the treatment is voice therapy. And there are 3 aspects to the voice therapy. Vocal nodule is the result of a mismatch between vocal ability and vocal demand. So our treatment should be aimed at improving the vocal ability, reducing the vocal demand, and teaching the vocal hygiene. Vocal hygiene is fairly simple. Everybody will follow. The other 2, they may not follow. But so what you do is, what are the standard vocal hygiene you are going to advise? First of all, the only important medicine for vocal cord we know is actually water. So hydrate them. Ask them to drink frequent sips of water. That is the single important treatment. Do a lot of enough hydration. Deep breathing in shower with mouth open is actually an excellent technique. If they are singers, they can sing in bathroom. Why? Because when you are breathing in a bathroom, you are actually inhaling highly humidified air, which actually go through between the vocal cord, which humidifies the vocal cord much better than anything else. Avoid acidity. She has got reflux, so treat reflux. You know that acid is the enemy of water. If you put acid on water, water will be dried up. So treat acidity. Aloe vera has got some role. It actually reduces the mucus from the throat. So aloe vera gargle will be okay. Be careful about premenstrual period. Instruct them. Tell them that premenstrual period is troublesome area for them. And more so because she has got two small children. These mothers, they shout at their children and they create lot of vocal nodules. And the role of voice rest. There is nothing called absolute voice rest for vocal nodule. The basic rule of vocal cord is that 1 minute voice, you need 2 minute rest. That means 8 hours voice, 16 hours rest is the thing. So you should actually inculcate that habit. Tell them that if you're talking too much and if you feel strain, you will be okay if you take enough time of close, their voice is likely to strain. And finally, the most important advice, but most of the time people fail to follow, is that ask them to speak slowly. If you speak slowly, you will never develop vocal nodule. It is not the loudness which is creating trouble. Have to do the laryngeal massage. This patient need massage of the suprahyoid complex, the digastric stylohyoid complex and the hyoid. I will just illustrate with a simple example. Vocal nodule is something like backache. Now, if vast majority of the backaches are because your own creation, you sit in a crouched position, you have got a back technique or something like that. So we can treat it 3 ways. Backache can be reduced by giving medicine, painkiller, but once the effect of painkiller goes, the backache comes. Similarly, you can give steroid, the symptom will go away, but once you withdraw the steroid, the hoarseness will come back. The second treatment of backache will be absolute bed rest. My doctor suggests that you go and sleep total bed rest for 2 weeks. Don't sit up all. I take 2 weeks bed rest. My pain is gone. But when I come back, my habit hasn't changed. I will again sit crouching. I will again develop backache. This is what voice rest is going to do. Voice rest will not cure the vocal nodule. It will simply reduce the symptom for the time being. But when they come back, they again speak in the wrong technique, they develop the vocal nodule. So what is the treatment of my backache? That is making me sit upright. That is physiotherapy. That is what exactly is voice therapy. You treat them, teach them how to produce a voice. And finally, suppose my backs are so much aching, I cannot do the physiotherapy. The muscles are so bad. Then they do what is the massage, back massage. Exactly same is the vocal massage, the laryngeal massage before you start the voice therapy. Right?
Sir, and is there anything additionally you counsel for specifically teachers? Because they always have this issue of too many lectures in a day and all those things which they can't avoid.
Yeah, same thing. And I'll prescribe I am the biggest prescriber of microphones.
Microphone.
So you prescribe microphone. That's the easiest way. It actually amplifies. But again, there is a problem. Many teachers forget that they have got a microphone. They still shout in the microphone, making the life uncomfortable for the students and keeping their neck bad also. But microphone is an easy solution. You amplify their voice, so then the strain is reduced.
Yeah, good morning, sir. I just wanted to know that is there any role of T3, T4, TSH, that is thyroid dysfunction, with the change in voice and lump in throat? Sometimes the patients comes to us, they have that lump in throat feeling and change in voice, and even the patients have irregular menses, and we, get the thyroid function test and it's like hypothyroid or something like that. So is there any role of the thyroid hormone on, like that?
Voice. Yeah, certainly. If you suspect that, you should do that. But hypothyroidism usually produces polymenorrhea or menorrhagia, increased frequency of the periods and more bleeding. And also, hypothyroidism doesn't produce a vocal nodule. It produces the Rhinology edema. Generally, the voice will be very coarse, low-pitched, and the vocal cord look much thicker. But It's a systemic disorder. If you suspect hypothyroidism, you should do that.
Okay, thank you, sir.
Yes.
So
You
this
can speak
patient,
English.
yeah.
Yeah. Your name, please.
I'm Deepak Lalchandani,
And how old are you?
60,
So we have got a 60-year-old gentleman. And what is your profession?
businessman.
So businessman. Do you need to talk a lot for your business?
In business, I am actually a social person also.
Ah.
That's why I talk.
You need to talk.
Yeah.
That's okay. And what brings you here? What is your complaint?
Actually, this will be easy for me to talk to you in Hindi. You will understand.
Okay, no,
He will
what
try- he will
happened?
translate.
What happened?
Ah.
He is a singer also.
Oh, okay.
He came to me with the complaint of hoarseness of voice.
Ah.
I am knowing him since long.
Ah.
So I prescribed him some steroid because acute laryngitis was there at that time. So he was relieved. And subsequently, whenever he sings, he always have difficulty in taking the higher notes.
So it is only for his singing voice he has got a problem. Your speaking voice is all right.
Even the speaking voice, even still it is hoarse, little bit hoarse, not normal now.
So he has got
And
problem with the speaking voice as well as singing voice. Okay, how long?
2.5 months back.
Before that, you were perfectly all right.
No problem.
Okay, so it started only 200 months. And was there any specific reason, like check the blood level?
Normal.
And you don't suffer from asthma, breathing difficulty or anything like that? Okay. Are you a smoker?
No.
You take drinks?
Occasionally 15, 20 ml.
Fine. Okay, did you ever have COVID in the past?
2 times.
Twice you had COVID.
Yeah.
Were you admitted in the hospital?
No.
It was
From
very
home.
mild.
Mild.
And after the COVID, did you have any of the long-time effect like breathing difficulty while walking, nothing like?
Nothing. No.
Okay, that is enough for the history. So that is his main complaint. He has got a subtle hoarseness. But others will understand that you have got a voice problem, or you feel only? Will others tell that why your voice is bad?
I think they don't feel.
They don't feel.
You feel? Yeah.
It is not. So but it is subtle. It is not very big, no? So he has got a subtle hoarseness and he has got problem with both singing and speaking voice. So let me see.
I have one problem.
Yeah. Yeah.
I get cough in the night only.
You
not
get,
full.
You get
not
cough
full.
in the night.
Night only.
During sleep or
during sleeping time.
Do you wake up with cough? No. You just cough and you sleep and sleep on. You don't. Your sleep is not disturbed.
No, not disturbed.
And you don't wake up with severe breathlessness.
No.
Nothing. Okay, that's fine. Right. Okay.
This every day I'm feeling this
in the night.
In the night when I want to sleep, at that time cough will start.
That time cough also is there.
Yeah, I start and then when I sleep, then there is no problem.
Oh, you mean I got it the other way around. So cough while you are awake. Once you are asleep, you don't have any issue. Okay, that's an important history because no chronic or non-pulmonary dry cough, which present only during day. Larynx get irritable. The scientific terminology will be PVVN, that is post-viral. It's actually psychosomatic, like asthma. That is why when they sleep, when you are then totally off their symptom, of their thought, the cough won't come. If they are engaged in or immersed in a very concentrated work, again the cough won't come. So they all are typical of a cough of a recent time, especially after COVID. Lot of people have got this kind of post-viral vagal neuropathy, which is more of a nuisance than a real illness. Okay.
But I was COVID positive 2 years back.
Yeah, but it can run on months and months many times.
Okay.
Okay,
But
we'll see.
this problem I am
Recently only, between the thyroid and hyoid, not tenderness either. And if I press the cricothyroid, again, that is a normal. And the tongue base look very, very soft. There is nothing wrong with it. So that external examination looks normal. So I will just have a look at your vocal cord with my camera. This is a spray. For a minute, you will feel a burning sensation. Then it will be okay. No, I'm going through the nose. That's all. That's the difficult part. And now rest is not very difficult.
अभी शुरू में जब अंदर डालते नाक तो मुंह से सांस लेना, बाद में नाक से लेना, ठीक है, हो जाएगा।
Keep it there.
टिश्यू है, टिश्यू है ना, टिश्यू दे दो।
Give tissue.
चलो।
Okay, here I go. This is not painful. Don't worry. It's not at all painful. It will take only a minute or so. Just breathe through your mouth. Nothing. Don't worry.
There is an important announcement. All those who are staying within the hotel, kindly please proceed with your checkout. It is an instruction from the hotel authorities.
Now, you see a lot of thick mucus. That is the main finding here. Yeah. Spit out gently. Sorry, cough out gently. Do that. Clear. Okay. That's okay. Let me go and see. Say. Looks fairly normal enough. There is a lot of thick mucus. So they all suggest something post-viral. Put on the NBI, please. Can you see that slightly whitish thing on the medial margin of both vocal cords?
Yes.
Yes, sir.
Which NBI only picked up. This many times happen. This is actually, and you can see, it is not leukoplakia or keratosis, because if it was a leukoplakia, you would have found in a suspicion. This is quite whitish area. Can you ask him to cough? Yeah, cough a little bit again. Clear it. Strongly. Right. Okay. Now you see that, you still see that.
Yes, sir.
See, you can see that?
Yes, sir.
So this is known as the idiopathic ulcerative laryngitis, which is fairly a common condition after chronic bout of non-pulmonary cough. Because of the chronic impact, they actually develop small ulceration on the middle third of the vocal cord, at the junction of the middle one third and anterior one third. They are absolutely self-limiting condition, but many times post-viral and the cough-induced. So there is a small area of laryngeal space problem with him. That is why his voice is actually like that. Sorry. That's all. Finish. That's all. You can wash your mouth. Finish. So that is actually that is a neurogenic cough with idiopathic ulcerative laryngitis, which is very, very common after viral infection. Many people develop. Of course, it depends upon the habit of the patient. Some people have the tendency to keep on clearing the throat. When they feel there is mucus there, they keep on really hitting the vocal cord against each other, and they create small ulceration. That is why it is actually taking longer time. Usually, a acute laryngitis should take only 2 weeks. But when they develop an ulcerative laryngitis, it may take even months, 2 months, 3 months time, and he still has cough. So the treatment should be, we should actually control the neurogenic cough. There are 2 medicines available. The best, depending upon the choice, both are equally effective. The first is tryptomer. You start on 10 milligram. Usually, even with 10 milligram, they start getting control. But you can increase every third or fourth day depending upon the control of the symptom. If the symptoms are not getting control, you can go up to 50 milligram in 2 divided dose. Or tramadol is an equally effective thing. It is you start with 50 milligram twice daily. You can go up to 100 milligram twice daily. Usually, in a 2-3 days time, the cough will be under control. But you shouldn't suddenly withdraw it. If you suddenly stop it, the cough come back. So you have to continue it for a period of 2 weeks or so, then gradually taper off. Then also, if the symptoms are very severe, for acute symptom, immediate symptom, this is the cure of the condition, because here both tryptomer and tramadol act as the neuromodulators. But for immediate symptom control, you can use benzonatate, which is now available in India, Benz pearls. You will get under the train of Benz pearls, B-E-N-Z pearls. So it's like a lozenges. They can keep it in the mouth and keep on chewing on it. So it gives sort of an anesthesia to the supraglottic larynx, and the cough will be symptomatically controlled. Now, even though he doesn't have obvious symptom of the LPRD, I will still treat with him with LPRD. All neurogenic cases, all chronic cough cases should be treated with LPRD also. The reason is that even though they don't have primarily LPRD, because of their cough, when somebody is coughing continuously, the intra-abdominal pressure goes up, and because of the intra-abdominal pressure, the acid goes up. So there is a pressure reflex. And to control that, it is safer to give pantoprazole too.
So how long to continue that?
Yeah, the teaching from Belavsky's group is that you have to give to a length of period which is equivalent to the duration of the symptoms. So the patient had 2 months, you have to taper it off over a period of 2 months.
So how often do you advise upper G? But then when will you think that it is because of the old age, the voice changes?
Well, first of all, we have to understand that there are two conditions, presbyphonia and presbylarynx. Even though they appear same, actually they are little bit different. Presbyphonia means the vocal cord is atrophied due to the aging change. It can happen. It is like graying of hair. Sometimes it can happen as early as 45. Sometimes it may happen as late as 70 years old. So what is a sign of presbyphonia is a keyhole-shaped phonatory gap. The vocal process will be very prominent. I think I yesterday showed a case like that. There the vocal process is prominent. Anterior toothed will be a little bit atrophic. It is a membranous cord. And posterior to the vocal process also, there will be atrophic. So with the result that when they phonate, you will see a keyhole-shaped phonatory gap. Keyhole because the head of the key is between the arytenoid and the stem of the key is between the vocal cord proper. But at the vocal process level, they meet. So this is their voice. The pitch become higher because the mass was reduced. Now presbylarynx, this is presbylarynx. Presbyphonia is a more generalized state. So aging doesn't affect just larynx alone. It affects all the resonating chamber. So there will be change in the nose. There will be change in the joints of the cricoarytenoid. There will be change in the oral cavity. There will be change in the effect of aging on the whole of the vocal mechanism is known as presbylarynx. While vocal cord atrophy alone is presbyphonia. So many times they require only counseling, good vocal habit, breathing exercise. But if he's a high profile voice user, you have to intervene. You may have to bulk up the vocal cord by injection laryngoplasty, fat injection. A lot of options are there.
Okay, thank you, sir.
Sir, in this particular gentleman who just left, is there any role of mucolytic agents, sir? Because sometimes they do.
Chronic non-pulmonary cough is an entity. It's a very common entity. The problem was that it's not like that. 40% of the chronic non-pulmonary cough is PVVN, post-viral vagal neuropathy, and 40% are actually LPRD. Now, many times, without doing a scopy, with proper history alone, you can many times diagnose. The typical 5 features of PVVN, that is post-viral vagal neuropathy or neurogenic cough, is that 1, they will be hardly affected during sleep because it is a psychosomatic disorder. They won't have any problem. Once they sleep, they won't have problem. Second, temperature change worsen the condition. So putting on the AC, increasing the fan speed, they generally start coughing. 3, smell irritate. So smell of masala from the kitchen, perfumes, smell from the petrol pump actually irritate and precipitates the cough. 4, speaking many times initiate the cough. 5, laughing will initiate cough. They all are signs of PVVN, not LPRD. While LPRD has got 5 classical signs, it is worse during night or both during day and night. It is worse after taking food. It is worse with lying down. It is worse when patient stoops something to pick up. Suppose he has got a hiatus hernia, and many times that history I asked, they wake up in the night with sudden, frightening inspiratory stridor. Both patient and bystander will think that death is impending because for a few seconds they cannot breathe. So they will cough out, wake up in the night, and then start like that because the larynx go for spasm. It is actually an absolutely innocuous condition. Within 1 or 2 minutes, once the oxygen saturation goes down, it automatically breaks down. But once the first time the patient experience, that can be a terrifying experience. They will think that they're going to die because the larynxes go for terrific spasm. That is, the reflex arc will be the superior laryngeal nerve, nucleus ambiguous recurrent laryngeal nerve. But luckily, once the oxygen saturation dips below 90, automatically that reflex arc break down and they will be okay. But the history will be different. Patient will say that we woke up, I couldn't sleep. Somehow we reached the hospital, they gave something by the time it is not because of the medicine he improved, but because it is a self-limiting condition, right? It actually breaks down, it goes down. Only two sets of people are potentially at danger when they have got irritable laryngeal syndrome. This is known as irritable laryngeal syndrome or ILS. That is below the age of 1, it's there. I think I will stop it. And above the age of, say, older people, they can, and also when people are highly inebriated with alcohol, then this laryngospasm can be deadly. I will stop for the time being because they are ready with the theatre. See you a little later. Thank you.
Thank you, sir. Next, we have a case by Dr. Deepak Haldipur. Kindly put on the slides. Before we proceed to next session, I would request Dr. Ashutosh Nima to kindly honor our chairpersons. I would like to invite Dr. Anil Jain, Dr. Anusha Shukla, and Dr. Kirti Ashwi to kindly come on the stage. Dr. Anil Jain. Dr. Kirti.
Hello.
And Dr. Anusha Shukla. Salam.
Yeah, hi Anusha. This seems to be a case of revision tympanoplasty.
Next, for the next session, I would request Dr. P.N. Verma, Dr. P.S. Chaudhary, and Dr. Shalini Jaria to kindly chair the session.
Yeah. Section ಬೇರೆ ಕೊಡ ಕೊಡೋದು ಫಸ್ಟ್ ದೊಡ್ಡದಾದು.
Hello.
Hello.
Yeah, good morning, sir.
Morning, sir.
Good morning, sir.
Yes, sir. See, this case was operated in 1999. Can you hear me?
Yes, sir.
Yeah, alligator forceps koda.
Sir, picture is not clear. Microscopic
Yeah.
picture.
No, I'll focus it. So hold this. 1 minute. Focus करना कर ये now it should be okay.
Yes, sir.
You can see the perforation there.
Yeah, we can see the perforation.
Yeah, 1 minute. I'll focus it a little bit further. 1 minute. I will adjust the focus. Huh? Yeah, boss?
Yes, sir.
I know, adjust कर रहा हूँ मैं.
Okay.
No, then what happens? It's better I focus the camera first. perforation.
नहीं आएंगे
1 minute. क्या है बेटा? प्लस माइनस आ रहा है ना, क्या है ये? ओके,
zoom in zoom out
या ओके. Button code section. Cotton. Edka idu.
कैनाल प्लान कर लूँ क्या ट्रांस कैनाल भी प्लान कर हाँ
Okay. Just let me see. I will focus it as we progress into the case. 1 minute.
Sir, we are planning post-oral approach or end-oral approach?
Post-oral only, because there is already a post-oral incision.
Okay, okay, sir.
You can see the perforation now, I think.
Yeah, we can see.
Yeah, cotton. Because there's already one post-oral incision by the previous surgery. And second, this perforation is very anterior. These are the perforations which are likely to fail, you know. So, let me see. That's a, failure is anterior. Failure, invariably, the failure is always anterior. So, let me start. I'll put the canal incisions first. Suction. For the most part, I use Dr. Madhavaya's technique with a few modifications. You can also do it endorally. My friend Sanjay Agarwal. Yeah.
Sir, you always put the canal incisions first?
Yes.
Okay.
15 knife. I've injected the area. So you can see this is my first incision. The canal incision. So this way what happens, my visibility of the canal improves.
Definitely.
Second, that is the about 12 o'clock or maybe you can say 11 o'clock incision. The second incision I'll be putting will be in the 5 o'clock or 6 o'clock position. .15 knife. So this is my second incision. Again with a 15 blade. Yeah. Double end knife. And then connect these two incisions about 3 to 5 millimeters behind the annulus. The annulus seems to be somewhere here. So double end knife. So with a curved, now a circular knife, I will be connecting this. This incision as it comes up एक्सटर्नल कैमरा है बेटा, वो कैमरा इधर से फोकस कर सकते हो या डबल एंड नाइफ. And similarly, this corner, I will elevate now. So this way, if you can get this, this is the main vascular flap in Dr. Madevaya's technique of tympanoplasty, what we call as the coroner's flap. If you can elevate it all the way above, when you come in post-orally, it becomes that much easier, right? Lampert speculum, yeah, suction please. It's important to have sharp, clean cuts. Okay?
Okay, sir.
Yeah, so this is our coroner's flap. Yeah. Now, top light on. इधर इधर लगाना बेटा कैमरा, उधर से कैसे लगेगी, इधर कहीं आना चाहिए था, नहीं तो स्पेस 0.4 पे ಕರೆಕ್ಟ್ ಆಯ್ತಾ ಫೋಕಸ್? ನೋಡ ಕೂದಲುಗಳೆಲ್ಲ ಕಾಣ್ತಾ ಇದೆಯಾ? 15 knife. Because the revision case, I am taking the graft through a separate incision. Okay?
Okay, sir.
Yeah. 3-pin retractor one. Yes, L-shaped retractor. Yes. ಇಲ್ಲ ಇದೆಲ್ಲ ಬರ್ಬೇಕಲ್ಲ ಕಡೆ ನೋಡಿ, ನೀನೇ ಫೋಕಸ್ ಮಾಡೋದನ್ನ. ಫೋಕಸ್ ಆಗಿದೆಯಾ? ಇದು ಕೊಡು, ಆಡ್ಸನ್ಸ್ ಕೊಡು. You're getting the picture?
Yeah, sir. It is not properly focused.
Focus ನೋಡ ಅಲ್ಲ, ಈ ರಿಂಗ್ ಅಡ್ಜಸ್ಟ್ ಮಾಡ.
Okay, it's okay, sir.
Yeah. Now the focus is reasonably okay?
Yeah.
Last piece. Quarter idea. Looks like we are in a reasonably good play. Double end knife. Sorry, ಇದು ಕೊಡು, ಏನೋ ಆಡ್ಸನ್ಸ್ ಕೊಡು ಫಸ್ಟ್. 15 knife. A cautery cable built there. Okay, hold this. AdSense. Mosquito.
So sometimes we infiltrate in the normal saline just below the temporal fascia.
That's also a good technique. That's a very good technique. My friend Dr. Vijayendra does that. But if you can get into the correct plane, without that also, you can do that. Only thing is the injection has to be in the correct plane.
Yeah.
If you inject it a millimeter deeper,
then it goes in the muscles.
Muscle, yeah. Then that becomes cumbersome. So if you can manage this like the way I did, that's also okay. Otherwise, for beginners, that's also a good technique. Ensure that your injection is correctly, in the right plane.
Right plane.
Yes.
Yeah, just below the face.
I've taken the graft. Yeah. L-shaped retractor. AdSense. Touch. Touch. Yeah. Cross piece. Touch. 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 Yeah. Stitch. I'll just close this in a minute.
So what are the other flap if you do is in multiple operated cases? Suppose the temporal flash is not available at all.
Yeah, see, one is temporalis fascia, Rajiv. Second one is tragal perichondrium. Third, fool's fascia. Fourth, mastoid periosteum. Fifth, fascia lata. Right?
Yes, yes.
Then rarely, if all these are not available, go to the opposite ear, harvest from there. Then now the new addition to this whole list, PRF. PRF, if you have a simple centrifuge, you can prepare the PRF with the patient's own blood, and you can make it a good membrane and graft it. Any other ones that you know, Rajiv?
No, I think in multiple cases, I think the very strong one is with 100% is that temporal mucoparietal flap. That is very good, actually.
Yes.
With the very good blood supply.
Yes. Yes. And if none of the human elements are available, in theory they mention calf, cecal serosa, pig bladder mucosa.
Yes.
I think all those things are too far-fetched.
Too far.
One of these 5 materials you can definitely get. Basically, one thing I have seen, my sir, Dr. Madhavaya, used to practice tympanoplasty since 1971. That is about 52 years back. Even now, despite extensive teachings,
Here is yes, basics are same.
the graft failures are still a substantial number in our country. Isn't it? So, revision tympanoplasties, we do a fair number of them. ये क्या है brightness है?
You prefer dry graft or wet?
I see, I've been used to the dry graft technique. But I personally believe that wet graft is far more superior to the dry graft. I have been telling this in workshops. I learned this technique in 1990. And that time, very few people were really putting wet graft. When I see Satish Jain using the fresh graft, I am very impressed. It looks very impressive to me. Ideally, I tell the PGs who are learning now to learn using the wet graft. Unfortunately, I'm used to the dry graft. I've been using it for the last 33 years. where with fairly good amount of results. Of course, nobody can claim 100% results. If anybody is claiming 100% results, he is living in a wonderland. But around, if you can get anything above 95, 98% of the graft take up, whatever technique you're doing is good. But between the dry graft and wet graft, Rajiv, any given day, fresh graft is better.
Yes, yes.
In fact, I feel when you put a fresh graft, the biointegration is very good. A dry graft probably works very good as a scaffold and still your perforations close. But if a younger PG would do it today, I would strongly recommend wet graft. I've closed that wound. Now let me go posteriorly. External camera, I think, is...
Sir, when do you think use a cartilage along with the temporalis fascia? Is there any indication from your...
To be honest, I almost never use cartilage. My colleague, very good friend Arshad uses at times. I've seen Ravi Ramalingam use it. My take is very simple. If the middlear ventilation and the eustachian tube ventilation is okay, then temporalis graft is good enough. Right? If
yes, sir.
Yeah, if the ventilation is bad, you can try cartilage, but even that doesn't work well in the long run. But in trying to remove some limited squamous epithelium or tympanosclerosis, if you have removed the scutum by yourself to get better exposure, there is nothing wrong in placing a cartilage to cover that bone which you have removed. Again, once upon a time, we used to believe in firm fixation of that cartilage. You know, like making a notch and making it fit snugly over the bone. Now that concept is gone. Now we put cartilage in such a way that it nicely integrates with the tympanic membrane. It's a little mobile and pliable. But ultimately, I feel it is all a play of middlear ventilation. One, the eustachian tube. Second, you have to stay focused on the chorda tensor fold, which can be the biggest culprit. Initially, we used to feel perforation was the disease. Now we have realized that perforation is only a secondary effect of poor middlear ventilation and various other factors. So it's very, very important that you address the middlear ventilation and then think of closure of the perforation. Then only it works well. If you address only one of the factors and don't address the other one, then we are in trouble. I have taken the graft. You can just see the graft here. You know, one portion of it is a little thin, doesn't matter. Yeah. That was the area where the previous graft was taken. 15 knife. I will use the previous post-oral incision to go down to the mastoid.
Sir, as it is a revision case, are you planning to open the antrum?
Let me see what the previous surgeon has done. Otherwise, we'll open the antrum.
Okay, sir.
Isn't it? But nowadays, again, that concept has changed.
Yeah.
We try to address the pathway through the middle. So antrum opening is not mandatory, though no harm in opening it a little bit and seeing. Cautery?
No. Sir, how will confirm the middle ear patency?
Yeah, I'll show you that, how you do that once I elevate the tympanomeatal flaps. Then we can also open the antrum if you desire. Okay?
Okay.
SMR elevator. It appears that they have opened the midlia before. Let me put the 3-pin retractor and see. 3-pin retractor. ಇದಲ್ಲ ಇನ್ನೊಂದು.
तो एक हाथ से एक नंबर
20% मस्टर्ड वो साइड आउट कर लेते हैं 30% अंदर से बाइनोकुलर करने तो कैमरा लगा लो मॉनिटर एंडोस्कोप में कैमरा लगा लो
ಫೋಕಸ್ ಮಾಡ್ಬೇಕಲ್ಲ ಆಯ್ತಾ ಸರಿ ಇದೆಲ್ಲ is the focus okay now?
Slightly better but not okay, sir.
Top light on. See.
Okay, sir. It's better.
Yeah, let me see if they've opened the mastoid or not. Maybe I'll go to one step higher. Let us see. SMR elevator. It appears that they have not opened the mastoid.
Yes, yes.
Yes, sir.
Right?
Yeah.
Yeah. So this was our coroner's flap incision. Yes. Pottery. You can see this. ಎಷ್ಟಕ್ಕಿದೆ ನೋಡು कितना है काट्री बेटा 60 75 ಕ್ಯಾಟ್ರಿ ನೋಡ್ಕೋಬೇಕಲ್ವೇನೋ ಮಣ್ಣು SMR elevator ಕೊಡು.
Sir, I think you must have done so many revision cases of others and few of yours also. So if you think of 100 cases, what are the 5 most common causes where you find that this is the cause, this could be the cause, this could be. So what are the 5 main causes of graft failure or ear surgery failure? I mean,
Generally, according to me, the first cause, mid-ear ventilation. Second cause, in the anterior 180 degrees, if you have not placed the flap properly onto the bone, and the old tympanic flap has come on that. Number 3, poor vascularity in patients who have undergone radiotherapy or something like that and poor health. Some cases, if you have ignored an adenoid in an adult, because you think at that age they won't have the adenoid or whatever. And number 5, sometime mastoid reservoir of disease. But if you ask me, the commonest one is the mid-ear ventilation. And number 2, proper exposure of the undersurface of the perforation and grafting.
Yeah, it's like
Rajiv, you can add, because I may not be knowing all the answers. You are yourself a punter.
so maybe infection, I think, is one more common cause which we
Yes.
get in our.
ಒಂದು SMR elevator ಕೊಡು.
And the technique also, of course, the interlay as.
Yes. Any technique, the technique should be done well.
Yes.
That's important. It is never a fault of the technique. It's not that underlays will fail or onlays will fail. No. I feel any technique, it is the question of how you do the technique.
So do you do means culture in few of select recurrent cases? Suppose we get a discharge very often.
Yeah. See, especially if there is Pseudomonas,
Yes.
you have to be careful, you have to be really careful.
So what is your protocol for Pseudomonas? Suppose you get a culture, Pseudomonas.
Pseudomonas, better to give some injectable antibiotic. Usually a ciprofloxacin or meropenem works. Better give it for 14 days and then take it up.
Yes, sir. Recently, Miss Meropenem followed by Ciplox tablet is a wonderful.
Yeah. See, again, Ciplox tablet in healthy individuals. If the patient is a diabetic, no, these diabetic people may not have good gastric absorption and intestinal absorption because they always be having some degree of microangiopathy. In those people, better give IV drugs, Rajiv.
Yes, yes.
In younger healthy adults with Pseudomonas, you can always give oral tablets also.
Sir, IV for 14 days.
Two of the organisms which you have to be careful is Pseudomonas and the second one is Staph aureus.
Staph aureus.
Because these two drugs are notorious for causing biofilms and they can spoil the result of your surgery. See, I am first doing the canalplasty because after you do the mastoid, then you try to do the canalplasty, you may not be left with much of a bone. Okay?
Okay.
Can you see that spike I removed so that we can visualize things better? You're getting a good view, I think, now.
Yeah. It's better than before.
Yeah. Maybe let me go to one step higher. Yeah.
So focus.
Yeah.
More fine focusing needed.
Let me see here.
Just
tell me when it is correct. For me in the monitor now this is correct, alva? Edge of the perforation.
It's okay, sir. It's okay now.
Yeah, can you see the edge of the perforation?
Yeah.
You can see one ball here. Yes, that I removed now.
Okay.
Smooth curved pick. I think, smooth curved pick. Maybe I can just about. Oh, this is really a sclerotic ring, quite a sclerotic ring here. Micro scissors.
Yeah, I think you have to take this is I think old graft. It looks like old graft.
Yeah, that's the old graft. And this seems to be the neotympanum, smooth curved pick.
I think you have to make it a large perforation. I think we should take out everything. Make it a total.
Because it's very sclerotic. There seems to be this kind of, I don't know whether it's a tympanosclerotic plaque or the handle of the malleus which has got devascularized. This let me not touch right now, Rajiv. I think I'll just micro scissors. This I suspect could be the malleus as well. I think let me elevate first. .15 knife. Let me put a antero-inferior incision here. Imperometal flap incision, and then let me put one more incision here. 15 knife. The retractor is coming in the way. 1 minute. Sharp mastoid elevator. Yes. Okay, retractor now. Yes. $15 knife.
इतने सब नहीं दिखते हैं बॉम्बे वाले
This is a superior tympanomeatal flap incision.
वो लोग इधर नहीं आते हैं
Okay.
Okay.
Double end knife, because let me see the middle ear. I have a feeling this could be the malleus, which is attached to the edge of the drum, and trying to just put a wide incision. Let me make sure whether it is a the graft put previously, or is it a tympanosclerotic plaque, or it's a hypermobile malleus in the surgery which has come and got attached to the tympanic edge. So I better go this way. I think I can see a glimpse of the chorda.
Yeah.
Important, smooth curved pick. I think I can see a glimpse of the chorda now.
Yes, sir.
Just a glimpse of it. So let me just see. That seems to be the chorda.
Yeah, it's
Yes,
chorda.
I think I'm seeing the round window as well.
Yes, yes.
Yes.
I think chorda is the most.
I can see the promontory. Right?
It is the most neglected nerve in our ENT. Nobody take. I think we should preserve in all the cases, I think.
That you can do when you're a Rajiv Pachori, but there are so many Deepak Haldipurs. Double end knife. Problem is, Pachori, not all are extraordinary otology surgeons.
So what are the points to how to preserve the chorda, sir?
First is to identify it. Second, in your mind's eye, you should know in which angle is it going and try to dissect parallel to it. Let me first see whether I can preserve the chorda in this case. I speak like an authority, and then if I am unable to preserve, but anyway, Rajiv is in the audience, so no problem. He can always help me if I'm in trouble. Smooth curved pick. Some small mucosal adhesions from the previous surgery. Cotton, please.
Sir, fine focus.
Yeah, let me do
focus.
just
Focus.
focus, madam. I'll not come. One minute. Just 1 minute. Smooth curved pick. 1 minute. Can you see the chorda now?
Yes, sir.
Going underneath the malleus.
Yeah.
So somehow, luckily, we have preserved it.
Okay.
And I think that part which was attached to the drum was the malleus, Rajiv.
Yes, yes.
हाँ, old graft करके हटाते तो ज़्यादा नहीं थोड़ा मुसीबत होता है. I would have shown a osteoplasty also. Now, let me see if I can go to maybe 1.6 and ಇವಾಗ focus ಮಾಡು ಮನು. ಒಂದು ನಿಮಿಷ ಇವಾಗ ಕಾರ್ಡ focus ಮಾಡು. ಒಂದು ನಿಮಿಷ. You can see the corda?
Yes, yeah.
Yes, okay. Smooth cut thick. Let me remove the mucosa from the notch of Rivinus. Yes. I'm happy with my dissection so far. I hope, Rajiv, you're also okay with it?
Yes, sir. Perfect, sir.
Small side knife, yeah. Huh? Double end knife है कोडो. one निमिष. टेबल थोड़ा उस तरफ टिल्ट करोगे हेड एंड. 1 मिनट अभी नहीं. मैं बोलता हूँ 1 मिनट. डबल एंड नहीं अभी नहीं. अभी कुछ मत करो. This is my superior tympanomeatal flap incision.
Yes, yes.
Which I am elevating. Small circular knife idea. The mid-ear ventilation pathways seem to be okay, Rajiv.
Yes.
Looking at the state of the mucosa. But anyway, let us check after some time. 1 minute. Smooth cut thick. So now we are near the neck of the malleus.
Yes.
I must confess the malleus is a little hypermobile.
Little bit, yes.
Yes, and here you get the cartilaginous cap of the malleus.
So what exactly are you looking in the middle ear, seeing which you decide whether to open the mastoid or not?
First thing is look at the middle ear mucosa.
Okay.
It looks
See how it looks now?
Yes, sir.
And I will check this pathway here, pathway posterior.
Okay, sir.
Okay. Double end knife.
So do you ever ask for a eustachian tube function test when you're taking patients for revision cases?
Yeah. See, impedance always.
Okay.
If the impedance shows AS type.
Yes,
yes.
sir.
But the question is, after you know, what are you going to do about it? Do we have any solutions other than the debatable eustachian tuboplasty?
Yes, sir.
Yeah. Which seems to benefit the instrument company fellow more than the eustachian tube.
Yes, sir.
Yeah. So other than that, yeah. I think you can see the eustachian tube area there.
Very clearly.
Yes,
Yeah.
sir.
The mucosa looks very good, Rajiv.
Yes, very good.
And good that we didn't, kind of, because see, look at the hypermobility of malleus. Yeah. I would like to look at the IS joint as well. Curate. So, you can remove a bit of this bone.
Yes.
Near the notch of Rivinus, Rajiv. Smooth cut pick.
When do you decide to
Well, this is the corda. So ಡ್ರಿಲ್ ಕೊಡ್ತೀಯಾ ಚಿಕ್ಕ ಬರ್ಟಿ ಹಾಕ್ಬಿಟ್ಟು ಕೊಡ್ತೀಯಾ
He said balloon. No, no, he doesn't. He said the benefits the other.
ಚಿಕ್ಕದು ಇನ್ನೂ ಚಿಕ್ಕದು ಕೊಡು ಅದಾಕ
There is a concept of removing each and every bit of mucosa from the handle of malleus. If it is
yes, that is in total annulus excision.
Yes,
I am a big proponent of total annulus excision, and in that case I meticulously remove everything. In this case I am not going to do it for two reasons.
because
The malleus is hypermobile.
yes,
Second, if you notice when we started the case, you didn't find even a bit of granular myringitis. Did you find anything? No.
yeah, in the posterior half.
Yes. So see this? Can you all see the incus? 1 minute. I'll focus it for you.
Little bit, you can say.
Little bit is enough.
Yes,
A simple case like this, no need to expose it, like Aishwarya Rai is fine. No Sunny Leon. Ball probe. See, I can feel this. Can you see the movement?
Yeah, very much. Leave it.
Now look, I am going above the tensor tympani. One pathway check.
Yes.
Tensor fold vertical component. Tensor fold horizontal component I am checking here now. Okay.
Yes.
And you can go here also posterior to the incus and check. This case actually doesn't require a mastoid.
No.
But I will put a small control hole only for the postgraduate sake. Right?
You can do wash. Yes, sir.
Routinely, yeah. Again, you do the wash if you find a lot of mucus and glue. Okay? This seems to be a clear-cut case of graft failure. Okay, and I've taken the meticulous step of preserving the chorda, micro scissors. If possible, I like to keep it preserved. Okay? I'm just taking away those bands because that could complain. So the chorda is fine. Right?
Yes, healthy also.
Yeah, healthy.
So I really liked your concept of checking the mucosal pathways in the middle ear. If
You have to.
That's a very wonderful concept. Very few people actually press on that, because most of the time everybody says, okay, fine, there's a graft failure, do a mastoid. Nobody actually looks into the middle ear pathways.
And it's not rocket science, nah. Just take a ball probe and poke it in 3 places without dislocating the articular chain.
Yes,
That's
sir.
all.
So if these pathways are blocked, like if you feel that there is a polypoidal tissue or there is blockage, then
open the mastoid.
Yes. No, even opening the mastoid may not be required. Put in an endoscope. Put in an angled endoscope and clear the blockages.
Okay.
Yeah.
Okay.
So what we are doing, sir, we are taking one needle, making it right angle, tip bit on the right side, right angle,
and then wash.
Wash with the the needle.
Now, Rajiv, curved instrument suctions are available with Santosh Surgicals. So you need not even take a needle. Ila idu kodu, small circular knife kodu, athwa double end knife kodu. But in this case, I am pretty happy actually. Double end knife.
Sir, I would like to ask, what's the name of the mastoid retractor that you're using?
Oh, this one, you mean the one which I've placed now?
No,
Dr.
the mastoid.
Madhavaya sir used to call it as Burkin's cheek retractor. This instrument is actually designed by him.
And it's from which company?
Surgiments, Bangalore. But now everybody makes it. I think it's available with Santosh, with Kalelkar. I don't know whether the teeth, the prongs are also attached to it. He would call it as Burkin's cheek retractor, but we would use it as a mastoid retractor. I think I'm pretty happy with my elevation now.
Yes.
Let me just probably see, Raji, because I need to ensure that this whole graft correctly sits on the bone. That would be very, very important for me.
For television, only for vision case or small case?
Yeah. Cotton.
Sir, you've elevated almost 270 degrees. So, 360 degrees. Okay. So in all cases you do this, or only for the vision cases?
No, all cases, all cases.
Okay.
I want my graft to lie on the, bone all around. I feel very assured that way. All cases I do this.
So have you ever had a case of flap necrosis, tympanomeatal flap necrosis?
100%. Any person who has done more than 500 tympanoplasties, every human being will have it. If somebody has had, he says he has not had it, he is lying.
So then in those cases, what should be done if we get a tympanomeatal flap necrosis?
Yeah, create a different, go back for a revision, create a good vascular flap, and then regraft again. ಸ್ವಲ್ಪ ಚಿಕ್ಕ cotton ಕೂಡ. See, there is only one synonym to the word surgeon. It's called complication. Okay? Every surgeon, whatever may be the technique, God Almighty, will have failures, will have complications.
Sir, I'm asking about the flap necrosis. Can we get a flap necrosis by elevating so much of it?
No. In fact, Mario Sana removes the entire flap like a circle and places it back.
Very vascular.
My theory is, if you can keep it attached somewhere, and it is attached here, no, beta? Isn't it? See, it's only elevated 360 degrees, but look at the attachment here. Can you see this? It's not coming off in my suction, is it? No.
Yes, sir. Yes, sir.
See here, from here up to here, it is attached. It is only elevated inferiorly or medially, whichever way you would put it. So this will not give rise to flap necrosis. The only thing I am slightly unhappy in this case with my technique is I would like to denude the malleus little more than what is done here. Okay.
So I think best for the solution for this could be just make a nick in the graft and sleep through the malleus, so that malleus will remain open actually. So
that I will do, Rajiv. But even then, in those cases,
it's very mobile.
You can get granular meningitis. The problem is
very mobile.
Such a hypermobile malleus. I'm only scared that it may come out. And I don't want to give too much of play onto the stapes.
Yes.
Which itself can cause some amount of SN loss. So, and in this case, because I didn't see granular meningitis, it's not that this patient will go for granular meningitis, not necessarily. But sometimes, you have to compromise because they see the mobility.
They get some peeping drum during rainy season also.
Yes. So should I open the mastoid or no?
No, I think not needed.
I think not required. According to me, not required. Again, one final time, ball probe. I want the postgraduates to realize, see, this is the attachment of the tensor tympani. This is the tensor tympani tendon. Okay? Go above that. See here. I've gone here. It can be seen, the probe can be seen moving here anterior to the malleus. Okay? The second one, you see the vertical component here. Here also it is going in freely. Right? And third, of course, you go here, posterior incudal space. These three you check. Graft, top light on or 20 minutes. Gel form ready, yeah.
See this malleus in this also, I feel like
Hello?
Yes.
I think we shouldn't be opening mastoid in this case, Rajiv.
Not needed at all. Not needed at all, sir.
Yeah.
Sir, I would like to ask one question.
Ask you, no problem.
If there is a fibrous continuity between lenticular process of incus and stapes,
Yes.
would you try to remove it and then rebuild the ossicular chain, or
if there is
it's not a bony discontinuity?
If there is a bony discontinuity and there's a small fibrous attachment between the incus and the stapes head, then definitely you have to go for ossiculoplasty. Either like Dr. Minesh Juvekar, you can use bone cement, augment the tip of the incus and make the joint continuous. Or as Dr. Pusalkar does, you can put the titanium prosthesis. Or the simplest thing what Dr. Madhavaya taught us, take a cartilage from the floor of the canal, shape it and put it on the stapes head.
It works very well.
If the midlear mucosa is very clean, as in this case, and if the incus is necrosed, you may not even remove the incus. If the midlear mucosa is thick, you find glue in the midlear when you are dissecting, and when you are washing the attic. If the incus is eroded, better remove the incus. And remember one thing, removal of incus will not cause retraction. And retaining the remnant of incus will not prevent retraction. In fact, a damaged incus, when you remove, the midlear ventilation improves a lot. So you, on the contrary, get a good ventilated midlear. Okay? So it's very, very important that you keep looking at the midlear mucosa and the midlear folds.
There's an AB gap of 20. What about audiogram, sir? How much?
Audiogram, the
20
around 40 dB or something.
40.
Anyway, you would look at ossicular discontinuity if
Yeah,
you're
it's
looking
good.
at 60 dB.
Well dry.
Yeah, very dry. Top light. इधर फोकस करो बेटा कैनाल के ऊपर. Let me see. This Raji fellow coming on the other side of the mic makes me very, very nervous.
No, sir.
He's a very prolific otology surgeon, cochlear implant surgeon, a very good friend of my guru, Satish Jain. I think Satish is in Nandyal today.
Yes, yes.
He's demonstrating there.
At 10 o'clock position.
So, yeah, gel foam press. Actually, Rajiv, I thought there was a thick round sclerotic ring that Melius initially mistook it for a continuation of that mild tympanosclerotic ring. And here the tympanosclerosis is also not mature.
Yes,
it is a semi-soft variety, you know, like a thickening of the tympanic membrane.
Yeah, could have been because of infection previous infection.
And the two layers of graft plastering together, whatever. So, alligator forceps. Straight pick, smooth cut pick, gel foam. 22 section kodo, ಎರಡು ready itko. Smooth cut pick. I use gel foam soaked in Ofloxacin, dexamethasone.
You keep in the middle ear also, or just
Middle ear. I fill it up. I fill up the middle ear. The only contraindication is your middle ear mucosa should not have a lot of injuries or raw areas. Then gel foam, promotes additions. But again, keeping the gel foam is not a must. You can graft without keeping the gel foam also.
yes, yes.
My guru Satish Jain does that. Rajiv knows it very well. Probably Rajiv also must be.
And what about putting silastic or cartilage in, if suppose there's a middle ear is very not healthy actually?
Yeah, you can put a thin silastic or maybe a thick silastic. Important thing is you have to place the silastic well. It should be kind of convex so that the edges don't touch the tympanic membrane.
Membrane, yes.
Yeah. If it sits concave, then it's a problem. It can touch the tympanic membrane and extrusion can happen.
And do we need to take that silastic out in a second look surgery?
No.
Not necessarily always. No. A well-placed silastic can be kept there alone. But suppose like Europeans, if you plan to do a second look surgery or a second stage osteoplasty, then you can take it out. Okay? There are a lot of surgeons who do a second look surgery, either to look for sometimes a recurrent cholesteatoma, or some people believe that they would like to do the osteoplasty after the middle ear is healed well. In those cases, definitely you can take out the silastic. But if it is not giving trouble, it's not mandatory that just to remove the silastic, you have to do one more surgery. A well-positioned silastic will never give trouble. You can mention it in your OT notes, but you can leave it at that.
Sir, what is your opinion on tympanosclerosis involving the middle ear, the medial wall of middle ear? Sometimes you get the whole wall is chalky. So what do you do in such situations?
If it is contributing to hearing loss, if the patient is a young patient with bad hearing, and if you are confident that you can dissect it without displacing the Stapes footplate, go ahead and do it. If the ossicular chain is mobile and you just find that there's a mosaic pattern and the whole middle ear on the medial wall shows tympanosclerosis, leave it alone.
Okay.
Don't create more trauma.
Yes. Thank you, sir.
Yeah. So it's not that the moment you see tympanosclerosis, you have to do something. In fact, some cases, my chief, I have seen Dr. Mahadevaya, if there was tympanosclerosis but not involving the ossicular chain, he wouldn't remove it. No, he would leave it as it is. It's not that the moment you see tympanosclerosis, you have to chase it down, even if it is not giving trouble. In fact, in novice's hands, removal of that could be more damaging, You should make sure that you are a reasonable expert before you play around with tympanosclerosis.
Yes, sir. Thank you, sir.
Yeah. Nothing wrong in touching it.
Yes, sir. I did have.
Yeah, if you have a if you're a Rajiv Pachori, you need not worry. Just go ahead, remove it.
Yes, sir.
If you are a medium surgeon like Deepak Kaldipur, think twice. Take time. If you feel it's worth it, do it.
I think we need to sit together for some time, sir.
Rajiv, this is the notch I made.
Yes.
You can see that. Manu suction work ಆಗ್ತಿಲ್ಲ ಕಣ ರಾಜ. ನೋಡು ಒಂದು ನಿಮಿಷ ತಡಿ ನೋಡ್ತೀನಿ. Block eyes. Then 20 na estido 22 na. So I took the notch underneath this, Rajiv. That V notch which I created.
Yes, yes. Beautiful.
And now I bring it like this, bring it up here. And similarly, the other end, if you bring it up, okay, then it is called the double breasting or garlanding or whatever you can call it.
So many names are there.
Yes, names and names and names.
अच्छा वो तो नहीं है
Yes. Lock idonu matte. Still itilva.
Hello. Managing sir, then there is any disadvantage by keeping the graft over the handle of malleus?
The graft can get lateralized, no, if you keep it over the handle of the malleus. Because that is one of the problems of the onlay technique, which is why the best thing if you can do an interlay is a very good technique. Okay?
Yes.
Can you see the malleus there?
Yes, yes.
Yeah.
Can you see my graft going underneath the malleus? This is the edge of the graft. And can you see it go near completely nicely underneath?
Yes, yes.
Now I'll bring it up a little bit here. Yeah. We can even build it up a little bit. We can put one more piece of gel foam here and build it up. Yeah, small gel foam kodumanu.
Oh, 230.
Yeah. ಇಲ್ಲಿ ಕೊಡು. ಬಿಡು, ಇದು ಸ್ವಲ್ಪ ಚಿಕ್ಕದಾಯ್ತು. ಇನ್ನೊಂದು ಕೊಡು ನೋಡೋಣ. Yeah, one more. That's it.
That's it.
See how the graft is sitting nicely over the ear canal.
Yes, yes.
You can see the malleus. You can see it is lying nicely on the bone here. Completely this end is coming up here on this side. This on this side. And then you place this back. ಮತ್ತೆ ಇದು ಬ್ಲಾಕ್ ಆಯ್ತು ಗುರು. I think this time there should be no problem, Rajiv.
Yes, yes.
This patient should do well. It was a small perforation. The bottom line was to
Pathology.
yes, and also to see that This was grafted well. This bit of soft tympanosclerosis, one piece is here, but it's a soft one. So I won't bother too much about it because the malleus is here. Things are sitting nicely. This covered well. Yeah, gel foam.
Old hand.
In this technique of externalization of malleus, you won't get anterior blunting. Okay? You can put a flat gel foam, dry gel foam, round gel foam, that doesn't matter. What is important is the canal skin should go back to its original position.
Yes.
Yeah.
I think wonderful surgery wise you, sir.
No, only couple of things I was happy, Rajiv. One is while widening the perforation, luckily we didn't dislocate the malleus or whatever. Number two, I could preserve the chorda. Looks quite neat and clean. In revision surgery, sometimes when you are elevating, you can tear the chorda.
Yes, yes.
Number three, we could check the pathways. Number four, exteriorization of the malleus.
Yes.
Number five, the middle ear mucosa assessment. Number six, despite being a revision, we were not tempted to open the mastoid unnecessarily.
Unnecessary.
Because it was not required in this case. However, there is no harm for beginners to even open the mastoid as long as you again don't give complications. Trying to do that, you get into dural plate or sinus plate, then you will always feel, array, it was originally unnecessary. I shouldn't have done this or whatever. That's the whole thing. Rarely I have seen. Again, I don't think it's the fault of mastoidectomy per se, but young surgeons damaging the lateral canal, rarely the facial nerve, or covering a simple small perforation. That's a little too costly a value. But again, it's very important that all surgeons are very well versed with opening the mastoid, because that becomes the approach to lateral skull base, glomus, cochlear implant, so many other things. So not to be well versed in mastoidectomy is a dangerous precaution.
Yes, yes.
Yeah.
Thank you, sir.
Yes, boss.
And this patient will get a very good result as well as good hearing.
Hopefully so, hopefully.
Yeah, 100%.
Lampert speculum, SMR elevator, gel foam with ointment.
Yes, sir, we have other case, something else in the other OT?
Yeah, one rhinoplasty is going to be there. And I'll be showing one stapes also.
Good.
Stapedectomy, yeah. But Rajiv.
Yes, sir.
Pleasure to have the three of you moderating and asking questions, because when a good otology surgeon is on the other side, we can always have some discussion. No?
Yes, sir. Thank you.
I know you don't need to learn anything from me.
No, sir. Everything. Every case give us so many things to learn.
But at least you will learn how not to do it also.
No, sir.
Gel foam with ointment.
Announce कर सर दे देना चेयर पर
So I now request Dr. Puneet to give memento to our chairpersons, Dr. T.S. Chaudhary sir and Dr. P.N. Verma sir.
I thank Dr. Chaudhary sir and Dr. P.N. Verma sir for chairing this session. Absolutely. Yes, boss. Absolutely. Cotton?
Hello. Hello. That is a better angle. Sir, आपका angle खराब हो गया था.
So next we have Next, we have lecture by Dr. Rajiv Pachori on do's and don'ts in rhinology. To chair the session, I would request Dr. G.S. Saxena sir and Dr. Smita Soni.
Since yesterday,
one triangle hand piece idya avar hatra kelu.
Since yesterday, we are seeing sinus surgery as well as ear surgery. So I think most of things been covered so far. So I was sitting here and I was just editing what not to show. So everything has been covered till now. So I think few things are left, few points are left. And screen share. So you want, we have do's and don'ts in otology and do's and don'ts in CI and do's and don'ts in rhinology. What do you want, rhinology or ear? Rhinology. Dr. Jay, Miss, 1 second. So this is about the rhinology. All the things been covered, most of the things been covered by Dr. Janki Ram. So few surgical, these are all videos, nothing like you can say slides and everything. Surgical tricks and tips in rhinology, and it's just like when we travel a long distance, every road, everything has a turn and every turn has its significance. Same thing happened with our surgeries, like whether your ear, nose, throat, whatever. But and each and every step we do mistakes and we learn from those mistakes. And a few mistakes which we have done in our practice, I would like to share, and I would like to suggest few points for all of you. So few things I would like to keep in, especially those PGs and those who are starting in ENT, that never ever go for these videos, these made videos by the companies, and you like where you're going for Rhinoplasty, tonsil, mammilloscopy, larynx. Don't go for these things and then you start surgery directly on the patient. Always have a, you can say, on-hand training with the instrument and on the patient. Then you should go for the surgery. That is the basic point before any step you take. Pre-op preparation, which we do in our all the cases, we have a list of all these pre-op 1, 2, 3, 4, 5, 6, 7. But with few things which we should keep in our theatre is that we should keep your theatre atmosphere very cool, calm, and if you are fond of music, then you should have never scold your staff before surgery, because every surgeon does the mistake, and that is your staff who correct on table. Suppose you tied them beforehand, then they will not help you, they will not cooperate very well in you. So have a very good atmosphere. Keep whatever you are fond of is doing your theatre. That is second step which we do, whether you're doing surgery under local or GA. Ask your patient to go for urination before surgery. In fact, you should also do the thing before the surgery, because it may take a lot of time to, so it gives a controlled blood pressure. And never keep no time limit, never keep pending work before starting any big case or any case, whether it's a stepage, whether you're in fast, anything. So be free before doing. This is a very, this is the original recording almost 25 years back. And like we see HD movies, but just think about the black and white time. and we enjoy that black and white time also. But because of the black and white movies, now we are enjoying the highest grade of the surgery. Same thing is, this is my recording on 2001. And when we used not to have the good endoscope camera, everything, and we used to do surgery like this. We have changed, we have evolved ourselves in last 20-25 years. So this reminds that how far we have come across, and as a result, you can assume that at that time, what was the result? Now we are getting good result because of we have changed ourselves as per the time. But still, don't think that we have done a lot. It's still a long way to go in sinus surgery, whatever surgery, because today this is our rhinology, but same thing that we have to go a long way, and we have to learn each and everything. Keep in mind, keep basic principle of any surgery. Like this is a case being operated 2 to 3 times for chronic rhinosinusitis with fungal sinusitis, and everything is being removed. Male terminate, infant terminate, and even septum being removed. This was a case of AFRS, CRS. But basic thing that nothing, the basic thing is still there, that the the maxillary osteum is still there, and which is causing mucosal movement around, and the patient complaint is still saying that he is having recurrent, of course, nasal obstruction is there, but recurrent post-nasal drip is still there. So keep in mind that you should follow the basic principle of any surgery. Again, the new concept, like we discussed with Dr. Jankiram an hour back, follow the basics. Now, the concept of cutting, trimming the middle terminate, trimming the inferior terminate without checking the maxillary osteum. In this case, we can see pointer was light pointer. The uncinate is still intact. The surgeon has removed everything, but see the uncinate is still there. How can you expect that this patient is going to get a good result? So you can see uncinate process is still there, and surgeon has removed everything. So it is not the debulking of nose. You are doing sinus surgery. It is not the debulking of it is the clearance. You have to maintain the mucosa, take out, open the sinuses to get a perfect result. That should be the main goal of the surgery. Follow the basic again. Since morning, yesterday, Janki also, we were discussing point. Respect the mucosa. Don't touch your instrument. The basic point that he didn't even use the suction during surgery. That is the reason, because if you use the suction, if you use the instrument without knowing the anatomy, without you just make your endoscope dance in the nasal cavity, you get mucosal damage that can cause the recurrent, you can say synechia, and just see, even after a perfect surgery, so-called perfect surgery, it is a worst complication, worst sequelae a surgeon can have that lateralization of the middle terminate. Why this lateralization to happen? You have to keep in mind that it is the excessive manipulation of your middle terminate, remove axillary flap, so-called axillary flap tracking, removing the ground lamella without taking care of the mucosal tags. So ground lamella and axilla should not be disturbed without any intervention, without any indication. So follow basic principle, know your instrument before whatever purchase you are purchasing instrument. It has happened in one patient. I got 2 cases. You purchase the debrider, but you don't know how to use it. And the case, the Ella was totally gone because the surgeon introduced that debrider while it was on. So he just cut the Ella. Same thing, what is your limit of instrument? Because you should know that debrider should not be used at this place, because fat he's taking out the fat. This is for the chorda, because the microscope, the light source was very heavy, so he damaged the chorda. Same thing had happened if you use a long light source in our sinus and in the endoscope, etc. Your armamentarium, your voice instrument which you have should be your own. It should not be borrowed by someone, and you should know how your instrument works, which instrument is for what purpose. Like, keep your instrument up to date. Never borrow the instrument because you don't know, because he's trying to cut the terminate, and it is a seizure, but it is a non-cutting seizure. So you should know how your instrument is working, whether it is out of date now, when to change it. So never play with any surgery without after getting instrument from others. always do a detailed because this is one thing we do lots of septoplasty, and even in spite of very good septal correction, patient has same complaint. So whether you're doing septoplasty in a local or GA, always do a patency, because many of times we see the spur, but beyond the spur we get accessory maxillary osteum, and the incidence is almost 10 to 15% in post septoplasty cases. They come to us when we do an endoscopy because we see lots of accessory osteum in these cases, and so we should check beforehand. And there are so many types of osteum, because these are frontal, anterofrontal, postfrontal. So you should do and take while doing septoplasty. You can do under local, but always do a check endoscopy. Even you can miss these things in CT scan. So endoscopy is must before taking patient for any septoplasty or non-fast surgeries. And Denkers, yesterday we discussed, because post-COVID, now everyone is doing Denkers with so many instruments are there using the debrider, everything, but you should know the basic principle, what exactly is Denker, what are the complications. So always it should be bloodless. Use drill, never try to break the bone with your chisel hammer. Even suppose if you are using the chisel, never cut the lower bony attachment first, because once you take out if you remove the lower, then it becomes a floppy hypermobile, and it can damage. It is very difficult to take out that bone, and 100% you are going to damage the NLD or the frontal process of maxilla, and that can damage the cosmetic as well as some few complications. So keep in mind these things and be careful, because yesterday again same thing happened, that so you should know where exactly what should be your limit in Denkers, because these are three cases, and this picture I have borrowed from Dr. Haldipur, I think, because somewhere it was there. And never CT scan or MRI, you should just discuss in detail. You should know exactly how is the pathology inside, and especially like simple example is the thing that if in AFRS, always look for where exactly is the anterothoracic artery, because a hanging or you can say hanging anterothoracic is very common, and these are the cases where you can damage it. And so there are so many points you should see in the radiology. So this is a hanging, and after dissecting everything, you can you find it out exactly, and if you want to cauterize it. But never, even I would advise never leave it open there, because once you clean the nose, sometimes the chances of damage are there. So you can bipolarize it, but bipolar not to use goblet tray as well, and not to use unipolar at this level. Regarding the post-op nasal cavity, and if you are playing with the middle turbinate and you feel that you have to take out the ground lamella or axilla, then always try to stabilize the middle turbinate by any way, whichever way suits you. Bulgarization is there. So many things are there. I think this is the simplest way. You can suture your middle turbinate both the sides, and it takes hardly 3 to 4 minutes. Special forceps are available over there. You can use normal forceps, and you use Vicryl for this. In after 10-15 days, the Vicryl gets dissolved, and you can get a perfect. So these are the because if you see the endoscopy picture right now, it should be the outcome in a properly done phase where it is not hampering, it is not blocking your smell area, everything is under control. So never have a hitch to bipolarize stitch that area. Otherwise, if you do not follow this principle, again you are going to see the video picture endoscopy in your post-op cases. And second thing, again after phase, or if you have missed in CT scan, always do nasal examination and nasopharyngeal examination, and many of the time you may find adenoids over there. Again, you have everything with you on table. Take out the debrider, take out the adenoids, because to get a better results, you can do adenoidectomy on table, and don't do blindly, because the main purpose over here is that it is a nasal blockage. So targeted clearing of adenoid is must for better outcome, whether there's ear symptoms or they're not. But you should take out the adenoid on table if needed. Again, like ear surgery, like you take care for CI surgery, like for stapes. Always prepare your patient like you are doing ear surgery. Clean the nose, you beat it in. Don't do that. Nose is already infected. Why to take a proper asepsis? But always do proper antiseptic care pre-operative, even post-op. Should do regular nasal cavity check examination because these are the biofilm. In spite of getting good radiological clearance, you may get a symptomatic patient. That's why, and give a proper antibiotic coverage, regular checkup, regular cleaning is must for these cases. DCR, I think, I just removed 3 or 4 slides, but this step, just see. If you want to have a perfect DCR result, see the hand movement of the surgeon, and it is very crucial step, but it will make your surgery very smooth and without any complication. No need to play with the bone, no need to drill the bone. Just Karan, his lecture, you can come already there. So just see this step. Take out this bone, lacrimal bone in single take, and you can see the sac as well duct very clearly. So chances of post-op adhesion, chances of we are not putting a stent in all the cases except revision cases. So keep few steps and follow these basic things, all the surgeries. And these are very common in our practice that we get regular recurrent epistaxis cases. And if it is more coming to you more than 3 to 4 times in a month or in a year, then always go for nasal endoscopy under GA. And we see many cases of this multiple telangiectasia cases, and these are rewarding cases. Just take their opinion, take their consent, and do the nasal endoscopy, and you can get the better results. So, but here, do's and don'ts doesn't work because it can happen in any sinus surgery, ear surgery. So it is not in hand, but keep always, whether doing any surgery, keep the darker side in your mind, any complications before taking in. So you will be a perfect surgeon and be on the better side. Thank you very much, because I have to finish in because I have to, and he has to finish it up. There's so many videos are there, but I will stop right now. Thank you very much.
Rajiv, for enlightening
Come, who is
tips, tips for do's and don'ts of rhinology surgery. Thank you, sir.
Thank you.
Thanks.
They're almost
Important for not only for PGs, for senior and junior surgeons also. But there is one thing I just want to add. There is no replacement of pre-operative history and examination of the patient, which one should always.
Of course,
keep in mind.
pre-operative, that's why there are so many things we have to keep in mind pre-operative, but that is the most important thing, pre-operative preparation and
Thank you, Dr. Rajiv, for a lovely lecture. I request Dr. Sachin Nagre from Aurangabad to felicitate our speaker, Dr. Rajiv.
who else? Kiska hai?
Something to. Small injection. This is not. Where is it? Yeah. So tell that this is not
Dr.
the Botox.
Sachin, to
this is
please
only the
felicitate our
silocaine.
chairperson,
Right now I'm
Dr.
injecting
G.S.
only
Saxena and Dr. Smita Soni.
This is not the Botox. This is. Hello, can you hear me? Oh, sorry. Yeah. What is it?
So now we have Botox injection case, and to chair the session, I request Dr. Rajbala ma'am and Dr. R.S. Joshi to please come.
So now Yamini sir is injecting xylocaine. Can you see that?
Don't worry. Nothing.
Hello?
Not that.
Hello?
Don't worry. Nothing.
Hello.
Hello.
OT. We
Yes,
are with
Oti,
you,
can
sir.
Yeah, this is the case of spasmodic dysphonia in which Dr. Jaykumar is injecting
Silocaine.
Botox. Right now he is injecting xylocaine, right? Hello?
Hello, hello.
Can you hear us?
Yes, sir, we can hear you, sir.
This is the case of spasmodic dysphonia, which you have seen when the Dr. Jaikumar was doing flexible laryngoscopy. Now we plan for Botox injection. So he has already marked the area and he has given the xylocaine there. And now he will put the Botox injection. He will show you how to take, how many units he is going to take. Everything he will show you. Sir, please, over to Dr. Jaikumar.
I think first you can show this. This again I have marked now all this area. You can see that that is the hyoid. So when you do the injection, it is better to do in extended position, because when you do the scopy, patient has the tendency to lift up the neck. So this is the superior thyroid notch. This is the lower border of the thyroid cartilage. This is the upper border of the cricoid. So you draw a line along the lower border of the thyroid cartilage, and just 3 millimeter above is the thyroplasty window. That corresponds to the vocal cord. It is better in a female, it will be 5 millimeter from the midline. In a male, it will be 7 millimeter from the midline. So I will tell again, superior border of the superior thyroid notch, lower border of the thyroid, upper border of cricoid. So you draw a line along the lower border of the thyroid cartilage, and just 3 millimeter above is the surface landmark of vocal cord. You draw some 10 millimeter into 5 millimeter rectangle, 5 millimeter from the midline. In a male, it will be 7 millimeter from the midline. So you mark it. We have already anesthetized the oral cavity with the 4% xylocaine, and I have anesthetized the external perichondria, which is quite sensitive to pain, with 2% xylocaine. Now I am going to take Botox. So she require only 0.4 cc, 0.2 cc on either side. That means so 2.5 units on either side. Total is only 0.5 units. Yeah, that is 0.4 cc. And I need the 20 gauge. Yeah. So I'm using a 20 gauge needle now. Now Dr. Dubey will do the scopy so that I can control it. You can explain everything because she is probably looks scared.
नाक से फूक डालेंगे और साहब ये सुन कर दिया है तो पता नहीं रहेगा और वो इंजेक्शन लग जाएगा.
Don't worry, it's not.
है ना?
Yeah.
नाक से सांस लो. वेरी गुड. शाबाश. नाक से सांस लेना है ना. पीछे मत जाओ बेटा, पूरा गर्दन को पकड़ के
Go a little more.
So can you tell us something about the Botox injection? How much it costs, and how much is a vial? How long can you preserve once you've used it? Can you keep that bottle for a longer time?
Yeah, this is 50 unit vial. You can keep it for 6 weeks. If you keep it between 4 degree and 8 degree, don't freeze it, but keep it above. Keep it above. You use a 2.5 unit on either side.
And how much does it cost, sir? Any idea?
It costs around 12,000 rupees for a 50 unit vial.
Okay.
His larynx is tilted a little bit here.
चलो करो swallow. हाँ very good. और swallow कर लीजिए एक बार और. हाँ. फिर से पानी पियो एक बार. पानी पियो पानी. या ऐसे करो. ऐसे करो.
Yeah. Yeah, keep it like that. Don't do anything. Yeah. Yeah. Yeah, that's okay. That's okay. That's okay. Cool down. Don't worry.
No.
think his larynx is slightly tilted. Yeah. Keep it like it. I'm going to inject now.
बस आराम से हैं, आराम.
No, she's closing the larynx.
ना सांस लो, लंबी सांस लो.
Yeah, yeah.
सांस लेते रहो. हाँ. बस 2 मिनट में परेशान मत हो, अच्छा हो जाएगा. अभी नीचे दिख रहा था नेडल, वोकल कॉर्ड के नीचे था वो. आराम से बेटा है, आराम से करिए. He is also 60, more than 60 years. So
Yeah, there will be.
Calcified cartilage. पता आपने.
No.
हो गया.
No, cool down. Sorry.
बस आराम से. बस. लंबी सांस तो लंबी सांस. Very good.
Yeah, the blood way.
बस आराम से.
Don't swallow.
अब गट्टो मत है ना, अब गट्टो मत. हो गया.
No.
लंबी सांस. कोई बात. चलो स्वारो का.
Hold down.
खूब गटक लो. साफ बाहर. गटक लो.
She's swallowing too much. Okay.
आराम. अब मत गटको, रुक जा.
Keeping on. Don't swallow like that. Okay.
बार गटको मत. हाँ, लंबी सांस.
I think he has to spit out and then come.
Yeah, the two broke थोड़ा फूकना.
She didn't swallow that frequently. Don't worry. Go and spit and come.
इस तरफ और होगा.
Spit and come.
बस.
There is.
एक बार थूक के आ जाओ. लो तुम लेके जाओ.
Yeah, right. Sometimes it happens. Why she cannot walk? Oh, right.
So how?
Yeah, she has to. Larynx is a little bit sensitive, and if some blood goes, then it becomes more difficult. That's a problem. Then you'll have to wait.
So you give a laryngeal block before this surgery, before this injection?
Give a xylocaine nebulization.
Only you don't give a laryngeal block, sir?
That is what is xylocaine nebulization.
No, that will be only on the surface anesthesia. But for the superior laryngeal nerve, which you go between the hyoid and the thyroid.
That also will go away because it is it just submucosally into the piriform fossa. So generally it will go away once that.
So no need to inject externally.
Yeah, you can do that, but I don't generally do that. I actually only do the superior the xylocaine block. Yesterday we did the same thing, you know.
And sir, where you have made the square, that is going through the cartilage. This needle is going through the cartilage.
That's why when they are older, it may become very difficult. Little bit. Tell her that cool down. This is nothing to worry. Don't get nervous. Right. Okay. Cool down. Okay. Don't worry.
अब नाक से सांस लो.
No need of swallowing. Just keep gently stay there. Don't do, oh, she's swallowing. Okay, just keep like this. Yeah, that is all. Yeah. I'll go a little bit above.
Yeah.
Swallow.
गटको एक बार गटको मिल जाए.
Yeah, that's okay. Just stay like that. Just stay like that. No. No need of sir. You have to go a little more deep. Yeah. That's okay. That's okay. Let's stay there.
बस. Yeah. लंबी सांस तो लंबी सांस. लंबी सांस गटको मत. गटको मत लंबी सांस लो.
Follow.
Very good.
It's turning out to be very difficult because it's very, very sensitive.
एक बार गटको. Now. Okay.
Yeah, now, stay like that. Stay like that.
Yeah.
No, I am talking to her.
ऐसी रहो थोड़ी देर.
She keep on swallowing.
लंबी सांस लो. गटको मत.
She keep on swallowing.
अब गटको मत ना. हो गया बस काम तुम्हारा.
See that there is a blood there now. That is a problem. I'm not very sure whether I will be able to do that because
you can try on the other side.
Yeah, but there's a lot of blood in it, so I cannot really see that. He keep on swallowing. That is not her fault. Just spray. Let me spray a little bit. Open the mouth. He want to spit. She want to spit. There is blood there. That once the blood come, it become little bit irritating. No. The larynx keep on irritating. Can you remove this thing little bit away from it? Yeah, right. Move. So if many times if the cartilage is calcified, if you struggle, there is one other way is that you inject the whole dose into one vocal cord so that you knock off one vocal cord and relieve the other vocal cord. That also, like Baylor Institute, they always inject only on one side. So if it become very difficult, there is an alternative. But I may struggle here again because once the blood comes into the larynx, it becomes very difficult. And especially if the patient becomes very nervous, naturally it becomes very, very difficult. They keep on spitting. I will try once again. Because the blood hinder your view, make the patient keep on swallowing and make the patient cough. So that become very difficult then. Sorry, do that. Okay. Let me try to not to swallow too much. Okay. Okay. Right. You put jelly on that. Yeah. Keep the head like this. Okay, like that. Keep that position.
Okay.
Yeah, keep like that and then don't move. It's okay. You'll be okay. Don't worry. Okay. Yeah. You see that? I will just go a little deeper like that. Yeah. Now that is there. I am going to inject the whole four.
Right. Very good. Very good.
That is all. That is all. That is all. That is okay.
Okay.
So what? Sorry. No, you can spit now. So what I did is that ideally you inject 2.5 units on either side. But sometimes in older people, even with the EMG, you may struggle to pass the needle through the cricothyroid. In that case, what you do is whenever you get one side, you inject double dose. That means you inject the 5 units straight away into one vocal cord. So what will it do is that it will give almost same effect. That vocal cord will be more paralyzed and the other vocal cord will be in the same position. In effect, what we want is that not too much of adduction of the vocal cord. Actually, there is an institute in USA, Baylor Institute. They continuously, all the patients, their studies say that they inject 10 units, not 5 units. They actually knock off the vocal cord, 10 units into one vocal cord, into one vocal cord. That is the pattern. But what follow is that actually what you saw, 2.5 units into each side. If that is not possible, you can inject the 5 units straight away into one vocal cord. Now tell the patient that the vocal for immediately there won't be nothing much. He will have a little bit of cough, but in 3 days' time the voice will become very hoarse. That is to be expected, and tell them that it may take anything between 2 to 4 weeks to come the voice to come back. So many patients may panic because their voice is now lost. Tell them that Botox has no permanent effect. Nothing will be there. It will be actually okay. So don't worry about that. That is the main thing. And some patient may have subclinical aspiration. That means when they take liquid, they may actually cough. That again is self-limiting, may go for 1 day or so. Other than that, you don't require any medicine. There is no history of any hypersensitivity reaction to Botox because the amount you inject is so mild and minimal. It is smaller than the test dose. So other than that, you may give, if you have injected multiple sites, if you have punctured the larynx multiple sites, you can just give a painkiller SOS. That is all. And regarding the Botox, you take, this is a 50 unit vial. You can dilute it with 4 cc. So that means 1 cc will contain 12.5 units. 0.1 cc will equivalent to 1.25 units. So standard is total 5 units. So 2.5 on either side. That means 0.2 division. 0.2 cc on each side you inject. Here what I injected is 0.4 cc into one vocal cord because on the other side there was small hemorrhage. So it was going to be difficult. I may not be able to see the tip of the needle again. She may cough. She may create more hematoma. It is no big deal, but it is more of a nuisance. So I just went through the other vocal cord, entered the paraglottic space and injected 5 units.
So very nicely and accurately done. So can you tell us when the patient goes into hoarseness of voice after 3-4 days, do you recommend steroids or some inhaler or something? Nothing.
No medicine, just paracetamol SOS because she has some pain because of the injection. That's why. Other than that, nothing is required because whether you give steroid or not, the voice is not going to come back. Because this is the effect of Botox. Botox is actually an agent which will prevent the release of the acetylcholine from the cholinergic nerve endings. So there is the recurrent laryngeal nerve is no more secreting. There is no more acetylcholine there. So muscle will be paralyzed. They won't actually move. The thyroid node won't move at all. For 2, 3, 4 weeks, it will be like that. It may vary. Usually, on an average, when you inject 5 units, they have a hypophonic or aphonic period for about 2 weeks. Then gradually, voice come back and the tremor will be completely gone. The duration of the symptom-free period varies anything between 4 to 6 months. First injection is almost always a guess. On an average, this is a standard dose, 2.5 on either side. Some patient may require more, some patient may require less. If they require more, what will happen is that their ephonic period, that is the totally breathy voice period, will be only 1 week. But then they will get symptom-free period only for 3 or 4 months. For some patients, this 2.5 minute unit may be too big. Then what happens that they will have an ephonic period of 4 weeks or 5 weeks. But the good thing is that they will have symptom-free period of more than 6 months. So next injection onwards, you know what is the correct dose. So if she had severe dysphonia for more than 4 weeks, next time I will inject only less than 2.5. If she had dysphonia only for a week, this time I will inject 3.75.
So before we conclude, one last question. Have you ever come across any patient having drug-induced dysphonia, spasmodic dysphonia of the larynx, drug-induced?
What?
Spasmodic dysphonia. Say these antipsychotic drugs and some of these levosulfopride and your perinorms. Have you ever come across any such case?
No, to my knowledge.
No drug-induced.
Spasmodic dysphonia is an entity which is a central neurological problem, probably at the basal ganglia level, and there is an auditory feedback problem. I know one of my colleagues, maybe you know him, Dr. Sanjay Subbaya. He's a neurolaryngologist he's my fellow. He was my fellow. He's in NIMHANS. So he does a new therapy for many of these conditions, which is known as the Tomatis. That is a company which give auditory feedback training. It is a sort of voice therapy. It is too early to say whether that works. But right now, we know that there is something wrong with the auditory feedback of this patient. But as of now, we don't know anything about drug-induced spasmodic dysphonia.
Thank you very much, sir. Thank you, sir. This session is concluded.
All the patient hearing. And now, with your permission, I am leaving. I have to fly to Trivandrum. So, see you all some other day. Maybe, and I ask a governing council member of the APSI, let me take this opportunity to invite you to the midterm phonocon. That is just one day. Association of Phonosurgeons of India conference on August 27th at Nagpur.
Thank you so much, sir. I would request Dr. Anil Jain, sir, to felicitate Dr. Rajbala ma'am and Dr. Rajendra Joshi for chairing the session. Now we have Dr. Jaskaran with his lecture on approach to frontal sinus.
Mic है? Yeah. माइक है तो मैं वो बंद कर दूं नहीं माइक अच्छा चलो इस पे Hello, good afternoon, everyone. I'm Dr. Jaskaran. At the outset, I want to thank my mentor, Dr. Dubey, Dr. Sanjay Agarwal, for giving me the chance to present my work. We had wonderful sessions for last 2 days, and many things has been discussed about frontal sinus. So when actually my original talk was not this talk, but Dr. Dubey asked me to present this work because this is our original work which we did on a frontal sinus.
I would request Dr. G.S. Saxena, Dr. Prabhat Gupta, and Dr. Mridula Sapre to please chair the session. Thank you. So is it when we talk about a route to a frontal sinus or route to a frontal sinus, is it really easy to reach frontal sinus in the beginning of our, are we looking for some easy route to reach frontal sinus? No, it's not very easy. And there has been a debate wherever we go for rhinology workshops. There are a lot of debate on this particular sinus, that is the frontal sinus. So because this route to this sinus has never been easy, and probably because anatomy is difficult, number one reason, and adequate training is not there. So we all want to reach frontal sinus easily. So, and there are different routes. There are many, many routes described in literature to reach the frontal sinus. But are we reaching frontal sinus safely, or what route we are going to take? Are we going to take first route and hanging ourselves and reaching frontal sinus? Or we want to take an easy route to reach the frontal sinus? So this journey of frontal sinus was made easy in 2016 by IFAC classification. That was the Rhinological Society classification, in which they describe the cells around the frontal sinus. We all know the anatomy of frontal sinus. We know the anteriorly it is bounded by beak. Posterior relation, I'm not talking in detail about the relationship of frontal sinus. Posteriorly it is bounded by anterior modal artery, laterally by lamina papracia.
So what these are the structures which are not fixed structure. They are static structures, which are always we will be finding. But what actually makes journey to frontal sinus difficulty is presence of cells in the frontal recess area. So what IFAC group did, so they studied the cells on a sagittal scan. So this, when we talk about these cells, it's always very complicated. And this is very easy thing which I'm going to tell. We just have to read a sagittal scan. So on sagittal scan, there are two group of cells, anterior and posterior cells. So when anterior group of cells are well developed, the frontal sinus pathway is pushed posteriorly. So what are the cells in the anterior recess? They are agenesis cells, which is the most important cell, and then supraagar cells and supraagar frontal cells. So these three cells, if are present, so you expect the frontal drainage pathway to be pushed posteriorly. So number one, so if this beak, when we call a frontal sinus a difficult sinus, because when we don't have an agenesis developed, in 95% of the population have a good agenesis cell. So when there is good nemotization of agenesis cell, this beak is pushed away from the frontal recess area, and we have a good area to work in the frontal recess. But if these agenesis cells, supraagar and subarachnoid frontal cells are not well pneumatized, and agenesis is not well pneumatized, so beak become thick. So distance between beak and posterior wall is more. If it is less than 5 mm, it becomes very difficult. We know we need a drill out in that. So whenever we are taking a case of frontal sinus, we must read sagittal scans, and we must ask our radiologist to report a distance of this distance. This is the distance between frontal nasal beak and a posterior wall. If this distance is more than 7 mm, so it is a easy walk away. So we don't have to struggle much. But if this distance is less than 5 mm, so it is going to be a very difficult frontal, and we often need a drill out procedure in that. So second group of cells, this is frontal septal cell. The second group of cell is posterior based cells. So if these cells are well pneumatized, so then we know the frontal pathway is pushed anteriorly. So only two things we have to know, either whether pathway is anterior or whether pathway is posterior. So if these cells are well developed, then we know the pathway is pushed anteriorly. What are the cells we are talking? One is bular cells and suprabular frontal cells. So this whole sagittal one section makes our journey to frontal sinus easy and straightforward. So we want to know that we want to study these cells. Once we know these cells are present, that will describe or that will tell us how easy or difficult frontal sinus surgery will be. So challenge now, once we are done with the study of anatomy, the challenge is it's a very difficult location. It is an angulated location. And it's not about like opening a maxillary sinus. If we touch the frontal sinus here, we're not able to clear the whole frontal recess area, we will have lot of adhesions and recurrences. So this area becomes very difficult and challenging for surgeons. So now what is the remedy for that? What we should do about that? There are many approaches. So in my talk at the end, I will try to make this concept easy, what actually we should be doing in the frontal recess. So there are either open or endoscopic approaches. So open I'm not talking, because open approaches itself is a separate topic. So we are talking about endoscopic approaches. So endoscopic approaches, one is classical technique. This classification is sort of a classification by Wormald, which is very easy classification, and there's many classification. But this classification is easy classification for postgraduates to remember. One is classical technique, in which classical endoscopic technique, in which we are using angled scopes, minimum 45, 30 or 70 degree, ideally 70 degree. Then axillary flap by Peter Wormald. Then there is a miniatrophine again by endoscopic assisted. Then image guided, balloon dilatation. Caroline window is the current approach by Richard Harwood and group in 2023. His article is there. And extended approaches like Lothrop or orbital transposition, what Dr. Janki was talking yesterday. So we have to choose 99% of our patients in this approach, and 1% of the patient who need open approaches are sort of a different patients. So if we know what approaches we have to follow endoscopically, we can carry on with these approaches, either of this approach. So each approach has a different advantages and disadvantages. So once we talk about angle scopes, if we use 70 degree, So main problem with 70 degrees is very difficult to learn a curve of a 70 degree. The simple concept is that we have to make a 70 degree to work at a 0 degree. So as you have seen Dr. Janki, he was keeping his elbow at an angle. So if we are holding 70 degree, we have to make this elbow at the angle of 120. Hold it like this. Once we hold it like this, the scope will make a 0 degree scope. So we don't understand this angle. So we try to hold scope like this and we try to expect scope to see at a 0 degree. That's not going to be possible unless this axis is right. Elbow and forearm axis is right. 70 degree scope will never work properly. So there is a long learning curve in working with 70 degree. We have to learn 70 degree to use as a 0 degree. So if we make this angle in a proper like 120 degree angle of this, and then we can use 70 degree to a 0 angle. So only thing is you have to just keep one's Mayo trolley or something like that, and then hold with that, and then use it with that. So the angle, there are two main approaches, intact bulla or non-intact bulla. So then there is a very good approach by axillary flap. This is by Dr. Peter Wormel, in which he makes a window anterior to the middle turbinate. This is the middle turbinate. Anterior to the middle turbinate, 10 by 10 or 8 by 10 window. And then he takes away this axillary flap, and by it is a basically like there is a stapedectomy and stapedectomy. So this is a stapedectomy, means we are making an axillotomy. We are not taking the axilla away, but making a small hole in the axilla, and then we try to see the frontal. But this works well only where there is good pneumatization of a frontal recess. If there is not pneumatization, then this doesn't work. So this is very good approach, and we can work it with a 0 degree. And only thing is that we have to make a small learning curve in that. So this is a mini Trephine approach, in which we know there is a difficult sinus. We know that we are going to be having difficulty in sinus endoscopically. So what we are going to do, we want to push something from the outside and then track it to the frontal recess. And then that dye or betadine or whatever, it will flow through the frontal recess area, and then we can see it with endoscope and then widen that part. So this is a small, this is by Dr. Andrews. It's not my work. Dr. Andrews from Germany has done this. So he has suggested right and left side. So on the right side, if we are operating right frontal, keep your left thumb over the eye like this. Left thumb over the eye, and then imagine a clock. This is a clock. Imagine a clock. If it is at 2 o'clock on a thumb, imagine a clock, and 2 o'clock you just pierce. So it's a safe area. You're not going to hit skull base over that. And on the right side, on the left side, you make a 10 o'clock position. So imagine it as a clock, and just put a thumb and then mark that area, and 2 o'clock on the right side. And 10, this is a very, very safe area. You can just pierce with drill, fissure, whatever is available with you. And just through that, just pour something to guide you the frontal recess. So this is very good in any case where we are dealing recurrent thing, or any we are expecting any stenosis in the frontal recess. So balloon, we don't agree with balloon. So this is the American technique. The American group is propagating it, but it's not very good technique, because here we are not removing frontal recess. We are just micro fracturing it. So this is not very good technique, and this lot of recurrence is a very, very limited indication, only 1 or 2 indication. One is a barotrauma. It is especially in pilots or divers who go and they have a severe headache of the flight, long flights coming back, severe headache. Then you take this pilot and then dilate that air goes away. That is only exact indication of a balloon. Here we put a balloon and then dilate and open up the frontal recess. So Caroline Winder, this is the current technique which is there, and it's very Dr. Richard Harvey from Australia and his group made this paper which they published in 2023. Here there is no like Wormel, there is axillotomy. This is axillectomy. We are taking away the axilla. It's very easy. Once it just time is there, I'll just show you the video how to do that. Once you open the flap and then take away the axilla, you are straight into the frontal recess. As Janki was saying, lot many times to straight access 0 degree. He means whenever a patient is coming to your OPD, you should see all the sinuses, not only in theater, but also in OPD by 0 degree. That is the whole idea. So this is the current technique, and in follow-up is very easy. We don't need any endoscopic, angle endoscopic training. Heavy mucosal disease, revision cases, I'm not going to touch the heavy mucosal, that itself is a separate topic, common cavity or topic disease. And then we have a straight access. And only thing we need a good drill system. That's only thing we need a good drill system, either a Medtronic or a Stryker, or any drill which doesn't take away the adjacent mucosa. So there is lot now. After my talk, I'm sure you must be confused. So what I'm saying, this is, so I try to take the confusion away and figure it out into the two basic techniques when we are using angle scopes and when we are not using angle scopes. So the whole, the summary of my talk will be either we should use the angle or we should not use the angle. So is there any real difference in that? So we in our institute did a RCT, randomized control trial. We grouped patients into two groups. This article is published in Indian Journal of Laryngology. So this is, I had lot of reviews, lots of reviews. I mean, they were not taking up this article and I have to review it again and again, 12 or 14 times, because they were not understanding the Caroline window is something like Caroline window is there. But when this European group published in May this article, then I took their reference and sent them, and then they actually understand that this technique is right. So what we did, we divided our patients in the two groups. One group we followed angle scope, other group we followed Caroline window, which am I going to say. This is a transaxillary approach. This is not original. Now what Richard is doing is something different, but to make it easy, I used a coblator. Ideally, we should not use coblator, but to make it a better understanding, I'm showing it with coblator. So what we are doing, we are taking this flap away. This is in the middle turbinate, anterior to the middle turbinate. We are making a small window. So we are taking this flap away with coblator. I'm not using any bipolar or Colorado. We can use that also, but try to give as low heat as possible. Then we drill. This is a high-speed drill, a Stryker drill. It's a very, very good drill, not as costly as a Medtronic, but a very good drill system. It's a very, very sharp, very, very heavy drilling system and very precise. So what we are doing, we are trying to take this axilla, this whole axilla will go. It's not we are making a small tummy into that. We are taking this whole axilla, and limit of our window is one side you can say this periosteum, this is the lamina papracia. And other side, you see there is middle turbinate. Anteriorly, I have drilled the axilla away, and posteriorly, we know skull base or anterior artery is there. So once we, so it's a straight, it's a 0 degree, and just with a simple curette or Kuhn's elevator, I can just elevate the all frontal cells. So once we take away these frontal cells, we can see directly into the frontal sinus. Now, what is the endpoint of this surgery? Endpoint is then when we have a good frontal glow. We have to keep on working till we have a good frontal glow, and we can see the this with 0 degree endoscope. Once, if you are not satisfied, we need to take some more bone. We can again take, it's like inside out mastectomy. When we are satisfied, your inside out is good cavity we're having, we can stop, or we can just take more frontal nasal process from maxilla to even have a good. But in this case, I was satisfied with this much of exposure. So second is our classical technique with which Dr. Sethi and Group and Stamberger, everybody has been talking. That is by intact bulla technique. So I tell you the difference. So here we are using 70 degree endoscope, as I told. So we are making a endoscope, 70 degree endoscope to work as a 0. We cannot work, eyes can work in a single trajectory. So we have to make sure that 70 also work like a 0. So only thing it has to be 70 has to be very vertical to the nasarella, and that can only be happen if we keep this arch in a right way. So in this technique, so we with the angle endoscope, we are just taking with debrider. And again, as I told, for this technique, we need to have angle debriders, and everything should be angulated. So this has a very long learning curve, and it takes a lot of time for our youngsters, because they are used to 0, then they learn 30 degree, then they learn 45, and then the 70 degree, and it takes lot many years to get training in that. So is there any real difference? So before telling you the real difference, so this is a chart in our study. So this chart is very important. I hope you can understand from this. But the endpoint or conclusion of this chart is this. We used a Lund-Mackay score. That is the endoscopy score in both the groups. So result in both the techniques were not very different. So both the techniques are good. Results in both the techniques were good. SNOT score is a symptom score. There are 22 questions. It is a questionnaire. We asked patient 22 questions pre-op and post-op. So both the groups, again, the patients were satisfied. So there is not much of a difference. So and then it is a mean time to reach frontal. So once we are doing FES and anterior FES is completed, we want to reach frontal. So how much time we take to reach frontal? If we are using drilling, of course, there is frontal bone is a very thick bone. We have to drill a lot. It takes 15 minutes, 21 minutes to reach frontal. In contrary, if we are good training in angle endoscopes, it takes 15 minutes to 16 minutes to reach. Of course, time doesn't matter, but this is just to tell you that it takes somewhat good time, somewhat extra time to reach frontal if you have to drill a lot of bone. So this main problem was this four things. So the main problem, both the techniques were good, but nasal addition and middle turbinate lateralization was more with Caroline window. And this was making our life, this will make our life, if we are not taking care of these parameters, and if middle turbination is the worst thing you can have in a post-op care of UFS patients, it becomes very difficult. Or the newer concepts are there, by Richard Harvey and group. You take the anterior or in heavy mucosal diseases, there is entity called the common cavity topic disease, which is very popular now. So just keep the remaining turbinate and just take the anterior turbinate, just a head of a turbinate. Because head of the turbinate is the area which is responsible for atopicity of node. If you take the head of turbinate, it will solve two problems. One, atopicity will come down drastically low. So there can be less chances of recurrence in polyp cases. Second, it gives a very good access in cleaning of frontal recess area. So post-op care becomes very difficult. It's not like that we have to take whole turbinate away, just an area of a turbinate which is around the frontal recess. Just 2 minutes. So middle turbinate lateralization is a problem with Caroline window technique. And this is the endpoint of your surgery. This is the frontal globe which I was taking, and this is the post-op. You should be taking care. So whatever technique you follow, you can follow. But gold standard still is a 70-degree technique. We should not run from learning 70-degree. We should encourage our youngsters to use, only thing is how to use 70-degree correctly. That's only, you just make this arch angle very nicely, and it is all physics, and then you have to make a good angle. If still you're finding difficulty, then go ahead with Carolino window. This is very good technique. Only thing you have to take care of the middle metal stenosis. That you can be handled with trimming of the anterior turbinate. I hope I have delivered and tried to solve the confusions. Thank you so much.
Thank you, Dr. Gill, for the nice presentation of all the sinuses, paranasal sinuses. Frontal is most difficult area. You have given a good presentation. Thank you very much. Any questions from the audience? Thank you.
Now I'd request Dr. Omkar Deshmukh to felicitate Dr. Jaskaran Gill for such a beautiful and explanatory lecture. I would request him to felicitate Dr. G.S. Saxena, Dr. Prabhat, and Dr. Mridula Sapre for chairing this session.
रूम की चाबी किसके पास है मोहन भाई? रूम की चाबी चेक आउट कर दिया ऑलरेडी.
Dr. Omkar Deshmukh to felicitate Dr. G.S. Saxena. Dr. Prabhat and Dr. Mridula Sapre.
भाई उधर एक मक्खी है.
Now we have a case on rhinoplasty.
ठीक है, ये बाद में करते हैं.
I would request Dr. Hina Bakshi and Dr. Nitin Shirvastav to please chair the session.
If it's associated from conca, something like this, we will be doing conca first and then the
Rhinoplasty कर सकते हैं इसमें डायरेक्ट एंडोस्कोपी की जरूरत भी नहीं है
हेलो
हेलो मेरा माइक ऑन करने को बोलिए
Hello, sir. You're audible, sir. Hina here.
Okay,
Yes, sir.
good. Okay, so this is a 17 years old girl and she has a breathing difficulty and also an external deformity of the nose. And I would like to explain the deformity first. So please, the external camera, focus on this photo. ये ऊपर कर दो भाई. Just give me a needle, a fresh needle as in sterile. Yeah. ये वाला. I'm not sterile. Syringe, fresh syringe, any fresh syringe. Yeah. Okay, so this is. I hope I'm audible. Yeah.
Yes, sir. We can see the external picture now.
Yeah. So the external camera, please focus on this photo only. Okay, so if you see this, she's a 17 years old girl having a breathing difficulty, and also she's having the external deformity of the nose. I asked her whether she had her menarche. She had her menarche about 4 years back, so this is a good time. So generally, after menarche, you should wait for 3 to 4 years and only then take the patient for the surgery. And the reason is because in the septum there are a lot of growth centers of the face, so the vertical development of the face will be hampered. Okay, so on the front view, as you can see here, the little bit of the photo is cut, but she has a nicely oval face. The upper 1/3, middle 1/3, and the lower 1/3 are almost divided into equal halves. If you see the glabella and if you see the philtrum, so they are almost in the same line, but they are about 1 millimeter. There's only a 1 millimeter difference. If you look at the glabella and if you look at the philtrum, so if you draw a line passing through the glabella, it generally passes just about 1 millimeter away from the philtrum. So this is a mild facial asymmetry. You can also see the right half of the face is a little flatter, and this half of the face appears to be a little wider. If you also look at the upper lip, this half of the face is a little atrophied as compared to the right side. If you see the base bony width on the dorsum, she has a dorsum which is deviated to the right hand side. There's an obvious deviation, and the deviation is at the level of the upper and the middle 1/3. Okay, so her upper 1/3 appears to be all right. So major problem is in the middle 1/3. If you look at the tip width is a little bit broader than the philtrum width. So we aim at a tip width which is almost equivalent to the philtrum width. Okay, and even the base appears to be a little bit deviated. So now we come to the lateral view. Ye photo pe focus karna. Okay, so now we come to the lateral view. As you can see here, she has a small bump on the dorsum, but according to me, this is not a hump. She has a radix depression. So the running point of the nose should start from the upper eyelid crease. Okay, if it starts from the upper eyelid crease, so ideal the nose should be starting from here. So if you draw a line, so even if you fill up this radix, this a little bit of bump which is there is not a hump, it is a pseudo hump. In fact, if you reduce that hump, she'll have a saddling. Okay, so but because she has a deformity, we don't remove the hump, but we'll take care of the bumps over there, so that those are the lateral humps. Coming to the basal view. On basal view, as you can see here, the entire nasal base is deviated to the right hand side, and the nostrils are not symmetrical. You can also see the base bony width to be very high. The ala base width is almost equivalent to the intercanthal distance. So we do not do anything to the ala. Her flaring is also all right. So we do not disturb that. And so this is all about the case. Look at the 3/4 view. It generally gives you an overall idea about this thing. So generally there's a little bit of drooping after this hub. So even that thing we'll try to correct it. Okay. So we'll open up and see what what surprises we have. In addition to that, she also has a concha bullosa on right side, which will take off after the surgery. Okay. Yeah, touch ho gaya. Give me a different gloves. Gloves चाहिए. Marking pen you have? New one? New. नया है क्या? Marking pen? Looks good.
So have you examined the septum preoperatively? How was it?
Yeah, it is very much deviated, and you see, I'll show you. ये थोड़ा कम ही रखो जो अपने को नहीं चाहिए. ठंडा पानी रखा है फ्रीजर में.
So in cases of females, you've told that menarche is the landmark for a pediatric case. What about males, sir? What is the criteria for?
Males, it is the change in voice or the cracking of voice. So you should generally wait till after 3 to 4 years after the cracking of voice. So this generally corresponds to 15, 16 or sometimes 17 years, like that. As you can see, there's a caudal dislocation of the septum. You can see.
Yes,
on
sir.
the right hand side, there's a caudal dislocation right from above. So this is the anterior septal angle, and there's a gross deviation on. There's a gross deviation on the anterior deviation on the left hand side, and posteriorly it again is deviated to the right hand side. So it is basically an S-shaped deviation. So for the sake of juniors, I've infiltrated the nose with 1 in 1 lakh ropivacaine with 1 in 1 lakh adrenaline. So while infiltrating, I've infiltrated the dorsum, the side walls, also the osteotomy sites, tip, columella, nasal spine, the incision sites. These are the incision sites, and also the septum. Okay. So I have infiltrated overall about 16-17 ml of ropivacaine. So the ropivacaine we use is 0.2% ropivacaine with 1 in 1 lakh adrenaline. So in 0.2%, 20 ml, I have added 0.2 ml adrenaline. Okay. So now I'm going to go ahead and take the incision. So this is, if you see, so this is the lower border of lower lateral cartilage. So it generally would correspond to the junction of hair-bearing and non-hair-bearing area, but it may be sometimes wrong. So it's better you palpate for all the earlier colleagues and for all the junior colleagues, and you have to palpate, and your elevator or the back of your BP handle will generally stop over here. So this is the place. So you should not cut it. So I generally take an incision on the lower border of lower lateral cartilage. So we call this as an infracartilaginous incision. And this is not working very well. Okay, so this is the narrowest part of the columella. The base of this incision should be at the narrowest part of the columella. यार थोड़ा नया ही लेके आओ. नया है? नया रहेगा तो बताओ, नहीं तो कोई बात नहीं. नया sterile. Okay, so this is the infracartilaginous incision. I am taking the incision on the lower border of lower lateral cartilage. So infracartilaginous incision consists of 3 parts. The lateral part, the most difficult part, and the part you should be careful about is the domal part. So this is the part you should not be if you are below, then you may damage the medial crus. If you are above, you will be damaging the soft triangle area. And then the columellar part. The columellar part is parallel to this columella in this groove. So I take this incision, the same incision opposite on the opposite side, the lateral part, then the domal part, and the columellar part. Then I generally, at the narrowest part of the columella, gauze piece please, wet gauze piece. Okay. Then the base of the incision should be at the narrowest part of the columella. I prefer to take it with a 11 number blade with a little bit of a sawing movement, and then this is joined, suction please, and this is joined with the lateral columellar incision. Okay. I prefer to do a retrograde dissection. So while doing this, I go in a smash plane. So this is a subdermal musculo-aponeurotic plane, that is a smash plane. So this is the Pitangis compartment. This is the Pitangis compartment. So you have to go past the Pitangis compartment. So in closed rhinoplasty, it matters that even in closed rhinoplasty, you have to split the Pitangis compartment. Mop please, section please. Okay. Then I join these two compartments and dissect in front of the nasals in supratip area. Then I generally dissect in front of the medial crus. So you have to be very careful. These are the places when generally would lead to some kind of trauma. And then we'll open it. Sir, thoda bleeding हो रहा है, पता नहीं क्यों. हाँ ना? ये टैकी है इसलिए हो रहा है. So this kind of dissection is called as a retrograde. So you can mop it. This kind of dissection is called as a retrograde dissection. So this, as you can see here, this ligament over here is a dermodermal ligament. This is called as a Pitangis ligament, which we generally sacrifice in an open approach. But if required, you can suture this to the supratip area. Okay. At this level, I have changed the plane of my dissection to the absolutely to the subperichondrial and the subperiosteal layer. ठीक है, पता नहीं, ये दे दो बाइपोलर.
Bipolar is at 50.
No, I reduced very little. 20, yeah, 20, yeah, 15, 20.
और bipolar भी 20 कर दो.
So with the stout elevator, I am elevating on the nasal bones till the glabella, till the nasion. एक काम करना फिर ये बाद में लगे. Give me a good wash. Wash. So as you can see here, I have reached in the level of nasion. You can see the movement of my instrument over here.
Yes, sir.
Yeah. In this case, I would like to do a little bit of lateral dissection. That is a little bit of bleeding. Because it's a crooked nose case, in crooked nose cases, I prefer to do more lateral dissection. Piezo bhi laga lo.
So are you anticipating any asymmetry of the nasal bones there?
Yeah, there is some. Piezo है ना उनके पास? है ना? है ना सर के पास piezo? एक काम करना मुझे 4% एड्रेनलिन का वो पैक जो है वो दे देना. Till that time, I'll just keep a pack over there. Adrenaline pack. Now the bleeding is okay. Okay. I'll do a little bit of rasping and also a little bit of osteoplasty. By rasping, I'm not reducing the height of the bone, so I'm not doing any reduction, but I'm just getting rid of the bony indulations and also, so as you can, if you palpate over here, I can palpate a little bit of a bony prominences, so which I'm going to get rid. So I'm not going to rasp like this. I'm going to rasp on the sides. So this is more of an osteoplasty. The upper 1/3 is fairly symmetrical. Otherwise, just give me a good wash. Just section.
So you don't like to give the vertical incision to remove the periosteum over the bone?
No, now earlier we used to do that. Now
Yes.
you see, after this, I directly changed the plane to subperiosteal and subperichondrial. Okay.
Right.
So earlier we used to do that. Now that after seeing the techniques of Dr. Enrico Robotti, we have changed our technique. So if you go to this plane, so it directly opens up into the subperiosteal plane also. little bit of convexity over here. Just you're coming in between. Don't take too many instruments. Only take the instruments that we need. Otherwise, we will not find our own main instruments. So almost done. So now we'll, after any hump reductions, then we open up the septum. C-shaped retractor, please. Artery forceps nahi nikale na? Yeah. Mop, please. I prefer to apply a little bit of retraction with the help of a mosquito artery forceps on the soft tissue over the lateral crust. Okay. You should, while doing this, you should never apply this to the soft triangle here, because this is the only place which is devoid of any cartilages. So if you apply it over there, then you'll damage the even the lateral cartilages are not very strong, so I don't want to fiddle with them too much. So all this goes into gentamicin. वहाँ पे चाहिए थोड़ा सा bipolar कर लेंगे. Somehow I don't know, maybe problem with the local anesthesia. Bipolar is here. यार ये तो गिर जाएगा सब कुछ. You'll have to manage it. Bipolar.
Sometimes it might not contribute. So that's the thing. We can do that. Europeans will kind of, because they
Please
have
hold this. No, please hold this.
If not, you already have a lot of consideration. So whatever maneuvering you do, ultimately will not show up. So we need to remove it. That's why it's one about it. And then now it's been very subperigon really. There is some fat that gets experienced. So and especially in cases of diagnosis, you have everything partners. So you can go exactly on the cartilage damage. And we can see that they all very sensitive.
Okay. So I'm going to go ahead and split the tip now. So as you can see here, this is the interdermal ligament. I think there's some problem with the local. Can you just give me the local again? Mohan, give me the local. No, the not reloaded. Yeah, no, there is some remaining local over there. So this is, as you can see here, this is the interdermal ligament. I hope you can see that.
No, I don't know about that. Yeah, it's kind of okay.
लोकल दे दे वो थोड़ा सा जो बचा है. Angle now?
Yes, sir.
So this is the anterior septal angle. From anterior septal angle, I prefer to make a submucosal tunnel between the upper lateral cartilage and the septum. So my preferred technique to do this is to scratch the periosteum and then get into the right plane. Yeah. So yeah, after this, you get into this right, please, sir.
You're now between the upper lateral cartilage and the septum.
Yeah. As you can see here, so if you dissect it nicely, you can dissect it. If you dissect it this way, you'll preserve the septal T.
Right.
If you cut it, you may not preserve the septal T, and then you get into the correct plane, and then it's like a cakewalk. It's not very difficult. So this is the anterior tunnel that I have dissected on the left hand side. I'll do the same thing on the right side as well. I have not gone to the inferior tunnel as of now. So here again, I make a submucosal tunnel between the upper lateral cartilage and the septum. And as you can see, preserving the septal T, we can do this. So by virtue of this, we have preserved the septal T.
Yes, sir.
But this is not a perfect plane. You can remove this now. Now I'm going to use my Killian's retractor when I separate the inferior tunnel. I prefer to do that on the concave side first. So I've elevated the mucoperiosteum and the mucoperichondrium on the left side now. I'm going to the right side. This is the caudal septum I'm dealing with. Please mop this. I'm trying to push this. I'm trying to dislocate this caudal septum from the crest. No. No, don't do anything. Don't disturb anything now. After dislocating on the left hand side, now I'm going to elevate the periosteum on the spur which is there on the left side. Leader. The columella vessels, yeah. Okay. So now I'm going to get rid of the spur. I generally prefer a double action forceps to remove the spur. So this is the bony spur.
Yes, sir.
That we are removing. This is the posterior part of the bony spur that I've removed. Although the spur was not very big. And developmentally, the nasal spine and the spur are not developed from the same centers. So even if you cut the nasal spur, generally this way, the fracture line would never go to the nasal spine. I have just removed the bone next to the nasal spine, but still the nasal spine is intact. Now probably I can.
So is the nasal spine in the center, or is it deviated?
Yeah, I'm checking. It's fairly in the center. So for that, this is a very good question, because you always have to, you see, actually, if you look at the external camera view, the entire face is open. You have to look towards the incisor teeth. You have to look towards the philtrum, and then you have to look towards the nasal spine. So nasal spine is in line with the philtrum, and then you also have to look here. Suction, please. Just give me a wash. Yeah. You have to look if this septum, if it is in the center or if it is in the paramedian position. To me right now, it looks a little bit in the paramedian position. Okay. But only, you see, only by relieving all the forces, the septum has almost become straight.
Yes, sir. So have you also released the depressor septi muscle fibers?
No, I have not released the depressor septi muscle fibers in this case, because there was no need. In fact, I have retained them.
Yes, sir.
And I've purposefully retained them because it acts as a good support to the nasal spine.
All right. So if sir, you had a deviated spine, you would have released those fibers, sir?
Not really. Not really. I don't do it unless there's a blunting of this angle, nasolabial angle. I'll do it only in those cases where there is a blunting of the nasolabial angle.
All right. Okay, sir.
In this case, although I'm trying to put this on the nasal spine, it still has a tendency to get deviated. And if you see on the lateral view, she has, okay, lateral view is not bad. Okay. A C shape, please. Yeah. Just take it off once. For once. Just before that, I'll just shave off a little bit of a cartilaginous hump. So here I'm sacrificing the septal T now. सर कुछ पॉज वगैरह देंगे क्या? पता नहीं है, सब कुछ ठीक है पर ब्लीडिंग ज्यादा है. वो ठीक है.
So you can use topical Tranexta also.
टॉपिकल ये रखेंगे, एड्रेनलिन डालते हैं। नहीं है ना, वो रेडी है, वो यूज करेंगे। number.
So what was the purpose of removal of that small wedge of cartilage from the dorsal septum, sir?
No, it was a little, there was a very little hump, cartilaginous hump over there.
Right, sir.
Please remove all this and just keep on giving a very good wash every 2 minutes. So till here, what I see, still here the septum is straight. After that, it has a tendency of collapsing. So I'll preserve the septum. I'll do a partial extracorporeal septal reconstruction. I'll preserve a part of the septum, part of the dorsal septum. So as you see, I've taken a cut over here, and then I am taking a cut posteriorly. Give me a suction, please. Yeah. He has a good amount of septum. Okay. So we are going to preserve this part of the dorsal septum, and rest of the septum we are going to remove.
Right,
We've
sir.
got a good amount of septum, and I'll show you the dimensions. The perpendicular plate of ethmoid and all are also deviated, so I'll remove them now. Suction elevator है अपने पास, वो ले लो। ठीक है, नहीं ठीक है, नहीं हो गया काम। लक्स फोर्सेप्ट रहेगा, देखो। Just removed a little bit of a perpendicular plate of ethmoid. The rest of the perpendicular plate is straight. This is the time I packet forceps. थोड़ा एडिनॉइड्स भी है उसको। I'll just do the lateralization of the turbinates. I have fractured the turbinates laterally. Okay, now we'll go ahead and do the osteotomy. You have a piezo, no? इसमें कौन सी ये है? ये लगेगा, ये और ये. Okay, so because it's a luxury over here that we do have an access to a piezotome. So piezotome is a very nice device to give me a good suction, please. Give me a good wash. Okay, so I'm going to give a paramedian osteotomy with the piezotome. Where is the foot switch? Section अंदर से रखना पड़ेगा.
So usually you do this step using a drill or a osteotome?
Using a drill, using a Lindemann burr. So now you can see there's a precise cut I have made in the bone. If you say I'll demonstrate the same thing to you with the help of a drill also. Yeah, Lindemann burr lena.
So what are the precautions that one must take while doing this particular step?
You should never cross the medial canthus, because if the fracture line goes beyond the medial canthus, then there's a chance you may go and hit the cribriform area, cribriform plate.
So many a times we encounter dislocation of the keystone area during osteotomy. So,
yeah, so that is the reason we have to go to finer and finer instruments. The worst part is it is bleeding from the I cannot cauterize this because this is a both bilaterally it is bleeding from the soft triangle.
Right.
I just cannot cauterize it, So otherwise, this is the paramedian cut that you should be. This is with a drill. You can even do it otherwise. You can even elevate the periosteum beneath. And you can do it inside out also. So this is the usual way I do it. So you saw that I made 2 paramedian cuts. This can be done with a 5 mm osteotome also. So these are the 2 paramedian cuts you saw that we made. This one we made with a drill, this one we made with a piezo.
Yes, sir.
Yeah. Now I'm going to do a transverse osteotomy with a piezo. That is not possible with drill. Otherwise, you have to do it with a percutaneous osteotomy.
All right.
Piezo. कैसे इसको निकालते हैं?
So can you show us the piezo handpiece?
Yes. Just give me a moment, because I'm also not used to piezo. But now that it is there, I thought I should.
मैडम कुछ बोल नहीं रही आप मॉडरेशन
बोल रहे हैं सर
बोल रही हैं मैंने कहा मैं भी आगे बड़ी स्क्रीन पे देखता हूँ
बिल्कुल सर
तो मेरे को लोकल इंजेक्शन है वो दे देना ठीक है चेंज करा लो वो लोकल इंजेक्शन था यहाँ पे पड़ा हुआ Mhm. Mhm.
So what are the indications for total extracorporeal septoplasty?
See, if the dorsal septum, even if it's in a paramedian position, I will still do a partial extracorporeal because I can still use it as a spreader graft. But if the dorsal septum, if the keystone area is deviated, if it is the angulation at the keystone area and the exactly at the keystone area, then that is one of the biggest indication for me to do a total extracorporeal. कौन सा लगा रहे हैं? वो नहीं चाहिए हाँ वो ऐसा जो साइड वाला है ये नहीं ये.
So what is the width of the dorsal strut that you have preserved behind?
Yeah, I think it's 1.5 centimeters right now.
Okay, sir.
I'll just show it to you. They are fixing the piezo handpiece. That will be, this is for lateral one. नहीं, और बताओ जरा वो शायद ये चलेगा. नहीं ये चलेगा ये.
So what is the advantage of this instrument over other instruments like the drill and other conventional?
As far as paramedian osteotomy is concerned, there's no difference, according to me. But when you do a percutaneous osteotomy, there's a lot of trauma. And because of that, there is a lot of this thing also, edema also. So this will definitely prevent the postoperative edema to some extent. Although some edema will definitely be there, but it will prevent the post-op edema to some extent. Okay, so this will be the transverse osteotomy that I'll be doing. I'll try to do it with a piezo.
So the upper limit for this is again the medial canthus.
The advantage of piezo is that, suction please, it will cut the bone and it will never cut the soft tissue. So even the mucosa beneath will definitely not get away. No, still. You'll have to do it intermittently, no problem.
Can the irrigation be reduced for this device, sir?
Yeah, better. Suction please. थोड़ा सा irrigation reduce करो. Yeah. So have you
Yes, sir, we
seen that
can
I've
see.
made a cut like this? A
Yes,
transfer
sir.
cut like suction block है.
So can you meanwhile show us the handpiece of this device?
Yeah, please, the external camera, please show the handpiece. Yeah. So this is the transverse osteotomy on one side. Although it is a little bit time consuming, but it definitely would reduce the post-op edema to quite an extent.
It can also be used to sculpt or contour the nasal bones as well.
Yeah.
Yes, sir.
No, it doesn't. Never done this. Power कम है भाई. Powerfully करो.
Yes, ma'am. Go high up. I'll ask him the question. He'll also explain.
So there's a question from the audience. In a case of severe deviation where we do an open approach, we remove the perpendicular plate of ethmoid, the vomer if that is deviated, and then we do a paramedian osteotomy, will it destabilize the pyramid?
Yeah, well, the pyramid is not in correct position, so you have to make it in a correct position, and only then you can do it. I'm not really happy with Piezo. I'll do it by my own conventional technique because probably I'm not used to it. Okay, so I'm just going to make a drill hole in the nasal spine.
When the both parameters in this upper one part itself is deviated. This is all right.
I'm going to make a drill hole in the nasal spine.
So bring it to the left line. Usually what happens is one nasal point will be small and the other one will overlap.
The nasal spine is not very big, so I'm just making one single drill hole. Okay. So I'll go ahead with my own conventional percutaneous osteotomy.
Little longer.
As you can see here,
Trim it off or you trim it off. Okay.
So I'm going to do the transverse osteotomy on the left side is done. I'm going to do a transverse osteotomy on the right side.
Very high to high. But if you are flush in the groove, then it just goes inside because it has.
And then the low to low osteotomy, like this.
The line is lower in the nasophacial area. यहाँ किया तो वो पूरा if you do it here at the level of the nasal bone and you don't include the tracheal process of maxilla.
15 number there. Okay, so I'm going to do a percutaneous osteotomy on the left side, as you can see here. So I'm going to make a percutaneous hole with the help of a 15 number blade, and this exactly in the nasofacial groove. This transverse of the lateral osteotomy should exactly be in the nasofacial groove. And I always do 15 number blade. इसलिए जो चीज की गरज नहीं इधर रखने का ही
it is there and that will be prolonged.
ब्लेड नहीं मिलता एक सेकंड में जी इसका काम खत्म हो गया वो रखने का नहीं है सर दिस इज हैपेजार्ड इसकी जरूरत नहीं है 15 नंबर ब्लेड कहाँ पे गया देखिए हाँ
Partial extrovert.
तो हमने किया है
No.
So I always prefer to do
Deviation was extending up to
higher osteotomy first. थोड़ा सा टेबल ऊपर कर लेंगे.
done. But even after releasing the whole thing, there was still a till of the cartilage. हाँ, but थोड़ा leads to a very hard.
So I scratch the periosteum, and this generally starts from the pyriform aperture to the medial canthus. So low to low osteotomy.
I think this is a 3 mm.
So using a 3 mm osteotome, sir?
Yes, yes. I always use a 3 mm osteotome. So if you see these conventional instruments, although they give rise to a little bit of bleeding, but they are so fast. That side, paramedian, the transverse osteotomy is complete with the help of a Piezo, so I did not take any incision. So the only thing is you have to be exactly in the nasofacial groove.
So do you always do percutaneous or you sometimes do a closed osteotomy as well?
I never have done a closed, but now I'm planning to purchase a Piezo. So probably with that you have to do a lateral, you have to go quite laterally and then you can do it. It's called saline. So we have mobilized the bone completely now. ठीक है पीजो निकाल लो आइस को एक काम करो नहीं इट्स ओके ये ठंडा पानी डालो इसमें अरे यार गया पूरा गया सम भाई कुछ तो भी कर दिया तुमने
While the external camera is in focus, can you please show us the piezo device?
Yeah. This is a woodpecker piezo device. It has a handpiece and
can the audiovisual please? Yeah, thank you.
Yeah. Now you see?
Yes, sir.
No, like that. Especially
can you also show us the central console audiovisual?
Especially okay, now you can see that the nasal pyramid is absolutely straight and two parallel dorsal aesthetic lines are there. This is exactly in the center. Yes. So
yes,
I would just keep an ice cold saline over this for some time until the time I will do other work. भाई ये निकाल लो पानी निकाल लो वो बाउल निकाल लो कुछ नहीं चाहिए अपने को So till that time probably maybe external camera can show this. So this was so almost we have preserved about 2.5 millimeters of the septum. This was the entire septum we have preserved this part. We have preserved this part, and now this part is this, because this part was deviated and coming out. So we prefer to remove this. अभी इसका काम जिसका काम हो गया वो उसका निकाल लो बाहर.
So it was almost 3 centimeters long, sir.
It was more than 3 centimeters. इधर गड़बड़ नहीं होता नहीं मेरे को चाहिए. That is my space. इधर कचरा नहीं चाहिए. जो काम जिस चीज का काम हो गया यहाँ पे मुझे 11 नंबर ब्लेड देना है अभी.
Depends on what deformity.
Okay, so I want a straight piece of cartilage. Now look at my aim. What my aim is, I want an absolutely straight replacement of the anterior septum. Okay, so I'm going to and 2 spreadographs. So this is what I want. So this is a fairly long piece. So this is a fairly long piece. If I take it like this, it's a fairly long piece. So but yeah, you see that there was an angulation over here. There was an angulation over here. So I will sacrifice this. I will not take this part. So now this part for me is relatively straight. So I'll plan it so that I get the maximum projection.
That was pushed because of the septal deviation. Once the thing is in between, there is already a line.
So you see the replacement for the anterior septum, I want a big piece. So this is almost about 3.5 centimeters. Then I want 2 good spedografts. Which I think will surely come from this.
No, nowadays
The question is, what is the usual dimension of a spedograph? The dimension of a spedograph can be compared to a matchstick. Generally 2 millimeters by 2 centimeters. 2 millimeters by 2 centimeters. But when you use it as a structural graft, but this is true only if you are using a spedograft for opening up the nasal valves. But if you want to use spedograft as a structural support, I prefer that the spedograft should be a little wider, about 3 millimeters wide, 3 to 4 millimeter wide, and about 2.5 centimeter in length. I also prefer the spedograph if it goes inside. It's better for me. अभी मुझे 2 ये लगेंगे, needles लगेंगे बड़े वाले. Yeah. So at this point of time, I prefer C shape, please, and wash, please.
Only fancy looking indicator. It looks a little like even in the vegetable, sometimes it doesn't hard.
ये निकाल लो पिज़्ज़ो अभी. पिज़्ज़ो का काम हो गया है. पिज़्ज़ो बीच में आ रहा है अपने भी.
So here something like a boomerang.
So this is the these are the 2 upper lateral cartilages, as you can see here.
Yes, sir.
This is the central septum, which is T-shaped. Can you appreciate that T-shaped septum?
Yes, sir. We can see the configuration.
So this is not. This is like it's coming like this, and then it is becoming like this. So God has also made a septum in T shape. So if you cut it like this, you have to. So this is already acting as a spedograph, and that's why this concept of septal T. So I'm going to place a Spasmodic first, and then I'll fix the caudal septum to this. Okay. Yeah. Just about underneath the T. So I'm going to place 2 Spasmodics on either side. I will fix it up with the percutaneous needles. 40 PDS. वो मोहन को पता रहेगा. मोहन अपने बॉक्स में. Yeah. So we have retained in a partial extracorporeal septal reconstruction, we have retained the septum, the dorsal septum. Yeah, अपना है.
So cranially, these spreadografts are just touching the nasal bones, is it, sir?
Yeah, it's better they go underneath the nasal bone also. So that's what, if you want it for the aesthetic reasons or if you want it for a structural purpose. What are you doing? No, it's okay. So for structural purpose, it's better that it is underneath the nasal bones also. For aesthetic purpose, it's okay. Even if it is, but if you see that I have placed it just below the septal T.
Yes, sir.
So it will not even broaden the dorsum.
So if you need broadening, do you usually place it little more
You can
towards
place
the
it above.
dorsum?
You can also use it in an extended position if you want an augmentation. So those are called as beam grafts. So those are called as augmentation extended beam grafts. So if you want it, if you want a very good structural support, then it is called as a beam graft. The same Spasmodics, if they are wider and you're using it for a structural purpose. So in total septal reconstruction, when you replace the entire thing with a costal cartilage, so that time they are called as beam grafts.
This looks like a 40 only.
Like this. Yeah. So we have attached. कुछ भी मत निकालो भाई. कुछ नहीं चाहिए. कुछ भी नहीं. So now I'm going to fix the
reaction.
The anterior septal replacement graft to the nasal spine.
Okay, sir.
Tibial speculum. Sure. So you see this, I've passed the needles through the nasal spine, the drill hole that we made in the nasal spine.
You're using a 40 PDS to secure this graft.
So this is going through the nasal spine now.
Yes, sir.
Yeah, we've made a hole in the nasal spine. We made a hole in the nasal spine. इससे किया था ये Lindemann burr से. Yes. So now I'm going to replace the entire anterior septum like this. So this is going to be absolutely straight. So when we do this, this is absolutely straight, okay? Otherwise, I'll just make a small notch in the graft.
So in case we do a partial extracorporeal septoplasty and the spine is deviated,
You have to fix it on the opposite side of the spine then. That generally happens in facial asymmetry.
Right, sir.
Yeah. So it's better. I would never fracture the spine. That is my own personal preference. But I will fix it on one side of nasal spine. If it is still deviated, then I will use something called as a spacer graft. So you see this? I made a small notch.
Yes, sir.
This is going to rest in front of the nasal spine. So I'm going to make 2 to 3 passes like this.
So which needle is this?
Yeah, this is actually the wrong needle. This is a round body needle, that's why I'm finding it a little difficult.
Usually, which 40 PDS do you use, sir?
With a cutting needle, 16 mm needle. Suction. I think it is dislocated. The needles will have to do a complete extracorporeal. I think there is some dislocation at the keystone area. I'll show you how to do that. Do you have 20 number needle? 20 number needle.
So are you planning the TTC suture?
Yeah, I am planning a TTC suture also. C-shape. Needle. Needle. What protection you want?
So how are you determining the projection that has to be achieved here?
I just wanted a projection. No, you don't leave this, okay? This suture has also come out. According to me, the projection, the tip position should be about 0.6 to 1 centimeter above the anterior septal angle. And now that we are cutting we have cut all the ligaments, we have to fix it with a structural support like a cartilage, right? So in that case, you have to, the level of the tip should be about 1 centimeter. In Indian population, generally about 0.6, in her case, maybe 0.9 to 1 centimeter above the anterior septal angle, and also in front. So, needle.
One side is fine, the other side is inside over. This one side is resolved like Septoplasty.
So this septum has become completely straight now with nicely two nice pedografts. Yeah. Septum has gone down because of this pressure. That's why I always tell all my residents, it's only a finger. Because of this pressure, the entire Piston area has gone down. You should, it's very delicate. It's just like Stapes surgery that you have to do Rhinoplasty.
So do you have any more cartilage?
Yeah. Cartilage is not a problem. I see that the keystone area is gone down, so all my plan is now changed.
What are you planning now, sir?
No, I'm just planning a TTC suture.
Okay.
But I'm not happy with the angulation of the anterior septum. So I'll have to add another graft to it. It's called as a ansa-banner graft or a TO strut. So now what I see here is that give me a good wash. Sure. This, yeah, not too much, little bit.
So we can see a small fracture line that has.
Yeah. You see that? Yeah, that's correct. There is a fracture line. It got, because of the pressure of the speculum, this got dislocated and it got fractured from here, which it should not have got. So anyways, we'll still fix it. No problem. Okay. Just give me a वो 20 नंबर का नीडल आ गया क्या? 20 नंबर नीडल? हाँ हाँ, वही तो मांगा था ना मैं। 20 नंबर नीडल नहीं तो फिर ग्रीन नीडल नहीं तो ब्लैक नीडल, कौन सा भी चलेगा? ग्रीन, ब्लैक, येलो में से कौन सा भी नीडल चलेगा? I still prefer this burr. हाँ चलेगा चलेगा. I still prefer this burr over this cartilage. So in a TTC suture, I would like to tell you what is a TTC suture. TTC suture is a cutaneous transosseous camouflage suture. Now because of this, I'm also not happy with the angulation, so I'm just cutting it off. So this is a transosseous this thing camouflage suture. So in this suture, we pass a percutaneous needle passing through the nasal bones and also the so I pass a needle like this. Okay. You see the needle inside?
Yes, sir.
You see? Yeah.
It's over the right nasal bone right now.
When it goes inside, it goes. So so it passes through the needle, then the septum, and then the bone on the opposite side, and then it comes out through the skin. Then you saw that it has passed through the, give me a wash. Then I generally give a wash, just hold this here. Then I pass a suture. 40 is okay because I think the dislocation is not too much.
This is again a PDS.
Yeah, the same thing, 40 PDS.
Okay,
30
sir.
is ideal for such a situation. 30 is better. But then I prefer to take out this suture again. And then again, I still prefer to take a mattress suture. So I'll do it again from the opposite side. So in complete extracorporeal septal reconstructions, you have to do this, okay? So now, section. Just it was not the perfect position. Section, please. You see that the needle has come over there?
Yes, sir.
Give me an elevator. Now I feed, just give a good wash through this, please. No, through the needle. ये needle में से wash देने का. Yeah, it's okay.
This is to remove the bone dust from the.
Otherwise, whatever I try to put, nothing will go inside.
Yes, sir.
Then I feed it again through this, through the needle, through. No, don't do anything. Yeah, so it's coming through that side. Now I'll withdraw this needle. And then I'll take out this needle from this side again. Hold this. Can just cut it. This one.
In between.
No, don't leave it. Just leave it.
Yeah, I leave it.
Leave it there. So now you can see there are these two ends, and I'm trying I can talk. This will act like a mattress suture. So now you have to hold this. Unfortunately, there's some bleeding over there. Just hold this. So this suture is a little cumbersome. So that's why extracorporeal septoplasty is not so easy. If you can perfectly take this suture only, then I think you should be doing a complete extracorporeal. Otherwise, a partial also gives you very good results. Okay. Yeah. So now you can see this. This is now nicely aligned. There was some dislocation at this point, but now it is okay. There was a dislocation at this point, but now it's all right. Very gentle. No. Rhinoplasty is like Stapes surgery. No pressure at all. Hack adapter, yeah, you should use hack adapter. My hack adapter, two of my hack adapters went bad, so they're for repair. Yeah. So it was initially it was designed like this. It was then Dr. Sebastian Hack got an adapter in his name. Okay, now just give me C-shaped retractor, and that's why I always insist that you should hold it very high on the forehead. You should never put a pressure on this. Okay. Now I'll fix the upper lateral cartilages to the septum. needle holder. So after this, I generally try to take a running suture to this 5-layer sandwich. So this happens, although this happens very rarely, the dislocation of the septum, dislocation of the keystone area, but you should know how to handle it. So I'm glad it happened. Although it happened to me, it happens maybe once or twice a year, every year. So you should know how to handle this complication. According to me, this happens to every good rhinoplasty surgeon who does a good work. What do you say? You have encountered around this kind of situation, Hina? Anytime? Here it was not too much, so that's why I'm not so much worried.
Yes,
so I'm not happy about now we come to the tip projection. So I want to add a graft, which is, I want the tip position to be like this. I want the tip to be at this position. Okay. So now this is the anterior septal angle for me. And I want the tip to be at least staying up at least 0.6 centimeters or 0.9 centimeters above the anterior septal angle. Okay. So I would like to add a graft. So this graft, they call it as an ANSA banner graft. But if you give it an angulation, then it is called as a TO graft or a TO strut. So this is generally designed majorly for an aesthetic reason. This is only an aesthetic graft, no functional implications. एक और भी ऐसा है. This is a little too wide for me, so I'll slice it up to 1.5 centimeters. No, 11 number. So I'm just slicing. This was a little too bulky for me, so I'm slicing it to 1.5 mm. Yeah, C-shape, 2 needles. You have to put it at one point, and then you have to see what angulation you want it at. So you can do this. Okay.
Right.
So this makes the tip a little less stiffer as compared to the proper septal extension graft. So the tip mobility will be a little better than this. But while doing so, you always have to judge it from the side. Okay. Now this has to be fixed at 2 points. At 5 points. Okay. As described by Tioman Dogan. This has to be fixed at 5 points.
Five points at the septum.
On the septum, I'll tell you what 5. So he has described it that you have to take one suture like this. Cut please. ओ भैया कट करने के लिए मदद करो. उन सर को दे दो, वो कट करेंगे. हाँ हाँ बहुत बड़ा. I think it's a cut through. Medium, not sure. Five zero periods then.
So do you perform other procedures like in this case you said there is a concha bullosa, or if there is a fess indicated or adenoids, do you do it in the same sitting?
It can be done. The only thing is it should not be an infected face.
Right.
Yeah, if it is not infected, then yes, you can do it. Concha bullosa and rhinoplasties should be done in the same sitting. Even nasal polyposis is not an infected thing, so even nasal polyps you can remove. But for that, it becomes very difficult after doing an osteotomy. So if you want to do it, if it's better you do it before. Thoda chota.
Do you do a CT scan in all of your rhinoplasty cases, sir?
Yeah. Because if it is associated with sinonasal disease, then it's better to address that, because so at this point of time, wash. Give me a good wash. Good wash. Now coming to tip sutures. The lateral crus is not very strong, so I don't want to do any kind of cephalic trimming, and only preoperatively the tip width was a little too wide.
Yes, sir.
So we'll control the tip width with the help of tip sutures only. So we generally identify the dome. We generally would identify the domes, then hold the dome because it's very flat, and create a tip defining point. Pass a needle through this, then take a suture. Yes, then we take a suture. So nowadays I'm taking this cranial tip rotation suture.
Yes, sir.
So this is basically a Kawachevich modification. So this, you have to take it in this way. So earlier we used to take a mattress sutures, but that causes pinching of the dome to some extent, and also the tip, the dome position of lateral crus can also be got into a desirable position if you take it like this. So if you take it like this is called as Kawachevich modification of a cranial tip rotation suture of a transdermal suture. The needle nikal. So now I'll just tighten this, and you see the lateral crus becomes more horizontal in orientation. You see this?
Yes, sir.
Yeah. So lateral crus has become more horizontal in orientation.
Dome is also better defined.
And dome is also well defined now. Yeah, cut please. हाँ, ये बहुत बड़ा हो गया ये. Similarly, on the opposite side, we identify the dome, the domal segment. It's better that there is some soft tissue. You remove the soft tissue on the domes. Then you hold the dome, pass a needle, then I take a cranial tip rotation suture. Earlier, it was just like a mattress suture. I've realized that this is the way Sebastian used to dissect it. It is not really required to do it in each and every case. If you do it like this, you can achieve a similar result. And if you're not able to achieve it, you then have to do that.
Yes, sir.
Now, yeah, you see this?
Vestibular skin does not need to be separated in all the cases.
Yes, not in all the cases. Yeah. Sometimes if it's just not happening, then yeah. Caesar, please. Chupa diya. Okay. It's after this, you have to get these domes to the perfect position. Needle, please. And then you have to join these two. So this is one step which decides your nostril symmetry. So I do take a lot of time deciding this perfect position. Hmm. Hmm. Tweezer, ये इधर है. Hmm. Hmm.
Are you planning to use any freedized cartilage, sir?
Oh, yeah. I always generally use a freedized cartilage because in Indian population, our radixes are a little low, all of us. So that's the reason I used at least a radix, pre-radix augmentation in almost all the cases. Please cut. ढीला हो गया है थोड़ा सा.
So this suture that you're taking is to reduce the supratip dead space, is it, sir?
No, this is just one additional suture that I always take. Yes, it's loose actually. I'll take it again. And I've seen this is not a classical intradermal suture, but when we take this suture, the lateral crus again becomes a little more horizontal.
Right.
So probably I'll just publish this soon. यार ये नहीं जम ठीक है देखो. I'll just take it again. This was not perfectly done. Mm-hmm. Mm. Okay, cut this. Mm-hmm. Then I'll take no. Leave, just keep it over. Then I'll probably take a classical interdermal suture. The earlier one which I took was a dermal equalization suture. Section, please.
Yes, sir.
Now this is a classical interdermal suture. I'll also incorporate the TO strut.
This is a 50 PDS that you're working with, sir?
This is the 50 now. Earlier for all the structural work, I somehow prefer 40.
Okay, sir.
I'll just redrape and see. So now this is a good, as you can see, this is a very good tip diamond that we have got. This is a very nice tip polygon that we have got.
Yes, sir. Looks quite straight.
This is also not, you should not pipe it like this in the rhinoplasty. After doing osteotomy, absolutely gentle. After doing osteotomy, absolutely everything is very delicate. So no pushes, no mopping, no wiping. So जो मेरा ऐसा रहता है वो पोछने का किधर है?
Are you planning any other grafts, sir?
I'm just planning. Yeah, the dorsum is straight from the side, so this dislocation is okay. I see a little fullness over here. This side it's a little excess. 15 number देना. 15.
So what was the instrument that you used to measure? Was that a caliper?
Yeah. It's a curved caliper. I prefer that. Scissor. I'll also take a spanning suture because I'm not happy with the orientation of these lateral crusts. They should be more vertical. They should be more horizontal. Now they are more vertical. We should never tie this to bada thoda sa. Wait a minute. I'll just some soft tissue here, which I may just remove.
Yes, sir. So do you ever score cartilages?
Yeah, you have to do it sometime. C shape. Yeah, there was some soft tissue over there which was giving this a little bit strange convexity. I'll just put a shield graft and also an ala rim graft and some free dice cartilage on the dorsum. That's all. Okay. Number. So I'm just preserving some cartilage for the ala rim grafts, and rest all will go for dicing. So this is the shield graft, and these are the two ala rim grafts that I've preserved. Rest all will go for dicing. ये dicing करना है सब कुछ. Just take the dicing board and start dicing. Take 1 ml syringe and छोटी needle. ठीक है. नहीं, ये भी इससे भी हो जाएगा. Just take out all this cartilage. Just give me 1 ml syringe and DL लिया था ना? DL ही लिया था, ये इधर है.
Can you explain the alar graft, the advantage of using an alar graft?
If you feel that the alar lobule is getting isolated from the tip lobule, it's only in those cases you have to use alar grafts. ठीक है, ये पूरा ले लो और उसको खीमा बनाने. Do it, don't worry. You only do it. On a stable background, do it.
So the shield graft is augmenting the lobule as well as the columella, right, sir?
Yes, but it is shield graft is for infratip lobule.
Yes, sir.
If you want if you want only for tip lobule or supratip, if you only want it for tip lobule, then you can use a cap graft.
Okay, sir.
This is, but what I do generally, I use a very large septal replacement graft, so that it all projects inside the nose. It all gives a very good projection. Then whatever infratip lobule deformity is there, I generally correct with this. Yeah, do it on a stable background. Now this is better. Now I'll put alar rim grafts if I feel that this is a tip lobule, these are the alar lobule. If they are not perfectly in the continuity, then I'll put an alar rim graft. Just give me a double hook. Yeah, good. ये निकालो ना सर, एक मिनट. This is a bone. I'll give you more. Just no, it's होता है कभी कभी. क्या देगा? नहीं, this is a lateral crus. Yeah. This is a part of a lateral crus.
So what is your protocol of post-op packing and antibiotics?
I generally don't pack. I put a Doyle splint only. I put a Doyle splint, and antibiotics I use Augmentin for IV Augmentin for about 2 days. थोड़ा सा एक काम करो ना, थोड़ा वो side में. I think you'll hit my head. So I'm making a pocket like this.
So this pocket is along the margin of the ala.
Along the ala rim, as the name suggests. I think the graft is a little bit projected, so I'll just reduce the height to. I'm reducing the height by 1 millimeter. वो रैपिड वाइक्रिल देना.
रैपिड वाइक्रिल. हाँ, रैपिड वाइक्रिल रैपिड.
50 है. Then I put this graft in the ala rim, so it supports the ala rim and make it straight. So these are the ala rim grafts. Okay.
Yes.
So
sir.
now you see there was a subtle deformity over there, which is now gone. Can you see this ala rim now? Ala rim, this rim is straight. And
Yes, sir.
The tip lobule and the alar lobules are in line. Okay.
Yes, sir.
Yes. Yeah, so it's looking good to me. I just want to place some feed ice cartilage on the dorsum to make it a little more smoother.
Yes, sir.
Otherwise, this looks fair. थोड़ा बीच में आ गया. तो मुझे ये दे दो ना अभी. Rapid वाइक्रिल. Yeah. मेरे बॉक्स में डॉयल स्प्लिंट है.
जो मार्जिनल न्यूट्रिशन खुला रखेंगे, बाकी सब कुछ डाल डालते वो मार्जिनल
So when do you remove the Doyen splints?
Generally after it gets blocked. So after putting the Doyle splint on from the second day, I ask the patient to start breathing more through the nose.
Yes, sir.
Because it may so happen that if the patient doesn't breathe through nose, then there are secretions and there are कुछ नहीं करने का. And then you have to ask if it gets blocked, then anytime after 5 days.
Okay, sir. Do you give any nasal drops immediate post-operatively?
Yes, I give a spray, sole spray,
Okay, sir.
so that it will prevent from forming the crust from the second day itself. नहीं यार वो नहीं, इसलिए मॉप ही नहीं करना है एक बार, राइनोप्लास्टी में मॉप नहीं करते हैं। तो पानी मारो जितना मारना है, पर मॉप मत करो। ठीक है. So now I'll just take some quilting sutures. This I have taken with 5-0 rapid Vicryl because 6-0 rapid Vicryl is not available in India. But you should not do it with 4-0 rapid Vicryl, which is readily available. Yes.
So what is the purpose of this quilting suture?
It's just very nice suture. Any mucosal indulations and mucosal irregularities are also straightened with this. I also take this with from the medial crust. So even the medial crust deformities are treated sometimes.
So in case there is a foot plate flaring, that can also be addressed.
Unnecessarily cutting the foot plate and all becomes a overkill sometimes. And this is because I've never seen Gubish also doing any exclusively foot plate work. It's all just suture the foot plates like this and it's going to be okay.
Sometimes that also gives a very unnatural look if it's modified too much. Have you ever encountered any septal perforation due to tight suturing in this area, sir?
Never. Septal perforation, if there's any breach, can definitely happen. Not because of tight suturing, never. Otherwise, if there's any breach, you should repair it right away. मुझे ये देना थोड़ा पैक अपना. नाक में थोड़ा अपना जो 4% वाला पैक है वो. Before putting this Doyle splint, I'll just, good enough. With the help of with what?
So very nice demonstration, Kshitij.
Thank you, sir. Thank you very
Dr.
much.
Dubey here. And one mistake I realized, I should not have made Hina as your moderator, because you see, you both are understanding a lot of things. And not discussing the basic things. There are so many questions are there.
Yes, sir.
So the next lecture of Hina is how to become a rhinoplasty surgeon.
Yes, yes, yes.
I think in this, she is going to explain all these things. And now you will put a free dice now?
I'm going to put a free dice and suture the lateral incision and a splint. That's all. If you want to go ahead with Hina's lecture, no problem.
No, no, I think we will see how you put a plaster over there. She is connecting her laptop,
Okay, no problem, sir.
right?
Yeah.
No hurry. You just show us free dice because I have seen that you Indian rhinoplasty surgeons who are the new stalwart of rhinoplasty like you and Viren Ghaisas, changing everyday concepts. Previously, I used to see that you take very large temporalis fascia graft, put dice cartilage into it and put that over the dorsum. But now I think you are going to inject a free dice cartilage.
Dice cartilage. I did it only for about 1 year, sir. Very frankly, and I failed very badly. All of my almost, according to me, 50%, more than 50%, more than 50% of the DCF that I did got absorbed, or rather, maybe more than 70% got absorbed. All those 20-30% also I followed with them very well. They didn't complain because of the good osteotomies and all. But even in the patients who did not complain, so they had some absorption. So depending completely on a dice cartilage wrapped in fascia, it generally comes from the European population and the Caucasian kind of noses. All this has been discovered and invented by Turkish people, and that's why it was earlier called as Turkish delight. Now, in Indian situation, I don't know if the skin is different or what. So I'm injecting this. This is a free dice.
Yeah. Free dice cartilage, right?
Yes. I'm injecting it on the irregular areas which are there.
So it will remain there with plaster.
Yeah. So, and then I nicely
spread it with your finger.
spread it. I place 2 fingers like this.
Okay.
And then I evenly distribute it with the help of my fingers. So all the irregularities which are there will
looks
be gone.
very smooth, right?
Yeah. So this is how it will look smooth. इसको बिल्कुल मॉफ नहीं करने का. नहीं, once osteotomy, no mopping at all. It's only.
So we will have you in PIP. I think Hina can start her lecture now.
Yeah, I just.
Okay, we'll see. Moment. Yes, please.
Just I'll show you the result, and then maybe we can.
Of course,
do
sir.
the rest of the things. So,
right.
Yeah. So can you just get that thing? I'll just show it with the help of this camera only.
External camera?
No.
With VTOM.
Mohan bhai, idhar aaja. Take it out. No, it's okay. You come from this side. Yeah. So this is the.
Oh.
So this is the
You can come. Oh, excellent. You have a big clap for.
So this is the front view. And
new definition you have given to her nose. So this is the side view.
Yeah, no. This is the front view. So
Yeah.
straight dorsum.
Yes.
This is the side view. And this is the side view.
Side view we are not seeing.
The VTOM picture only.
VTOM picture. Yes. Now we get the side view. Right. Very good.
This is the side view. And
the radix is now defined.
Yeah. This is the basal view. And
this is the basal view.
Here. Yeah, this is the basal view. And this is the 3/4 view.
Right.
I think with this, I think I'll just do some suturing and plastering. And we can go ahead with Hina's lecture.
Thank you. It's a nice treat to watch you, and you have big applause for your work. I think that lady will be happy. Now we'll start with Hina's lecture.
Sure.
So how to become a rhinoplasty surgeon? Hina is a very proficient rhinoplasty upcoming surgeon, and now she delivers lectures everywhere, and she is my rhinoplasty surgeon. Few of my patients she did, and they are doing very well. So please listen this lecture. Yeah, she's ENT, not plastic. Okay, Hina, go ahead.
Now it's better.
Sorry. Good evening, everyone. I'm Dr. Hina Bakshi from Indore. The topic given to me today is how to become a rhinoplasty surgeon. So I'm assuming that we have a 50-50 ratio of people who are experienced surgeons and as well as budding ENT surgeons. So I believe that learning is a journey and not a destination. My learning started from my undergraduation from Indore and post-graduation from Belgaum. I was very lucky to have found the best of mentors in Dr. Jankiram at Trichy. I was there for 1 year where I learned how to become a surgeon, how to handle tissues, how to respect the planes, and how to be bold but yet careful. And I was second time lucky to again meet my mentor, Dr. Virendra Ghaisas, with whom I trained for about a year and a half. I then went to Germany to observe with the stalwarts, Professor Gubish and Professor Hack, who is now the head of the plastic surgery department of Stuttgart Marian Hospital. So definitely that is the traditional way to go to be proficient in rhinoplasty, to get lots of hands-on training and visit the stalwarts. But even the experienced ENT surgeons can also start their rhinoplasty surgery. How to start is by analysis, a thorough preoperative analysis. Analyze all the faces, all the noses around you. Evaluate the patient as a whole, not just the face or not just the nose. One should see the personality of the patient, the psychological aspects of the patients, whether the patient is coming alone to your OPD all the time with unusual expectations. You should see the ethnicity of the person, whether he belongs to the northern part of the country or the southern part. They all have different facial features, different skin, different proportions of the face. One should also see the height of the patient. A very tall patient would not like a very up-rotated nose. A short patient will not like a droopy nose. So these are the basics that one has to see the patient as a whole and not just the face or the nose. And then you go on to the facial or the nasal analysis. The preoperative evaluation should be an amalgamation of the psychological analysis, the aesthetics, and the function. Psychological analysis, one should be really aware of the body dysmorphic disorder, wherein the patient has unusual expectations. The patient is usually very specific about their demands, and they have usually had multiple, something wrong with my laptop. I think it's stuck somewhere. So usually these patients have a lot of specific demands, and they have visited a lot of ENT or plastic colleagues, and they are usually talking in very specific medical terms, like I want this kind of a tip or this kind of a nasolabial angle. So
yesterday, one patient came from Mumbai. He has consulted Dr. Virendra Ghaisas, then consulted today with Kshitish Patil. And what Hina is saying is absolutely right. He has got 1 page technical details that I want my, even I cannot remember those technical things. He is from Jakarta. So ultimately, Kshitish says that you are a dysmorphic personality. You take a psychological evaluation, then only I will operate you. So it's really, you should know when to say no, that we will not operate you. Now your laptop is working?
I think it's stuck somewhere, so I'll talk anyway. So after thorough psychological evaluation, next comes the facial proportions and the various angles that have to be evaluated. So on grossly, if you see, the face is divided into vertically 1/3 starting from the forehead or the hairline to the glabella, and glabella to the I have already restarted it. Yeah, I think this is working now. So the facial proportions have to be studied. For that, the prerequisite actually is a good photography setup. So one should have this kind of an arrangement in their OPD. You should have a decent DSLR camera with a 50 mm portrait lens. And the light arrangement should be such that behind the photographer at an angle of 45 degrees, there should be 2 light sources. You can have a ceiling mounted flash installed, or maybe a tabletop flash, which is available quite easily in any of the camera shops. And the subject should be placed at a fixed distance. Your background should be fixed, so that in all your cases or all your records, you have a uniformity and you are able to analyze your own cases better. So this kind of photos usually come from a mobile phone. The first picture has been taken too much up close. So there's a fisheye effect that you can see. Same person, the picture has been taken from a distance from a mobile phone again. And the proportions look slightly different. So one should avoid to take pictures from a mobile, especially very much up close. Try to take from a DSLR camera, but sometimes it's not possible. So maintaining a distance of maybe at least 4 feet or more would eliminate this fisheye effect. Try to have a uniform background, uniform light setting, fix your corner so you can eliminate these kind of differences. So seeing all these views, that is the frontal, the lateral profile view, the basal view and the oblique view, you must be able to analyze and imagine the entire anatomy of the nose, entire placement of each cartilage, and how the deviation is affecting the external nasal appearance. One should be able to analyze by these pictures. So on the frontal view, one should analyze the facial proportions, the skin type, quality, any asymmetry or deviation, the dorsal aesthetic lines, which are nothing but light reflections on the dorsum of the nose, depending on the configuration. The bony vault, if it is deviated too much broad, the middle vault, which is the middle third of the nose, the tip, the alar rims, the alar base, and the upper lip position. So the facial proportions, we all know the theory that horizontally and vertically it is divided equally into 1/3 and 1/5. And any gross facial asymmetries need to be preoperatively addressed and discussed with the patients. These kind of patients with gross facial asymmetry, even after giving an absolutely straight nose, patient might complain that there is some kind of an asymmetry because the whole face is grossly asymmetric. And you might even want to offer some adjuvant procedures in such cases, for example, some kind of fillers or fat injections to equalize both sides of the face. The dorsal aesthetic lines are play a very key important role in the aesthetic nasal appearance. These lines are nothing but light reflections on the dorsum of the nose and follow the leading edge of the dorsum. So whenever we take the pictures, the importance of flash is that it enhances these dorsal aesthetic lines, and it is a guiding light for us. The bony vault usually is accounts to about 70 to 80% of the alar base width. Any broadening requires narrowing via osteotomies, and any deviations or asymmetry has to be looked after. This is a case of a wide base bony width. Usually it is also described as the widest part of the nose at the maxilla. These are cases with middle vault splaying, wherein they will require reconstruction in the middle vault, maybe in the form of structural grafting, extended spreader grafts, and good septal support. The nasal tip should be studied well. A triangular configuration usually is desired, and it should be well defined. There should not be any boxy or parenthesis deformities. Alar rims are usually, if you draw such a line on your pictures, you will be able to see a gull in flight arrangement. Any retraction, that is the wings going up, or any collapse, the wings going down, or any notching needs to be preoperatively seen, and accordingly you need to do certain maneuvers to correct it. These are cases of the right one you can see has lot of alar notching. The gull configuration has, the wing configuration has gone up, whereas here you can see an asymmetry. Next to see is the alar base. Alar base width should approximately be equal to the intercanthal distance. Any flaring, if it is going beyond the intercanthal distance, especially on smiling or facial animation, a large nostril size, any alar base or nostril asymmetry also needs to be analyzed. Here are two cases of a wide alar base, wherein an alloplasty, an alar base reduction, or a cyst reduction has to be planned. Next is upper lip or depressor septi muscle overactivity. Sometimes in some cases you might notice that a droopy tip becomes even more droopy or comes even more down when the patient smiles. This is because of overactivity of the depressor septi muscle. It is usually attached at the caudal border of the septum and needs to be released or addressed in such cases. Coming to the lateral view, on the lateral view, there is the nasofrontal angle. The radix, as we saw in the previous case, was a little depressed. Here, this picture you might see over and over again. This is actually my cousin who I was trying to analyze. So I've taken her pictures and made this presentation on. So radix in her case also you can see is a little depressed, and she has a pseudo hump, and her dorsum needs to ideally be projected a little bit more. So on this view, you also see the tip projection, the relationship of the ala and the columella, the lip-chin relationship, the tip rotation, the nasal length, dorsum, supratip, and if there is any periapical hypoplasia in cases of binder syndrome or cleft lip noses. So this is the nasofrontal angle, and you can also see that we can, there is some little bit of radix depression. These are two cases of an overprojected dorsum and a saddle nose or a depressed nose. In this girl, you can also see that there is a hanging columella. The columella is much more than 2 to 3 millimeters from the alar rim. Next is the tip projection. The tip projection, roughly, it is said that 50 to 60% of the tip should lie anterior to the vertical line from the upper lip. So that is how you see the tip projection. In this case, this is a case of a partial binder syndrome, where there is, of course, a periapical hypoplasia along with anterior septal deficiency, and it is a highly underprojected tip. Whereas the other picture shows an overprojected tip where most of the nasal tip is lying anterior to the vertical line drawn from the lip. The tip rotation is determined by the nasolabial angle. It is usually desired to be obtuse in cases of females and around 90 degrees in cases of males. So these are cases of both a deprojected and an overprojected tip. The ala-columellar relationship, usually a 2 to 3 millimeter of columellar show is considered normal. So there can be many deformities related to the ala-columellar relationship. There can be a retractile alar rim, where the alar rim goes way beyond the desired position, and there can be a hanging columella. Both of them we can see in this picture. This picture is she has a retracted alar rim, where you can see a little bit of notching, and this girl with the hump nose has a hanging columella. Sometimes there can also be a combination of both these deformities. There can also be a periapical hypoplasia or premaxillary deficit. In this case, it needs to be augmented with either with a solid rib cartilage or disc cartilage and fascia. On the basal view, the aspects to be studied are the nostril symmetries, the columella, if any deviation is there or there is a bifid columella, the nasal projection, the alar base and alar flaring. The nostrils should ideally be tear-shaped and they should be symmetrical. The alar rims, if they are concave, or there is a pinch deformity, it's usually there in a very boxy tip, wherein the lateral crust of the lower lateral cartilage is deficient. It goes too much cephalic, leading to a pinching deformity. In this case, it needs to be derotated, needs to be augmented, and an articulated alar rim graft needs to be placed. In case of very convex alar rim or thick alar rim, that has to be addressed via an alloplasty. So in this case, you can see that there's a boxy deformity along with a caudal deviation. And this will need to be augmented, and the lower lateral cartilage will have to be derotated cephalically. This female has thin but very wide and ballooned nostrils. The columella in this case is little bifid, and here you can see a deviation of the columella and pushing of the foot plate due to the deviated caudal septum. The oblique view gives a few additional information about the contour of the dorsum and also should be kept for record. Next comes, of course, the endoscopic examination. One has to see the status of the septum, whether any septal perforation due to previous surgery or abscess, any internal nasal valve obstruction. The level of obstruction needs to be determined. Any adjuvant turbinate pathology, sinusitis, polyposis, or adenoids needs to be addressed as well. So the conventional septoplasty cannot always give the perfect results. One needs to adapt to the principles of septoplasty. We often get such cases in our OPDs who come for nasal obstruction and want septoplasties. Here, this young gentleman has already undergone a septoplasty for nasal obstruction, but his nasal obstruction was never cured. So he had a high deviation, along with, you can see that there's a bony and cartilaginous pyramid deviation. This female also had a very complex S-shaped deviation with a fractured septum. Her endoscopic picture was available with me. So on the right side, you can see that the level of obstruction is almost near the middle turbinate. And on the left, there's an anterior deviation leading to the internal nasal valve collapse. So there are many classification systems available for deviated nasal septums. So I believe that septal tilt and localized septal deviations can very well easily be treated by a conventional septoplasty technique. But all these complex deformities like severe septal deviations, combinations of various deviations, S-shaped deviations, high deviations, mid-dorsal abnormalities, caudal deformities, and anterior deviations needs to be addressed via an open septoplasty technique. Or even if we address them through closed septoplasty, the septum needs to be released from all the areas, especially inferiorly, posteriorly, sometimes even the caudal end, to give a good straight septum. So in open septoplasty, the advantage that we have is we have an excellent exposure wherein we can release the septum from all its attachments, and most of the straightening is already done, as we saw in the case previously. So the septum, this picture that we can see is actually of that gentleman that I had shown the picture of, who had already undergone septoplasty. So this is the kind of fractured septum that he had, and this can only be addressed if we do an open technique. So these are the cases that come to us in OPD on a regular basis. She has a fairly good nose. There is not much of a gross nasal deformity, external deformity. She has a caudal deviation we can see in the basal view. But on with the open septoplasty technique, this is the kind of finer result that we can give. There is a subtle change in her lateral view. You can see that the hump has been reduced. The nasolabial angle is better and the tip projection is better. And of course, the deviation is gone. This is a case of a C-shaped anterior-posterior deviation. On On the lateral view, you can see that the nasolabial angle is absolutely acute. This affects the parabolics of the nasal airflow. And post-operatively, this is the kind of result that we could give: a straighter dorsum, more aesthetic, and of course with good function. This is again a case of cephalocaudal deviation, C-shaped deviation with caudal deviation, leading to pushing of the ala that you can see. There's an asymmetry of the ala. And this is the post-op result. So open septoplasty definitely has the advantage of giving an increased angle of vision and good access. The release of septum leads to accuracy of the deviation correction. This is also the foundation surgery for all the advanced rhinoplasty techniques. So one can start their career by doing an open septoplasty and then advancing on to doing other rhinoplasty techniques. And other critical factors that contribute to nasal obstruction, that is the tip rotation, the parenthesis deformities, anterior nasal spine deviation, valve dysfunction, all can be addressed via an open technique and thus leading to better outcomes. So one should never hesitate to pop the hood, start opening the noses, and definitely you will deliver better results. I would also take this opportunity to invite all of you to Indore for our live surgical rhinoplasty conference that we are holding in the month of March in the year 2024. And we'll soon be opening registrations, and I'll be happy to host you all. Thank you.
Thank you very much for excellent demonstration. I think the message is very clear that if you want to become a rhinoplasty surgeon, then you should start doing open septoplasty, because sometimes C-shaped and upper deviation is literally becomes very difficult to treat with conventional method. So try to open up more noses for septoplasty and then go ahead with the other complex thing. May I write, madam?
Yes, sir. Absolutely, sir.
So if OT is ready, we have the last case today. It's a auto, or any questions are there, you can free to ask with madam. Hello, OT. Hello. Yeah.
Now I request Dr. S.P. Dubey sir to please felicitate our speaker, Dr. Hina Bakshi, for such an excellent presentation. I also request him to felicitate our chairperson, Dr. Nitin Shrivastava, sir.
Chairperson for the next.
Dr. Vijendra says always that he has gone to one CNT academic conference and there were only two. He is the speaker and two chairmen were there and one audience. But he has delivered lecture with full vigor. He says even one person is there. So I have to deliver my stuff to that single person because he has came all the way to attend my lecture. So this is the last osteoporosis surgery. So if you are interested, please stay and see the magic of Dr. Deepak Haldipur. He is a very excellent ear surgeon.
Chairperson for the last session is Dr. Bhagwat Chaudhary, Dr. Ruchir Vashne, Dr. Anupriya Hajela. Please come forward.
So I think Chief Minister is busy in election, but he came to our hospital in the morning to facilitate Dr. Jaikumar Menon and Janki Ram, because he has got, he always blessed us with his blessings. So he came early morning there before surgical session starts, and Jaikumar and Janki Ram was very happy. So meanwhile, when they are preparing, I think the short video they have recorded, they are showing you. our course director, Dr. Sanjay Agarwal, has to leave for Indore because his mother is having some problem. So he went there. Otherwise, he is the last person to go from the hall. Janki has already posted all his stuff to the Facebook. He is the Facebook master. OT1. Hello. Nobody is there. Let me ask.
क्या वो कितना टाइम डॉक्टर की तुम बोले कि डिस्कस कर ऑडियोग्राम वगैरह क्या है दीपक भाई कहाँ है बुला यार खानो ना बताओ सकते के बारे में दिखा लिया डिटेल
I think Jaikumar was telling that we can have a phonocon, midterm phonocon, not this year, but next year in Bhopal. He is going to talk to their central governing body. So it will be a one-day conference, and we will focus like in this way. We have focus on case discussion because ultimately we should have understanding. Even for rhinoplasty, I think we should have a case discussion. First, we understand what is the pathology, then only we can treat those pathology. Because the term that they use, they brought, I think, more than 50 types of grafts were there, and so many types of sutures are there. So we should have a clear understanding of what is the pathology, then only we can go ahead with the cases. So, phonocon we will have next year. Date will be decided soon, then I will convey to you the dates.
Yes, sir. So people are waiting for you in hall for your demonstration. So please kindly discuss the case. Okay, and tap your rest.
फाइनल ईयर में तभी पूछा कुछ दूसरे आपको जेल सर है ना मेरा सर डिसीजन जब गुजरात में तभी हम लोग 2-3 बार एग्जाम में साथ में थे कई बार हम लोग मिले हैं अहमदाबाद में भी एग्जाम सर को एकदम ग्रेचुटी
भाई आप कुछ मार्गदर्शन करना चाहते हैं मेरी कर लिया सब कर लिया सवेरे से वही कर रहे हैं सबसे पहला सबसे आखिरी में जा रहे हैं
हाँ 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 ऑन कर अभी हेलो
यस यस दीपक सर
अरे दुबे सर
हुकुम
अभी भी हाल में कोई जान से बचा है क्या
मतलब हॉल में आप समझ लो ये डेडिकेटेड 30 लोग हैं आपको फोटो दिख रही होगी ना हमारी वहां पर आपके टीवी स्क्रीन पर वी आर हियर
मुझे लगता है आपने डरा के इन सबको बिठा के रखा है एनीवे अभी चालू करता हूँ
मैंने उनको आपके फ्रेंड विजेंद्रा का इंसिडेंट सुनाया
हाँ
Vijendra is already used to tell that if I go there, even a single audience is there, I will give my lecture with full vigor.
Yes.
Because he has come into the auditorium, so we are sitting here. So you have to justify our presence.
When I look at you, I remember the movie Sharabi, where when Jayaprada comes to dance and she finds only one audience sitting there, and then he says, "ये हजारों तालियों की गूंज अगर सुनाई नहीं दी, नहीं?"
बिल्कुल सही कहा आपने। आप इधर हमारी तरफ से देखिए, आप कैमरे की तरफ देखिए सर, पलट जाइए आप।
एक कलाकार जो इंसान को कदर नहीं करता, वो कैसे कलाकार हो सकता है?
सर दीपक सर, हाँ यस से अभी हम अमिताभ बच्चन को देख तो ले पहले। कैमरा इस तरफ है आप।
In 5 minutes, I'll get ready. Okay.
Okay, sir, please.
And this is a case of right stapedectomy. Basically, the airborne gap is about, I think, yeah, about 40 dB, 50 dB in the lower frequencies. And in the mid frequencies, it's about 40 and 35 with a typical Gerhardt's notch. So looks like it's a classical otosclerosis.
I think you will appreciate your surgical benefit.
Yeah. And the only thing is, you know, when hearing loss is around 44 or 45, there's a chance that there's a small focus near the fistula and fenestrum. And these are foot plates which can be prone to floaters. This can become a floater. That possibility is always there. Not like a much deeper loss, but there will always be surprises. Let us see.
So you will do with the conventional instrument like perforator, or you have a skeeter with you? Because I know that in Bangalore, you always do with laser, CO2 laser. You have a big series with CO2 laser.
CO2 laser only. But skeeter also we can use, contra-angle burr also we can use. And let us see. No, contra-angle.
I think most of the people don't have a skeeter or laser. So if you show us conventional technique or with your contra-angle handpiece, so we'll be grateful to you.
Yeah.
Right.
Contra-angle, yeah.
Contra-angle, we have so many.
Okay, I'll take one.
Yeah. In cochlear implant, we are rich in contra-angle.
बेटा contra-angle handpiece देना. और अगर छोटा diamond burr है तो एक छोटा diamond burr. Okay.
चलेगा हमारे।
देखिए मैंने वो कॉक्लेस्टोमी में यूज करते थे, कॉक्लेस्टोमी परफोरेशन, ट्रांसकैनाल परफोरेटर, उसी में लगा
निकल नहीं जाती, मतलब गलती से भी नहीं जाएगी। अब अपन तो खोल के कर रहे हैं, भोपाल टेंटिंग में पूरा होता है इंक्लूडिव से कर रहे हैं, तो वहां पर भी अगर आपने पीजोटोम लगा दिया तो फिर पीजोटोम तो जैसे सॉफ्ट की रुक जाता है, एकदम सेफ। अभी उसको मैंने एक डिजाइन करने के लिए बोला है परफोरेटर की प्रोब, क्योंकि प्रोब थोड़ी मोटी है, तो डिजाइन कर रहा है चाइना वाला। अगर वो आ गई देन वी विल शो इट नेशनल कॉन्फ्रेंस में दिखाएंगे, पेटेंट करा देंगे जैसे उसने करा हुआ है कटे ने। मुबारक है।
वो तो रोज नया पेटेंट निकाल लेते हैं, थोड़ा मॉडिफाई करते हैं।
So this is the Vitome you can see. This is the Vitome. Vitome is costing now 9 lakh rupees. वो था बेटा, वो Vitome का था, Vitome का। मुबारक का वैसे वो भी ऐसे ही है, एंडोस्कोप
ऐसे ही है ना। 1.5 लाख में दे रहा हूँ।
पहले 60 से शुरू किया था, सारा तेरा पेपर था पब्लिश करेंगे, उसकी फ्री में देगा। कहता लो ना सर आपको।
लोकल कोड
कल आए,
कल बस दिया लगाने
ಎಷ್ಟು ಇದಾಕಿದೆಯಾ?
दोनों बच्चे
Xylocaine V13 ना
क्या बोल रहे हो
10cc ತಗೋ,
ಕಾನ್ಫರೆನ್ಸ್ के टाइम में
ಅದಕ್ಕೆ ಫ್ರೆಶ್ ನಲ್ಲಿ ಇನ್ನು ಒಂದು 10 ಡ್ರಾಪ್ 24 ನೀಡಲಲ್ಲ
ಮಾಡಿ
ये लेकिन बहुत ही सिंपल और डाउन टू अर्थ है। पर मालूम है इसके फादर को किया ही हो,
अच्छा इसलिए सवेरे नहीं आया।
इसीलिए कल पूरे दिन था गायब थे, आज सवेरे आया नहीं। तो आज सवेरे आया तो कंपनसेट कर देंगे, वो कल सवेरे आया तो विजय रात को मैं रहूंगा तो
बाकी सब हेड एंड थोड़ा लो कर दीजिए।
लेकिन हालत सारी ऐसी कि
हाँ,
ले जाना पड़ेगा।
नहीं तो ये पिलो निकाल देना,
वरना
वन
तीनों
ऑफ द टू। हेड एंड लो, नॉट टेबल लो, टेबल उल्टा, बस पेंट को
तारीफ कर देगा। दो तीन बार बोला मैं डायरेक्टर कैसे कर रहा था। मतलब आप सोचो मैंने कितना ट्रेंड किया, तो वो क्यों ट्रेंड हुआ, पीसीआर की तो नंबर ज्यादा होते हैं। दूसरा ये कि कॉर्पोरेटर डायरेक्टर हमको एक लड़की आई थी पेरिस से हमारे यहाँ फेलोशिप करने के लिए 10 दिन के लिए, वो हमको उसने पूरा सेट किया।
नहीं
वहां से भेजा उसने
बाल निकाल के।
उस समय जब वो थी हमारे यहाँ ना, तो मैंने उससे गोल्ड का एक इम्प्लांट करवाया था, एक टिश्यू पर, और वो विवेक सारंग को बोल के मैंने उससे बनवाया जाके सुनार को।
मैंने भी बनवाया, मैंने बनवा के लगवाया, वो बहुत महंगा है, बहुत महंगा है, करना ही था। मैंने पहले सिल्वर का बनाया, फिर उसका चेक किया, फिर गोल्ड बनाया।
4,000 का बन जाता है,
बट उसमें क्या है, वो 5 ग्राम का जो 24
हम कहा मना किए भाई,
सॉफ्ट रहता है, तो वो 5 ग्राम का उसने पूरा बोला कि सब तोड़ना पड़ेगा, तो 1 ग्राम 2 ग्राम बचने में तो चार्ज ज्यादा लिया।
कायदे में तो आपको उसकी कितनी बनवा के उसको रखवा के
वही करवाया, सिल्वर करवाया मैंने, सिल्वर में बनवाया क्योंकि, बट सिल्वर में सब टेस्टिंग थोड़ा मुश्किल होता है, उसका डेंसिटी ज्यादा है, वो साइज बड़ा बनता है, उतने ही वेट का।
अच्छा,
सिल्वर का वेट हो
बत्ती कोड़ा
साइज ज्यादा बन जाता है, उतने में वेट।
समझ गया, मतलब इसका घनत्व कम है।
हाँ, मतलब बैठ के बनवा के उसके पास सब लगाया, उसको बुलेट इंजरी था, वो बड़ा खुश हो गया।
So Deepak sir, which implant you are using regularly? I mean, you are using Teflon or titanium?
Teflon only, Teflon.
Teflon. Which company Teflon?
I have seen Satish using titanium. That also looks impressive, but that is expensive.
It's a Kurd implant costing 18,000 rupees.
Yeah.
So Satish will get it at 11,000 because he does lot of number.
Yes.
The company gives it 18,000 rupees.
Yes.
Even sir,
So
Teflon has done so many qualities. Even the decibel people give Teflon in 200-300 rupees, and Gyrus people are giving little costlier 1,500. So which brand you use?
I use Gyrus.
Gyrus, okay.
Yeah. It is somewhat midway. See, because titanium at even getting at 11,000 or 18,000 or whatever, see, they give it at 11,000 if you order huge numbers like what Satish orders. For us, I think they would still give it at 18. And in corporate hospitals, if you buy the material for 18, then including the markup price, to the patient, it will cost anywhere between 30 to 36,000 for the piston alone. So it may not be economically viable.
And now one company in Ahmedabad, Eon Medical, they are also providing some Teflon piston, and it is relatively cheaper.
Eon reasonably looks good. We need to use it and see. That's all. Dr. Dubey, actually, this surgery is such a all or none surgery.
Yeah.
That somehow you feel it's not worth taking the risk also, but probably in places where it is less affordable, local, I think it's worth trying Eon Meditech also. Once upon a time, the Indian audio company was making good implants. Scissor bekkana, hair cut madakya. Hair scissor.
Which company, sir? Indian company?
In the Chandigarh company, remember Sattu, Indian audio.
Indian audio. Yes.
He was making a good one. Then somewhere in between, he closed the company or lost touch. I think his quality is not that good. Decibel also not very,
So infiltration with the commercially available Xalicon adrenaline, or you have got some special preparation for you?
Ideally, I would like to use freshly added adrenaline.
Okay.
But here what is available is with adrenaline. That is also okay. Again, the bottom line is to inject first and drape later.
So that it will have good
That way,
effect.
about you have that vital 7-8 minutes before you put in the incision. So I think that is the key. Ideally, better to use a little more adrenaline than what you would use in tympanoplasty. So my teacher, Dr. Mahadevaya sir, used to use, 10 cc of adrenaline mixed with about a quarter ampule, 10 cc of 2% xylocaine mixed with a quarter ampule of adrenaline separately, out of which he would use maybe about 2 cc.
Okay.
Yeah.
So you don't have any 1.5 inch needle you are giving with conventional 2 ml needle?
No, actually, see, even in tympanoplasty, my sir used to use a 23 gauge needle, the light blue color one, 1/2 inch.
Yes,
1 inch. And actually speaking, especially in people with thick canal skin and slightly obese people, you try injecting with a 26 needle, you have to put a lot of pressure. And unless you have a lower lock disposable syringe, you can have a lot of extra vessation also. If you get into the right plane, like how my chief did and taught us, 23 needle is the best, Satu.
Okay.
Which actually pushes the solution well. You need not have to do multiple pricks. 26, 1.5, I use more in FES or any nasal cases. Yeah. But
So you are infiltrated. I can see that you have infiltrated in incisura terminalis. So you will have endoral
No.
approach.
The purpose of infiltrating in incisura also, a leash of vessel comes there, so your upper incision sometimes tends to bleed.
Okay.
So if the canal is very narrow, I may do endoral. And in extreme cases, I think in the last 33 years of my stapedectomy practice, in 2 cases I did post-oral. The canal was so narrow. So nothing wrong in doing post-oral also. Dr. Jankiram does most of his stapes post-oral. As long as your hemostasis is good, the exposure I think will be even better in post-oral. I think the only fear is that you may give infection. I don't know how you can give an infection, because if you can do a mastoid, CSF otorrhea, closure, everything with the post-oral incision, why not a stapes? And again, that scar goes into the groove, so it is cosmetic. I'm not an advocate of post-oral stapedectomy, but if somebody is comfortable doing it and can give good, safe hearing and safe stapedectomy, that is also okay. See, approach is an approach, like how you do in cochlear implant.
Right.
Whether it is posterior tympanotomy or varia or Bhopal, whatever technique.
Right.
Your implant should not get extruded, infected and form a biofilm or lead to meningitis. And your flap over the implant should not undergo necrosis. As long as you can manage these 2 things, approach doesn't matter.
Right, sir.
Yeah. Suction Tipakama.
Subramaniam used to make, we had only 2 person who used to make the Teflon. Need to make the Teflon kitchen from
Yes.
Make around 20 to 20 Teflon per day.
Oh. One of the senior fellow who is sitting here, he is telling that Dr. Subramaniam from South India,
yes,
he used to make his own Teflon piston by Teflon block. By one block, he was used to make 50 pistons.
Yes.
And at that time, only few surgeons, including Subramaniam, I think Mahadevaya sir and KKR, they were doing STPs in India.
No, even Mahadevaya sir and KKR, they learned from Subramaniam. Mahadevaya sir used to tell me that Subramaniam was his guru.
Oh,
in
so it's
Stapes. And Subramaniam also used to import this thing,
Teflon block.
Xylocaine from UK.
Acha, xylocaine, okay.
Even the xylocaine that he would inject, he would import it from UK.
So always you put betadine in canal.
Yeah, previously we used to use spirit,
But not.
30 years back. Now we have given up on spirit.
But in Stapes, usually we get very clean canal.
Yeah.
Autosclerosis means.
Is that? Yeah. But somehow this is one surgery. I always remember my chief telling me that this is one surgery that he is always a little apprehensive, even after doing so many hundreds of surgeries. Because
this is all in one.
Till the posterior coronotomy gets through well, you're not very sure, you know. It can make you look like a wise man one day and a total big fool on the other day. Yeah. This is one surgery that anybody would be. I think surgeries itself,
Yes.
when they go well, you feel like a hero.
Yeah, you're right.
When it doesn't go well, you sometimes wonder, why did you take up this profession?
Yeah.
Yeah, it can be quite exasperating, depressing.
No, I think all the ENTs who are doing surgeries, they will agree with your statement. Sometimes really even doing so many surgeries,
yes,
you think why we are doing this? We should invest and enjoy the interest.
When surgeries don't go well, you envy the cab driver also for his job. It is the absolute truth. After 33 years of surgical practice, 1990 February, I think 27th is when I did my first tonsillectomy. I can tell you that. No?
You remember date very specifically why?
It is important, no? It's like your marriage date. It's an important event in your life when you do your first surgery alone. Isn't it? Yes. Lampert speculum. Let me just saline, please. Just trying to wash away the remaining traces of betadine.
Yes, sir.
Now I'll go to higher magnification. I'm just taking a little time to get the overview.
So how you like this, our new microscope? We have got this new microscope.
No, this is a very good microscope. Very good
Armamentarium.
microscope. Yes.
It's a, I think, it's a, what is the name, Deepak? I just forget. Written over there. Extero 300.
Yes.
It's not very bulky, but the optics are very good.
Yes.
300.
Just like Satu, slightly bulky but good.
So we are having a clear picture now.
Yeah, double end knife. Let me start the first incision just above the malleus here.
Yeah.
Little anterior to that, about 2 millimeters anterior to that. Because occasionally you can find a fixed malleus.
Very good point and valid point.
Yes.
Please centralize the picture, sir, little bit.
Yeah. Because some surgeons feel that condition doesn't exist at all. But I have seen maybe about 10 to 12 cases, at least in my career, where the malleus was fixed. Then you need to go anterior to the malleus and take away a small portion of the double-end knife.
So double end miss, it's a round knife and flag knife both.
Yes. Circular knife on one side, and then this portion you can even use the flag knife.
Yeah. This word always I listen from Vijendra, double end.
Yes. Because we come from the same school.
Yeah.
The Baswan Gudi school of learning.
So the anteriorly, the incision which you have given anterior to the handle of malleus and superior part, it usually has got very thin, thick skin.
Yes.
And invariably when we get that, there is a tear or some mucosal tag is there. So how to avoid that?
Which one?
When you go superiorly towards the handle of malleus, the skin is thick.
Yes. No, you can do a sharp incision there and then elevation, because it is basically the tympanosquamous suture line.
Okay.
Where it is attached, yeah. Cotton kodo. You saw in the tympanoplasty I did today also, we elevated that area. Suction, 20 section, there.
You always talk suction with numbers.
Yeah.
I've seen you whenever you demonstrate, always say your assistant 20 number, 18 number.
Yeah.
मैं कहता हूँ मोटा दो, पतला दो, इससे भी पतला दो. So tell us, which number of suction should be remembered during Stapes surgery?
No, when you start with 16, because initially the incisions and all will lose. But as you elevate the flap, then what happens is, if you take a thicker suction, by the time you put the flap keeps falling back.
Right.
Because of the suction itself. So
Very
first you start
point.
with 16, double-end knife. Idala old double-end. Elevation
So these things are very important. You see how delicately hugging the bone he is elevating the flap.
Yeah.
Because ultimately after the surgery, if you have any tear in the flap, so it becomes mood off. Your mood get off immediately.
Yes.
So we have to take care of these small things, how he is placing the cotton. That way Deepak Haldipur is a very cool surgeon. I always admire him because he has got a lot of patience. No hurry.
Apparently cool, no? No, I mean, ultimately getting impatient or getting tensed up will not change the outcomes. It is like, as Jaikumar Menon was telling today, double-end knife kodu. It's like Dr. Jaikumar Menon was telling me, like people shouting in the airport, When the flight is delayed. When the flight is delayed, people keep shouting at the ground staff who have no control over the arrival of the flight. Just today he was telling me about the Bombay flight.
It delayed like anything because we have received him at 1 o'clock in the morning.
Cotton? Yeah.
It was scheduled to land at 10. It got delayed, yes.
But one of the finest laryngologists that the country has seen. And
I always tell him that you always advocate that you should speak with less speed. But you see the Jayakumar's speed. It is very high.
Okay.
But he is not having any sulcus vocalis or anything.
No, he has a very good voice. He has a very good voice, and I think that Malayalam as a language itself is spoken very fast. So they all speak fast because of that, possibly. double-end knife. But all said and done, people like, Satish Jain, Jai Kumar, Janaki, Vijayendra, they're all a real big asset to our country.
Definitely.
Because not everybody can afford to go to Germany to get trained.
But they can go to these places now in India.
Yes, yes, yes.
That is what Janki was saying, that me and Satish have changed the rhinology. Jaikumar sir, you have to raise your voice.
Small circular knife. Yes. Yes.
See how gradually he is elevating the tympanomeatal flap with utmost care, delicately.
Yeah, because Sattu said tear 2 times. So now I'm worried. Alligator forceps.
And these packs are soaked in a pure adrenaline or diluted?
No. The same one which I use for injection.
The same.
I use that only. Sometimes if the oozing is robust,
then you use pure adrenaline.
Then you can use pure adrenaline also. Generally, I have not had much problem so far. So,
Here local.
the only important thing is, once you make the fenestra,
Okay.
please
Yeah.
don't use any adrenaline.
Yes, sir. Sir, this is you are doing for the demonstration purpose under GA. Routinely, how you do your Stapes surgeries?
GA.
GA only, okay.
GA. Because one thing is I have realized now, the more educated the patients are,
okay,
their pain threshold is less, their anxiety is more.
True.
When you make the fenestra, they start hearing loudly. A lot of them react to suction also. There are eminent surgeons who are very comfortable doing it under local. And they do equally, in fact, sometimes better work. But ultimately, as a surgeon, if you are not comfortable, then there's no point in trying to do under local.
I think you just reached the annulus and we are seeing the mucosal layer there.
Yes, I always tell people create a blue line.
Blue line, yes.
Between the chorda and the annulus. No?
Nice.
Yeah. So that way what happens, smooth cut pick, you take a smooth curved pick and then you just go in that plane, your elevation in one smooth stroke.
Oh, very nice.
Becomes easy,
Right.
And you have also protected your chorda. You can see the malleus.
Incudostapetal joint is very clearly visible.
Yes.
My favorite round window is there.
Cotton.
I can see the cochleostomy there.
Cotton, yeah. In fact, that is another thing, Sattu.
Yeah.
We have become a little more confident Stapes surgeons because by chance the patient has a profound SN loss.
Yeah, we can go for cochlear
You can still offer him a cochlear implant and save his hearing, and you save yourself from the medico-legal problems.
Right.
Yeah.
But you always advise your patient and you always tell them that you have an option of hearing aid clearly.
Yeah, Sattu, but one thing is, as the alligator forceps, cotton. See, first one cotton take it, Buddha. As my friend Manoj Manikot has observed,
yes.
One thing I tell you, you would have also seen the situation where you have done a successful stapedectomy on one side, and after some 15 years or something, they come to you for stapedectomy on the other side. Many of them have developed a SN loss.
SN loss, yes. True.
Airborne gap is so. Nowadays it is better if one side is successful, you go and do on the other side 1 year later. 1 year later, but double-end knife.
Absolutely right, sir. Because if the patient comes after 10 year, 12 year,
Yes.
definitely other side, if you compare the audiogram,
Yes.
SN loss is there.
Yes. Smooth cut pick. See, Satu, now most of the oozing has stopped.
Yes, absolutely clean field now.
Yeah. See, the biggest enemy of any surgical field
Is the blood.
is bleed, and bleed. Okay. And the best antidote for bleeding is patience, and patience. Got
Right.
it? And it's not that we have taken a lot of time or something. We are still going at a good
Yes,
pace.
yes.
Yeah. So,
You are going with your commentary. I mean,
yeah. I am one of those surgeons who talks 10 times better than he operates.
no, but this time surgery is very good. Field is very good.
No, so far.
And
it is
ultimately,
good. So far, so good. Yeah.
that is why we are not sleeping. We are awake and enjoying your surgery, literally. Even after it's a long day today in comparison to yesterday, but we are enjoying your surgery.
Yes. And not only that, Satu, thanks to the YouTube and all that,
Yeah.
a lot of people watch.
Yeah.
I'm surprised that quite a few people called me in the afternoon after my tympanoplasty.
Yeah.
My dearest friend and younger colleague Arshad called me. He made some critical comments. So did
Critical. How dare he is to make the critical comment? I will ask Arshad.
No, that's what I like about him. It is the critics who make you better. Isn't it? For a creative person, I feel the biggest poison is the applause. See, there is a small tear here.
Yeah.
Can you see in the canal skin?
In the canal skin.
Not to worry. Yeah, not beyond the annulus. Double-end knife. So, despite all the meticulousness, we had a small tear, but luckily not beyond the annulus.
Sir, you always raise this flap up to the 6 o'clock. Even if you have not risen this much of, you can do your step is upwards.
I mean, Cotton, I will quote Janki.
Yeah.
Surgery is all about exposure, and exposure. If this flap stays away, you can even put a small gel foam and keep it away.
Keep it away, right.
Yeah. You can keep a wet gel foam.
So it's an important point.
Yes. And keep it away. That keeps.
Otherwise, it will fall again and again if you raise only up till.
Especially when you start using a diamond burr or something.
Yeah.
By the time your attention will not be on the flap. So there's a good chance that,
Good point.
it's better to. And what do you lose if you elevate it in the right plane?
Yes,
like how I could manage in this case, it will just sit back like a curtain. The length of your elevation will not make the step of putting back the drum difficult.
ये step is चल रहा सर दीपक हल्दीपुर सर का अरे वाह very good so Jaskaran is watching your surgery in Delhi because he has to catch the flight from Delhi to Amritsar. You are absolutely right. People are watching there because of the YouTube and link.
Jesse जैसा कोई नहीं.
Jesse जैसा कोई नहीं.
You remember there was a serial where Jesse would come, but that was a different Jesse, not looking like our Jesse. Yes.
We are, I mean, in this, though the bony projection is there, but we can see at least incudostapedial joint here. But you have to remove the bone.
Yes. You're right. See, I would love to see the facial nerve
Yeah.
in its second genu and the base of the pyramid. So first you flake away this portion of the bone.
So you're using which curate? I mean, it's a
Skull stars.
Yes, yes. That is what I want to listen, because so many people advocate that you should have a very genuine curate if you want to curate the bone there.
Yes.
Otherwise, you have to struggle. Huge instrument in which you have to invest.
Smooth cut pick. No, even good quality Kalelkar curates are also okay. Only thing is, they may get a little blunt a little earlier.
You have to change.
Yes.
So Carda, you are putting aside from your.
Some surgeons, like my friend Suri Prabhu, he cuts the Carda straight away.
Okay.
With a scissor and proceeds. I think, if I am right, that's what he does. One thing is proved.
Yes.
Abnormal stretching of the chorda leaves a longer time of taste disturbance compared to. Yes.
In place of stretching, if you cut, then
if you notice, contrary to the conventional teaching, lower down where the chorda gets, rises from the facial, I use my curate little below upwards. I don't go above downwards.
Sir, please centralize the picture.
Yes, boss.
Lateral cases will be a problem if you are used to cutting.
Sir, if a bilateral autosclusion from the audience, if the bilateral autosclerosis is there, if Suri Prabhu is going to cut the both quarter tympani.
I don't know, I have to ask him.
Okay,
but I can tell you, I had a couple of patients of cholesteatoma in whom bilateral chordas were sacrificed. Not immediately, but in gap of 1 month. Even they regained their taste sensation to a large extent. 2 of my own patients, cholesteatoma. Not Stapes.
In cholesteatoma, I think cutting will not affect much.
Why?
Because it is already involved in the disease.
So whether the disease involves it or cutting involves it, that means it recovers, no? See, here surgically you may be cutting it. There the disease, the halogenase and the peroxidase which is released by the cholesteatoma, those enzymes basically chemically inactivate the chorda tympani nerve. Isn't it?
Okay.
Yeah. Smooth cut pick.
So you say that you will like to see what are the limits you want to see for exposure?
The facial nerve I need to see.
Okay.
That is most important for me. Number 2 instrument. There seems to be some, mucosal bands between the.
Yeah.
Yeah, I am releasing it with a fish hook.
Near the incudostapetal joint.
Yes, now I am able to see the foot plate.
Yeah.
Seems to be fixed.
Even the stapedial tendon we can see a little bit.
Yeah, curate.
Though it's a young man, but your curate is working very good. It's a young, stout man of 30 years.
Yes. No. If once you get the chorda out of the harm's way,
okay,
you can even use the drill later to take out the remaining thick bone. But I'll try to stick to the curate initially right now. See, now I am coming conventionally like this.
Up to down.
Usual movement, ice cream shaving.
Yes.
This is the classical teaching in Stapes. Now I'm just getting probably a glimpse of the facial now.
And we can see very clearly foot plate also.
Yes.
Posterior crura is visible.
Yes.
Just below.
Yes. There is a focus of otosclerosis between the facial nerve and the foot plate, I think. There's only a small portion of which is blue. But anyway, let's not worry much about that. Right now, I just palpated the incus. See if the foot plate is fixed. It is fixed. You can see the otosclerotic focus just beneath the incus. Smooth cutting. At this stage, it's also better to move the malleus.
Yes.
The malleus is mobile, the incus is also mobile. I can see that. Okay?
Yes.
Only the stapes is fixed. Curate?
So usually what is your limit? What you want to see after curating the bone? What the boundaries you want to see?
I should see the second geno of the facial nerve.
Okay. That is superiorly.
That is in this area.
Okay.
This area.
And below, you want to see the stapedial tendon or what?
No, base
pyramid.
of the pyramid.
Base of the pyramid. Right. Please centralize the picture.
Yes, at least either the base of the pyramid or you should be able to see the posterior crus very comfortably.
Okay. We are having the glimpse of that.
Yes. Yeah, 1 minute. Manu? Gel foam.
Now it is very clearly visible.
Yeah. Maybe I'll come a little down, then you will see it even better. Yeah.
We'll keep away with gel form this quarter tympani.
Yeah. Because I'm thinking this bone is thick. I need to drill a little bit. Cotton.
Yes.
You keep a moist cotton
Okay.
or, a gel foam. Gel foam kodu innondu.
Keep away the corda.
Yeah. ಸ್ವಲ್ಪ ದೊಡ್ಡದೇ ಕೊಟ್ಟು ಇದು ಫುಟ್ ಪ್ಲೇಟ್ ಹತ್ರ ಇಟ್ಟರೆ ಎಸ್ ನಾನು ಸ್ವಲ್ಪ ದೊಡ್ಡ ಜೆಲ್ ಫೋಮ್ ಕೊಡು ಬಿಗರ್ ಒನ್ ಎಲ್ಲ ತಗಲ್ತು ಬಿತ್ತು.
So usually at your center, you are doing this with CO2 laser.
Yes, yes.
Most of the cases.
All cases. Only when the foot plate is very, very thick, then maybe I don't. Otherwise, I do.
So you order CT scan in all cases or only audiogram?
Audiogram is enough, but to confirm the diagnosis, you can sometimes do a CT also. Nothing wrong. If you have CBCT or a multiplanar CT, drill kodu. ಯಾವ್ದು ಹಾಕಿದೆಯಾ ಇದರಲ್ಲಿ ಈ ಬರಕ್ಕೆ ಸ್ಪೀಡ್ ಎಷ್ಟಿದೆ ನೋಡು.
Sir, one of the delegate asking question.
Yes.
Can we predict the audiological finding on the base on the basis of audiological finding thickness of the foot plate?
Yeah. But the best thing is CBCT.
Okay.
TBCT is the best investigation.
Less radiation, more information.
Yes.
Even it requires less space to install.
Yes. Yes.
How much RPM? Delegate is asking of your
This is a
drill.
marathon motor you have, so there is no RPM in this.
But it's
I'm using it at low rotation. They have given me a
lower
smaller,
rotation.
smaller marathon. You remember which we used to use?
Long
Yeah.
because I like that machine. Whenever I go anywhere to do the implant, that machine is very good. You can have 4 or 5 in your OT, no problem at all.
Multipid, yeah?
Some damage go because it cost only 5,000-6,000 rupees.
Yes. Yes.
पेट खराब हो गया अब वो अगले दिन सर्जरी मैंने बोला यार पेट को रिपेयर करने वाला नहीं है उसका पैर खराब हो गया बोला,
Only, yeah. The handle is movable, huh?
I always seen you doing dry drilling in this part. I always see. Is there any
Because I
advantage?
don't want a lot of bone dust to go into the
Okay.
this thing, mucosa. Give me the suction, please. I put all those gel foams and cotton precisely to prevent that only.
Right.
Yeah.
So tell us boundaries, what we are seeing now.
Yes, curate. Yeah, number 2 instrument. There's one more mucosal band
Yeah.
here.
Yes.
Can you see the facial here?
Yes, yes, very clearly.
Yeah.
Yes.
You can see the facial. Right next to that, you can see the dense focus of otosclerosis.
Yes.
White one.
White bone.
In a U-shaped, and next to that is the blue foot plate.
Yes.
Yeah.
Even one small blood vessel is running over it.
Yeah, that's the beauty of your microscope.
Oh, thank you.
Yes. Gel foam.
Can
Can you see the geno of the facial nerve?
Yes, 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 very clearly visible.
Yes. Alligator forceps.
I think this X0300 is not very bulky, but at the same time, optics are very good.
Yeah. Gel foam. I told you it is just like Sattu, but you didn't agree. Isn't it? Yeah. Suction, please.
I think Stapes is the surgery in which you should take your own sweet time, but do it very diligently.
We are taught, as I keep harping again, the Baswangudi school. You remember we used to buy video cassettes at that time too.
Yeah.
We went to workshop and all. I always remember what my chief said. The surgery may take 10, 15 more additional minutes, but the results are for a lifetime.
True.
For the patient. And he was actually quoting another great surgeon, Hugo Fish.
Yes.
So, when you would like to get operated, would you like to get operated by a surgeon who has all the time in the world for your disease, or a surgeon who is very busy? Isn't it? Curate? So I think we are almost done with it.
Exposure part.
Yes, number 2 instrument. There's a little mucosal adhesion here.
Yeah.
Can you see that coming out from the pyramid?
Yes, yes, very clearly.
You can see the entire genome of the facial nerve.
Yes,
taking the turn.
it is, yeah, taking the curve.
This is the kind of exposure I usually like to have. These are my limits. Superiorly, where the long process starts becoming the body.
Right.
You stop here. You should see the entire facial nerve. I can see the posterior crust fairly comfortably now. I
Yes,
can
sir.
also appreciate 2 strands of mucosal adhesions there between the posterior crust and this thing.
Tendon.
Only one part of my technique is different from everybody else. What is it, Satu? Number 2 instrument. Can anybody in the audience tell me?
What? What you ask?
Only one aspect of my technique
Yes.
is different from everybody else. Can you tell me what is it?
One lady is saying that you are holding the lampet speculum all the
Absolutely.
time.
Absolutely. You see this?
Yes, yes.
I don't use that black speculum. I don't use self-retaining retractor up to this phase. I do it with lampets because it gives me that maneuverability.
Okay.
Yeah.
So she is a young ENT surgeon, Anupriya Hajela from Bhopal.
Okay. Okay. Only problem with that is you need.
Again and again, you have to apply, reapply.
No, the left hand becomes strained.
Yeah, strained, yes.
And because you are holding it like that for nearly 35-40 minutes, no? That is the only thing. Yeah.
And your boss, Dr. Mahadevaya and Vijendra, what they do? Do the same?
Vijendra uses a black speculum.
Okay.
Mahadevaya sir puts a release incision in the 11 o'clock position and uses the self-retaining speculum from the first step.
Okay.
Which I have put now. What speculum I have put now is Mahadevaya speculum.
Okay.
From this stage onwards.
You will use Mahadeva's speculum, self-retaining.
Yes. Yes. It got a 0 perforated. Picture is clear?
Absolutely clear.
You're happy with the exposure?
Yes. We can even see the blood vessel running over the foot plate.
Yes,
very clearly.
that is the remnant stapedial artery.
Okay.
Yeah, usually it is so thin only.
So you are making a fenestra.
Yes.
With point perforator size?
3 mm.
3 mm, 0.3. 3 mm perforator, right. So, seems to be thick.
No, maybe, not very thick.
So you are doing at the posterior most part.
Yes.
And it is which perforator? It's a fish perforator, again with the stars, or it's a local perforator from
No,
Karel?
stars.
Stars. देख रहा हूँ चीजें अच्छी लेनी पड़ेगी. So you hold it between your thumb and your index finger
Yes.
and just putting there, not giving much pressure, and that just a screw movement.
Yes. I've got a small opening there.
Yes, some impression is there, right?
No, but maybe, I mean, ನೋಡಿ perforator blunt ಇದೆಯಾ ನೋಡು.
So your gyrus piston's diameter is how much? Your
0.4.
0.4. So you are using perforator right now 0.3.
Yes, yes.
3 mm. Okay.
It looked blue.
But it's hard.
Maybe it's hard, or maybe. But anyway, this is one step.
Oh, very good.
You keep talking, and then, you know, yeah.
You will have a way now.
Yes. Small gel foam.
A small pulsation we can feel and see.
Yes.
So what precaution or what technique any budding ENT surgeon should use while using perforator?
Just rest it on the, you know, this one. Smallest diamond bar idea nodama. Ide small, idikina small idea nodu. Ide small. Inyavdilu nam tarlilva. Let me see. Speed ಕಮ್ಮಿ ಮಾಡು ಒಂಚೂರು. ಇನ್ನು ಕಮ್ಮಿ ಮಾಡು.
So now you are using to plan a bigger perforator or
No, ತುಂಬಾ ಕಮ್ಮಿ ಮಾಡಿದೆ.
drill?
ಅಷ್ಟೇ. No, 1 minute.
I think diameter is 0.6. It's a bigger diameter, I think.
No, this is a step.
Okay.
Which I picked up from Dr. Ashish Bhumkar.
Okay, putting a gel foam there and drilling little bit posteriorly.
Yes, weakening the posterior crust, not breaking it completely.
Yes.
Just weakening it. This is the smallest burr I seem to.
We have even smaller than that.
1 minute. I'm trying to get a even smaller than that.
धर्मेंद्र दो स्मॉलर दो बेटा, सर को परेशान मत करो. Here just over the crust.
Yes. Suction. Suction blocked. Manu. Yeah. Suction.
You see, Dr. Haldipur is sucking just away the fenestra. Not
Yes,
to worry.
because you can't suck the perilymph, no?
Yes, yes.
Number 2 instrument. And I use this fish hook very frequently.
Okay.
It's a very good instrument to take away the small bits of tissue. Can you see the footplate much better now?
Yes, definitely.
Initially, we were thinking that this is to one side. No, this is the otosclerotic focus.
Yes.
This is the facial nerve. This is the other side of the footplate. And now almost 60% of the posterior crust is also drilled.
Yes.
Okay?
Yes, sir.
Now we can, now gently you can widen the
Fenestra.
Yeah. So I'm taking away the mucosa right now.
Yes.
Okay.
The fenestra already seems to become big.
Yeah. And remember, for beginners, when you widen the fenestra, try to do it posterior to anterior. Okay. In this direction.
Okay.
Because the otosclerotic focus, this part is fixed. This part is fragile.
If you go posterior,
23, 24 suction. Yeah. 22 na 23 ilva. Irvek nodu. So again, you see, I will do the suction not on the fenestra.
yeah, away from the fenestra.
Yes. 4 mm piston, 4 mm perforator, 5 perforator, 6. Yes. So now, 4 mm perforator. Okay, now you give me the 5 mm perforator and then the 6 mm. You can appreciate the fenestra becoming wider. Hello?
Yes, sir.
You can see the fenestra gradually getting wider.
Widened. Yes, yes. We can appreciate
6
that.
mm perforator, yeah. See, it is better to be well versed in all techniques. Because on a given day, your laser machine may not work.
Right, sir.
Some other day, your skeeter may not work. And some unlucky days, even your contra-angle handpiece may not work.
But
Okay?
these, yes, sir. But these basic instruments will always work.
Yes.
So enough widening is done.
Yes. Yes, small right angled.
We can see the right reflex from the fluid.
Yes, that's the beauty
It's
of your
shining.
microscope, Satu.
Oh, thank you.
Now at this stage, I would like to dislocate the,
Inculostapetal joint.
yes.
With your exposure, yeah.
Again, go in the direction of the Stapedius
Tendon.
tendon. Okay.
Yeah.
Gel foam.
So if little blood goes into the fenestra, no problem.
Because the pressure of the perilymph is much higher than the blood.
No, it will push
The,
it out.
the vestibule will not allow your blood inside.
Right, you are right.
Previously, people used to worry, you need not worry. No. Blood is your friend. Problem is the fragments of the foot plate. Alligator scissors ಇದೆಯಾ?
I will cut the stapedial tendon.
ಯಾವ್ದಮ್ಮ? ಇವ್ರದಾ? Oh, 1 minute. No, this is little wider. Sickle knife ಇದೆಯಾ?
So you will cut close to the
Pyramid actually, but the scissor prongs are little too wider. The crocodile scissors, ಈ ಚಿಕ್ಕ crocodile scissors ಇಲ್ವಾ? ಇದು ತುಂಬಾ ದೊಡ್ಡದು ಕಣ ಇದು. ಇದು ಪ್ರಾಬ್ಲಮ್ ಏನಂದ್ರೆ ಇದು ವೆರಿ ಕ್ರೂಡ್. ಸಿಕಲ್ ನೈಫ್ I usually use alligator scissors.
But it is too wide.
Today the one which I got was too wide. I thought it would, Number 2 instrument kodu. Let me make sure whether my stapedius tendon is cut.
I think it is cut now.
Yes. Yes. Now, one more. Yeah, gel foam. Chick gel foam.
Chick का मतलब छोटा. Yeah.
I think another maximum 15 minutes, Satu.
Oh, no problem. We are glued to screen and we are watching your surgery and everybody is very keen to watch.
Yes.
So it's all or none surgery. You take your sweet time. We are here to watch you.
Yes, because the most important structure in the entire stapes is the posterior crus.
Yes. All the accidents happens there only.
Yes. Despite your, Yes.
Please centralize the picture, sir. Thank you, sir.
Yes, boss.
Thank you.
Suction.
I think you have drilled the posterior crus completely.
No, better make sure,
Yeah.
Yeah.
Yeah. Yeah.
Because as I told you, this is one step which.
Yes, yes, your.
Yeah.
I can see it is tilting towards the round window.
Yes, yes, yes.
Because you have fractured it.
Yes. Smooth cut pick.
You are taking out. Good.
Yeah, you can see that.
Yes, we can see the whole structure. Anterior,
Yes.
posterior crus, head of the malleus.
Yes.
Very clearly, the suprastructure of stapes is coming out. Some mucosal
Yes.
tags are there
Yes.
inferiorly.
Alligator forceps. Now I don't need to worry about this because it won't
Yes.
damage anything when I take it out. Okay.
Right, absolutely right.
I think piston length measurer.
So this piston length measurer of which company?
This is Medtronic
Medtronics. Okay.
and even piston cutter Medtronic.
So,
Looks like it will take in a 4.5.
so marks are there in 3.75, 4 and 4.5.
No. 3.5, 4 and 4.5.
4.5, right.
The 4.5 is corresponding to middle of the incus.
Yes.
Which means, this piston, if I put 4.5, it should be adequate. Or maybe 0.25 mm longer. I'll try and put a 4.5 only. Otherwise, I'll cut it to 4.25.
Okay.
Okay.
Right, sir.
Again, see, suck gently.
Away from the
The
fenestra.
edge. Yes. Piston this is the Ion Meditech. Huh?
It's Ion Meditech?
Yeah. You are using that, Satu?
It's from my OT. Okay, then. Yes, Ion Meditech Teflon, not
Teflon.
titanium. Yes, Teflon. It's a good piston I'm using.
Okay. L piston idea. Huh? No, this is torp beta. Ye to torp hai re. वो दिखा जरा दिखा.
ये पिस्टन और टॉर्क में फर्क नहीं पकड़ पा रहा तो बड़ा मुश्किल है.
अरे यार वो लेके दूसरा पैकेट कुछ है ये उनका लेके आजा.
फोटो से ही समझ जाओ बेटा.
हाँ. In fact, Sattu,
Sir.
I became a little confident once I started seeing that otosclerotic focus.
Yeah.
You can see the tick focus anterior to the incus also.
Yes, sir.
See it is between the two. I don't know if it is focused for you.
Yes, sir. We can see very well, appreciate what you are saying.
Yeah. So I didn't get that much worried after that. Sometimes there's only a small ledge which is holding there. That is when I miss my laser.
Right.
I'll centralize the picture. Anyway, Stapes is one surgery. Enjoy it even without audience also. It keeps you alert always.
Always alert, yes.
I honestly feel it's a little more difficult than a cochlear implantation.
Definitely,
Because
sir.
cochlear implant, once you get used to,
It becomes easy. Stapes is always, whenever you do.
Adella piston alva. Huh? Okay. Oh, Satu seems to have a whole lot of torps. We can smuggle some and take it.
I think he has opened up a wrong box.
Box देखो, दूसरा box देखो. बेटा, wrong box उठाया है तो. Anyway, we will have got a gyrus piston. I'll use it, Satu. No problem.
Okay. I will replace, sir.
Ayo, don't worry. You have replaced so many things in my life. What is a piston? What is a piston?
Chocolate.
And I honestly tell you, don't worry about the audience in the hall because it is on the YouTube, which means a lot of people Sunday evening also with a cup of coffee in their hand.
Yeah, they are watching.
Learn a little, without straining themselves.
Yes.
Yes.
But we have luxury of having all these on the big screen.
Yes.
And friend around interacting with you.
Another thing what I have seen, Sattu,
Yes, sir.
ये हैंडल घूमता है क्या? ये हैंडल तिरगलाला? one निमिष.
Yes, sir. You are telling something.
15 knife, yeah.
You are taking some tissue.
No tissue. I'm just cutting the piston to 4.5.
Okay. So show us your slot measuring gauge. It's also from which company? Tell us.
Yes.
External camera people. It's a Medtronics.
Zomed.
Very good.
Yeah. This will last you for a lifetime. Even the measuring rod, so better buy the best quality.
So how much it is costing?
I think that time I paid 38,000 or something, I think, for this.
That time is how many years before?
12 years back or...
Oh my God, it will cross 2 lakhs now.
No, I don't think.
कम नहीं होगा सर, लेकिन ज्यादा नहीं होगा. इंपोर्ट कॉस्ट जीएसटी वो सब नहीं था ना, 15,000 तो जीएसटी हो जाता है. At that time in 1 lakh now, not 1 lakh.
Only problem, Sattu.
Yeah.
The external, no, the handle.
Handle?
On the right side, the console and the handle, the space is a little less.
I will tell them.
Put your, yeah.
Because handle, can you move that handle up and down?
That's what I'm trying to see. I don't think there's any contraption to move the handle up and down.
Okay, I will
See, I have
call.
to put my hand like this. See, otherwise I have to put it like this.
Okay.
Yeah, straight pick. That handle, they have to do something.
Okay, I will understand the problem, then I will talk to them.
Yes.
Because if Deepak is saying something, it has to be addressed. Because he is the most accommodative person I have ever seen. You give him whatever to him, he will do. Even he is ready to operate offline. If cases are there, he said, no problem. The transmission time is out, I will operate offline.
Yeah.
With the same vigor.
Yes. Number 2 instrument.
Okay. Please now focus there, sir. I think
Yes.
piston is already in place.
No. Piston is not in place.
Not in place? Okay.
No. With a fish hook.
Now it has gone.
Now it has gone in.
But I think you have to. Now it has gone in.
Can you see that?
Yes, sir. Please focus, sir, there.
Yeah. 1 minute. I'll go to higher magnification.
Yes. Now we can see that piston is in the fenestra and it is crammed over. Already gripping the.
No, wait. I'll do a little bit of suction. I'm happy with the length also.
Yes.
Seems to be perfect.
You don't do that bending and hanging test? No need, you are satisfied.
Any test once I put it there, unless I'm in doubt. Once the vestibule is open, I'm very, very conservative.
Now we can see that it is there inside.
Yeah.
It's a 4.5. Seems to be the.
Yeah. Yeah, it's sitting well, moving well. Maybe I'll crimp it just a little bit. Okay? Satu, I am very
Yes,
happy.
yes. I am also happy. There is a applause for you from our
Yes.
senior ENT colleague.
Yes.
So you will put some tissue around it.
I may put a small piece of gel foam.
Okay. Hello.
Yes.
Delegate is asking, you never use vein graft over the fenestra because
I've clipped it.
yeah, you have trimmed
It's
it.
done. Smooth cut pick. Atha number 2 instrument. No, I don't.
You
I used
don't
to
use.
cut tissue pieces. I used to cut tissue pieces by non-touch technique taught to me by Dr. Madhavaya. You
And
know,
put
where
around
you take the fat and put small pieces around the
fenestra, piston around the piston.
After seeing Satish Jain, I changed to putting a small piece of gel foam,
That's all.
allowing the blood to trickle. Yeah. Small piece of gel foam.
Yeah.
So this I just soak it in blood
Yeah, same.
and you know,
Putting there.
yes. Thanks for everyone who stayed back.
No, there is a big applause for you.
Yeah.
You can hear. Nice demonstration. Dr. Deepak Haldipur.
Yes.
We enjoyed and so what is your dressing protocol? You take the temporal flap back, then put a gel foam
I
there.
like to put the corda here, Satu.
Oh, so that it cannot.
Because 24 hours later, when the patient gets up,
Yeah.
the incus is going to become vertical and piston is going to become horizontal. So this corda
will take care.
I will show you in the higher magnification.
Yes, we can appreciate, sir.
This corda can prevent the slippage of the piston. Okay?
Sir.
Yeah. That's it. Now I think I'll just try to take out that single cotton ball which was there. 20 section or 18 section kodu. Thanks for moderating very well. Hello.
Yes, sir.
Especially for asking non-stop questions when I was putting the perforator on the foot plate. But then dosti to hoti hai na, I can't complain. See, even if you elevate the flap very wide, how quickly it sits in place.
Yes.
Let me go to lower magnification and show you.
It is almost, very well settled flap.
Smooth stroke, it settles in place. And like what both of our Mahaguru Kirtane sir does, you need to just place one piece of gel foam.
One piece of gel foam, that's all.
That's all, that's all is what is required. So
thank you very much, Dr. Deepak Haldipur. If any questions are there, I'm asking delegate because it's already 7 o'clock. It's a long day today.
This must have been one of the noisiest moderations of Stapes.
Thank you, sir.
And see, this is a self-retaining speculum of Dr. Madhavaya.
Yes.
Yeah. Okay.
Yes, sir.
Yeah. There is no day in my life that I don't spend the day without taking Satish Jain and Madhavaya's name once.
So it's like an ardent student. I mean,
every day in some context or the other, Madhavaya sir's name comes into my mouth.
Yes.
So also Satish Jain.
Both are great teachers.
The man who taught me by giving his patients to me to operate and learn. So till the last breath of my life, I will be grateful to Satish Jain.
Thank you, sir.
Thank you very much.
Okay, sir. Now we will.
Yeah.
चेयरमैन साहब लोग कहाँ गए?
Yes.
Who is the chairperson for?
बेचारे भाग गए.
No, they are here only.
Plaster.
Hello.
Yes.
I'll request Dr. S.P. Dubey sir to felicitate the chairpersons, Dr. Ruchir Vashne sir.
Plaster. Nagpur. Bhatti sahab. Thank you.
Dr. Bhagwat Chaudhary sir.
मेरा माइक निकल.
And Dr. Anupriya Hajela ma'am.
I think at the end, thank you very much for your presence, all the delegates. And at the end, I will thank all my consultant who were guest faculty who were there. And big thanks to Moxclave. Keskar is sitting behind. He has put in a lot of effort to invite all the people in all arrangements. Sometimes I become a little harder to him also. So thanks, Moxclave. Thank you very much. So we call it a day. Thank you very much. All right. Thank you, madam. And how are you? आइए हमारे इनका बात सुन लीजिए. जैन साहब कह रहे हैं कि आखिरी के लोग ग्रुप फोटो करा लें एक. आओ बेटा. जो कैसका साहब रख लो.
The back base is getting better and better every year. This is the best. Very good.
Sir, besides the background.